Progress.
A very good morning and welcome to all of you on the second day of ImmunoAllergy Conclave. I hope all of you thoroughly enjoyed yesterday's session dealing with the pros and cons of various allergic manifestations and immunology behind them. So, a brief overview of what all we'll be discussing today. So, towards the beginning and end, we have interactive case based discussions, and in between we shall be having 3 sessions dedicated towards history taking and diagnostics of allergic diseases, followed by the session on drug reactions and contact dermatitis, and last session on therapeutics in allergic diseases. So for the first case based discussion, I invite Dr. Puja Srivastava for chairing the session. She is consultant rheumatologist at Star Rheumatology Clinics, Ahmedabad. She did her MBBS from AIMS Delhi, MD Medicine from PGI Chandigarh, and DM from SGPGI Lucknow. Over to you, ma'am, for further discussion.
Thank you. So in this case-based session, we have 3 cases. The aim to keep these 3 cases are to explore the entire spectrum of urticaria. So it is up to you to ask all your questions and doubts. A case generally stimulates us to ask more questions. So we'll start our first case. Dr. Sandeep will present. We have among faculty members Dr. Pravin, Hissaria, sir, Dr. Dr. Rajendra is also has also joined in online. So we have all the experts from across the globe to answer our queries.
Good morning all, respected teachers, my dear seniors. Welcome to the second day of our Immunoallergy Conclave 2024. I will be presenting a case, the first case. My patient is a 29-year-old female. She is mother of 2 children. Her illness starts at the age of 18 years. So she had recurrent episodes of swelling of her face, lips and eyelids. And these episodes were acute onset, which were unprovoked, which were moderately painful swellings, which progressed to involve all the above areas over a period of over around 3 hours, and it lasted for 3 to 5 days, and it subsides spontaneously. And she used to have 4 to 5 episodes in every 3 months, but she did not have any history of any hospital admissions for these illnesses. There was no history of any itching, skin rashes, breathlessness or stridor, pain abdomen, diarrhea, syncopal attacks, loss of consciousness, fever or weight loss. So this is her clinical photograph, which shows marked swelling of her eyelids. In the first picture, in the upper part of the face is also swollen, and in the second picture we can see there is marked swelling of her lip. So for the above complaint, she was initially treated with steroids and antihistaminics, but with very minimal response. For the past 2 years, she almost had no effect on this with steroids or antihistaminics. She was born out of a non-consanguineous marriage, and she had her family history shows multiple family members have recurrent episodes of this angioedema. So we can see the first, our patient is the first, this is our proband, and her father, her two paternal uncles, paternal auntie, her grandfather, and all the kids of her paternal auntie are having similar kind of illness. When she came to us, she came with this typical history, and on examination she was conscious, oriented, her vitals were normal, general examination and systemic examinations were also normal. Her investigations shows a normal hemogram, liver functions, urine routine examinations, and inflammatory markers are also within normal limits. Her ANA was 1+ core speckle pattern. Her complements C3 was normal, but her C4 was 5.28. That was low, with a normal range of 15 to 20 milligram per deciliter. To summarize the case, she is a young female with recurrent episodes of angioedema, with a positive family history involving 3 generations with low C4. So we kept the probable diagnosis as hereditary angioedema. So we sent a C1 esterase inhibitor level that came to be 128, which is low for the normal range. So we initiated her on danazol 15 milligram per day, and we gradually increased to 100 milligram per day. In between, she had mild transaminitis, which improved once her dose was decreased from increased. It was resolved once the dose was de-escalated from 100 to 50, and after that, on a follow-up period of 1.5 years, she did not have any more episodes of angioedema, and currently under 100 milligram per day danazol. So after this case,
Do we have any questions regarding this case from the even online attendees can send us some questions, we'll address your questions. Pravin.
One question is, what is the utility of getting an ANA done here, and when would you recommend doing an ANA when we have such a strong family history, clearly stating probably it's going to be HAE? And second is, what is the goal of the therapy? Just like patients would ask us, how long should we give? So is there a guideline to it? How to go about it?
we are having these questions will be we are actually
To the panelists, don't worry.
So the goals of treatment,
All right.
like how should we counsel these patients? How their life is going to be in long term?
Yeah, so
How should they move about with this
Yeah.
diagnosis and the future prognosis?
Yep. So few standout points actually. First, obviously, this is not a diagnostic dilemma, right? The question is more of one of a management issue rather than diagnosis, which is straightforward. But one thing that should be a standout feature, which is in most of the cases, this is obviously not a made-up case, I'm sure we've seen this, is the penetrance. So when you talk about autosomal dominance, you say 25% risk, right, to siblings. That's what we all have read and understood. Did you see the penetrance there? It's like 80%, right? And the reason is that there is a dominant negative effect of the C1 inhibitor mutation. Dominant negative, I'm sure you guys know more genetics than we did. We actually started reading it after we became consultants. Is that the abnormal C1 inhibitor protein, which is mutated and produced, actually causes inhibition of the other one, which is normal gene as well. So the normal gene also has less production of the effect. And that's the reason why there is such a high degree of penetrance, despite it being an autosomal dominant, right? It does not actually believe in the statistical values that we all learn. So that's one standout case, that if you have such a strong family history with such high penetrance, it is most likely a hereditary angioedema. The management goals, actually, it is difficult. If one-liner would be lifelong. Obviously, nothing is lifelong. If you say that in the first instance to the patient, he's going to run away to your next immunologist, who might not be your friend. So the best way to tell is that you give it for about at least 2 years. And the history is very important. Now that you know the diagnosis, it can be managed, right? And now we have C1 inhibitor available. So you give it at least for 2 years. If there is no episodes whatsoever, you could actually try to stop it or reduce it to a minimal doses. Now, if the tolerance is so good after 2 years, most likely you would not stop it, but because she is quite young, right, 32 and danazol and a female, you would possibly want to stop it after 2 years. Because these are very episodic. As we know with most of the things that we encounter in autoimmunity as well, that these are all stochastic events. Like there is these periods when you have very bad lupus, very bad scleroderma, you get over it, then they do very well for the next 5 years of their life. But I think 2 years is sort of the standard goal, that you would tell them that, look, if you've not had any episodes, we might try to stop it and see how you go. So it is on an individual case-by-case basis. But academically, lifelong, like there is no other things. And the other thing that to always tell these patients, which we do actually there as well, although we have all the treatment modalities available, is that, look, there might be something coming in the pipeline. Like I don't know how many you have read, that there is CRISPR-Cas9, exactly. You know, the NEJM publication about a month ago. CRISPR-Cas9 has come in, right? So there is a gene editing whereby you can actually silence that mutation that you are actually seeing by editing it on a CRISPR, which means that the best thing to say in modern day practice now is that the way the science is progressing, you actually might have a cure to it. So let's not even talk about lifelong for now. It might be in 2 years, you might have something that will actually fix your problem. And with at least genetic problems, as we all know, with, there's siRNAs. So there are 3 trials currently on for the treatment of these conditions. So there is CRISPR-Cas9, which got published in NEJM. There is a small siRNA molecule, which actually silences the mutation. And obviously, there is gene therapy going on as well, right? Gene therapy, as you know, with the experience with sickle cell got stopped. So that's what I would counsel this patient for.
And along with that, giving hope, should we tell them, should we explain them a little bit about the disease and explain them how they can manage on demand if they're undergoing a short-term surgery or a procedure which can precipitate an attack, or for the period when they are getting recurrent episodes, maybe like you said, for 3 months, 6 months, we can give them
Absolutely, absolutely. So if you're not planning on a short or a long-term prophylactic treatment, you would definitely counsel them about the on-demand therapies, right?
There's an online question. How long can danazol be given?
So we have patients on it for 25 years. I'm a big believer of that drug. Yeah. I think it just did not have any sexy pharmaceutical to back it up, and that's why it has lost its charm. It definitely works. And as I said yesterday, all you need to do is just monitor the liver functions and alpha-fetoprotein maybe once a year. Ultrasounds, they are quite cheap now. You could possibly get it done every 2 years, because hepatoma is possibly the only major side effect that you worry about in long term. So it can be given. We've given it for about 20. We have a whole generation for family, which is everyone is on danazol. We've tried to put them on clinical trials of all these new agents coming in and everything. They just don't want to stop.
Could we, in this population, once we have diagnosed it as bradykinin-mediated angioedema, we should avoid antihistaminics and steroids in this population?
Oh yeah. That what you put was perfect. Yeah. There's no role of it. No experience. No.
What would be the maximum dose of danazol that you can go, and how would you choose between danazol and tranexamic acid?
How do you choose between methotrexate and leflunomide for arthritis? It is how you feel on that day. I think, honestly enough, I think my first go-to drug would be danazol. It makes good sense that it increases the amount of the protein liver synthesis. Textbooks would say a very high dose of danazol is required, as you rightly said, 400 milligrams. Normally, you can maintain them on very low dose. And this case would reflect what we see in practice as well. Maybe not as low as 50.
More like methotrexate, as the episodes come down gradually, we can taper to a minimum possible dosage.
So maybe not as low as 50, but yeah, 100 is what we've seen works. The other thing, as you were asking, Avinash, about follow-up as to whether you actually measure the C4 levels and C1 inhibitor and tailor or taper your therapy based upon those levels, there's not much of evidence there. C4, most of the cases, never comes back to normal. You can do what you want to do, right? So you're possibly measuring C1 inhibitor levels. One other oddity about this case was the level of C1 inhibitor, right? It is usually less than 30% of your normal value. So if you had that level, although this case was like had classical features, so you would doubt. But let's say if you didn't have family history and if you were thinking, this is the index proband who started to develop this mutation and is now in trouble, if you got that C1 inhibitor level, which is about 70% of normal, you would repeat it, right? Because normally you will get the angioedema episodes for very earlier publications from Italian groups would say that you actually try to keep it to about more than 50%. And that's all. As you know, in human body, everything 50% is good enough because we have been given double of everything. So that's what you would keep. So if you are at that level at diagnosis without that family history, that classical, all presentations, you would possibly repeat your C1 inhibitor levels and try to get a functional if you are possible.
So regarding functional studies, I think what best we have in India at present is Dr. Lal's lab is doing a test where they collect samples from across India the whole month and they send it to some lab in US. And then we get the result in around 3-4 weeks. The transit time is around 3-4 days. So the cost is
So,
those kind of functional studies
so
should be considered in type 2 HAEs?
that's a good question, and I'll let Ankur actually dial in as well about his experience with how it is done here. The way we do it, it's an ELISA-based test, by the way. So you incubate it. It's not rocket science, and it is not FEIA. It is a simple ELISA that you can set up in your lab. The only thing is about the transport, as it is with all complement proteins, right? So you have to have, transport it on dry ice and keep it cold and everything, so that there is no complement activation happening in vitro whilst during the transportation mechanisms, right? But it is an ELISA-based test. So you have a stimulant. They don't tell you actually what they use to stimulate it when they measure the C1 inhibitor functional levels, because I think that's a proprietary thing. But it's not very costly. It's just an ELISA. You just need an ELISA meter. So you incubate it for about half an hour, I think, and then there is a couple of stopping steps, whereby, as you do with every ELISA, you stop the reaction from happening, and then you just read the OD. And that tells you the functional levels. So it's not rocket science. It's easily available. And I think the economy might be because of the scale of the test, as you can imagine. So if you are only running one or two tests, you have to run one positive control, one negative control, and one titer control. So you can imagine, that adds up to the cost. So if there was only one lab doing it, which sort of, I don't know, PGH Chandigarh could do it, is if you become center of excellence, it is not rocket science by any means. It's a very simple test which needs very simple lab instruments to do it. I'll let Ankur talk about that as well, as to whether they have looked at.
Any inputs from Dr. Ankur?
Good morning, ma'am. Can you hear me?
Yeah, we can hear you.
Okay. So good morning, everyone. And nice case. And I agree with the comments given by Dr. Pravin, sir. So how do we counsel these patients? We always tell them that, look, this is not something that we are, looking at a permanent cure as of now. Although in our counseling, we always talk about, the upcoming therapies, that may potentially be the future in next few years. But once a prophylaxis is started in these patients, it is very, very difficult to actually stop prophylaxis in these patients. So when do we actually think of stopping the prophylaxis is when their attacks they're absolutely attack-free or very minimal attacks for at least 6 months to 1 year, and they have good on-demand treatment available at home or a nearby healthcare facility. I think that is something that we use as a criteria to think of stopping on long-term prophylactic treatment in these patients. In terms of tranexamic acid and danazole or stanozolol for that matter, I think we decide based on certain factors. If it's a young child, we always think of initiating tranexamic acid first, and then if the child is not improving, then we think of initiating androgens. Young female, especially female of this age as well, I think they have a lot of menstrual issues when you start them on androgens. Not that we cannot start, but our first choice is tranexamic acid. Now, having said that, tranexamic acid doesn't work very well. About 70 to 80% patient will experience angioedema attacks even when they are on good dose of tranexamic acid, and we end up initiating androgens in those patients. But about 20 to 30% of our patients, in our experience, do just well on tranexamic acid alone. In terms of C1 inhibitor function, we used to do this test in PGI 4 or 5 years ago. We've stopped doing it for some reason, but we'll get this kit very soon again, and we'll start doing it again this year. Now, as you said, ma'am, that the cost of doing C1 inhibitor function is at least 10,000 in commercial labs. So in that cost, and in fact, even lesser than that cost, you can get the genetic testing done in these patients in India, that. So we feel that C1 inhibitor function in our setup is not an extremely good test. If you just do C4 levels, if you just do C1 inhibitor levels, you can definitely diagnose type 1. For type 2, we have published this experience that C1 inhibitor level in these patients is actually not normal. It is actually high. So if you have a patient with low C4, if you have a patient with C1 inhibitor levels which are high, then your diagnosis of type 2 HAE is nearly confirmed in those patients. You don't really need to do C1 inhibitor function to prove that. And in the coast in which we can actually do C1 inhibitor function in India, you can actually get the genetic testing done in these patients. And there is absolutely no role of monitoring these levels on follow-up. And there was a question on biomarkers. So as of now, we don't have any biomarkers to predict when are these patients going to actually develop an angioedema attack.
Dr. Ankur, we would also like to hear about your experience of using plasma-derived C1 esterase
Yes,
because they are
ma'am.
now available.
Yes. So, ma'am, I think I would say about 50 to 60% of the patients who are using plasma-derived. So, first of all, it works wonder. It works very, very well as compared to fresh frozen plasma. So, we looked at how fresh frozen plasma and C1 inhibitor, in terms of logistics. So, if you have to think of using fresh frozen plasma in a patient, the logistics would say that it may take about 8 to 10 hours before a patient decides to get fresh frozen plasma and goes to the emergency and actually gets a fresh frozen plasma. While in case of C1 inhibitor, now what we do is we ask them to keep at least one injection at home. They go to a nearby healthcare facility, or some of them can actually inject it at home. They decide to take injection, and the interval between deciding taking the injection and actual administration of injection can be as less as 30 minutes, and it works very well in these patients. Now, about 50 to 60% of the patients are still paying it from their pocket. About 50% of the patients have actually started accessing this injection through the rare disease policy of Government of India, and we have about 10 patients who are in follow-up in PJ who have started getting C1 inhibitor injection now through the Government of India's rare disease policy. So yes, and some of these patients are actually getting it through insurance as well. So the pickup rate for C1 inhibitor injection is actually increasing for on demand, and it works very well. Yeah.
Thank you.
Thank you, ma'am.
Thank you. That was great. So, do we have anything or do we move to second case? Yeah, that's last question, Puja.
There is a high index of suspicion for HAE where we do a C1 esterase inhibitor levels and they turn out as normal, and then we need to repeat it. Any technical issues or anything else that can bias the report?
So there are now 6 more mutations. If it is normal, then possibly C1 inhibitor is not the cause. So there are 2, as Ankur said in his talk yesterday, there are at least 6 more mutations described now. So factor 12 activating mutations are there, which can actually be picked up on a coagulation testing as well. They are activating mutations though, so the time gets reduced, the clotting time with the direct contact pathway. There is kallikrein inhibitor, I think, KI gene, which is found mutations in that. I think sclerostin is another one. So there are about 5 other mutations. So if that's the case, I don't know how much it costs here, but there is a panel available now. Is Invitae has opened Indian branch? I think last time they were talking about, I think they were going to go. So there are panels available which will do all the 6 genes that we know of currently that gets tested. Possibly if the level is normal, I don't think there will be any issues. I wouldn't think repeating it. I would look for those other genetic causes. And then there is this whole bag now that there is more awareness of this condition of, type 3, as you were saying, which is not type 3. It's hereditary angioedema with normal C1 inhibitor, as they call it. And that still remains in the research arena. On-demand therapy still works in those conditions. So you would be talking about tranexamic acid use. Icatibant, as I was telling yesterday, actually icatibant in most of the parts of the world is actually supplied by Cipla. But Cipla don't have license to actually distribute that particular drug in India because there were some DCGI issues and everything. But Cipla supplies the icatibant to what we use in Australia. And I think that will be the best on-demand therapy because that works wonders. Again, the timing is important, as was mentioned yesterday, in terms of when you start taking it, which should be ideally within 5 hours. But yeah, so there is this whole bag, but I wouldn't repeat it.
Thank you. So I think we discussed angioedema, now it's turn for urticaria. We move on to our second case. Thank you, Dr. Sandri. We invite Dr. Swapnil to present our second case.
Very good morning, all of you. Welcome to ImmunoAllergy Conclave 2024. Myself, Dr. Swapnil, SR in the Department of Clinical Immunology at GPGI. I'll be presenting a case of I'll be presenting a case of 33-year-old female, nursing officer from Lucknow. She had 4 episodes of allergic manifestations. During the first 2 episodes, she had generalized pruritic erythematous rash involving her face, limbs, and trunks. As we can see in the images following in the slides, she had this erythematous pruritic rash over her arms and over her trunk. These rashes were lasting for less than 24 hours. She had no history of any fever, pain in abdomen, or respiratory distress during this episode. And she had no any past history of any known allergies to food or drugs. And she was treated with antihistaminic and dexamethasone at her local place. And her symptoms resolved. Next, after 3 days, she has developed a similar urticarial lesion, but this time with swelling of face, lip, and along with she had also stridor. She was treated with IV hydrocortisone and phenyramine maleate, and she was started on oral prednisolone of 20 milligram once a day and fexofenadine 120 milligram once a day. During this treatment, after around 4 days, she had similar urticarial lesion, but this time with breathlessness and hypotension. Then she was undergone IP admission, and she was treated with IM adrenaline, and her steroids and antihistaminics were continued. Notably, in past history, she had tubercular osteomyelitis in 2019, for which she took anti-tubercular therapy. And her in family history, her mother is a known case of aplastic anemia on treatment. She had no family history of any allergy or angioedema. When she came to us, after these 4 episodes, she was actually referred to our department. When she came to us, her general physical examination was normal, except she had few residual urticarial lesions over bilateral arms and over trunk, and other systemic examination was normal. She was investigated, and her investigation showed normal complete blood count, absolute eosinophil count was also normal, slightly raised CRP. Her serum IgE, liver and renal function tests were normal, and in immunological workup, her ANA was negative and normal C3, C4 levels. We went ahead with C1 esterase inhibitor levels that were came to normal, and again went to for after this came normal. Then we had whole exome sequencing that we have not found any pathogenic mutation in this case. So we had this 33-year-old female with history of recurrent urticaria, that 4 episodes, along with one episode of angioedema and 1 episode of anaphylaxis. So we have started her on danazole 50 milligram BD, and her oral steroids were tapered and stopped, and her antihistaminics were continued on SOS basis. So in follow-up, in last 7 months, I think she had no episodes of further urticaria or angioedema. She's stable on the dose, no side effects of danazole as of now on investigations. So,
overall, this is a 33-year-old lady who presented with 4 episodes of severe urticaria, angioedema, and anaphylaxis. All happened in the month of June. So less than 4 weeks duration. So more of a acute urticaria, a very severe one. So what else should we ask in history? Like any triggers or something? Yes.
So we had a whole talk on terminology that was taken yesterday, and this is a classical example of why terminology is so important, right? Because that is what helps you decide. You have to have a working diagnosis which then helps you decide the framework of the treatment. So this is, as Puja rightly said, a case of recurrent acute urticaria, and angioedema fits in with that. She did not have other features of anaphylaxis, possibly, because I think she did not have bronchospasm, it was only stridor. So, but still one severe organ involvement and episodic. So this is more likely fitting into spectrum of anaphylaxis, recurrent anaphylaxis, rather than definitely not chronic urticaria, as Puja said, recurrent acute episodes of either isolated urticaria or possibly fitting into the spectrum of anaphylaxis. The one most useful test when you get recurrent episodic event here is tryptase. So when she presented into that ED and when you gave dexamethasone and everything, I would have done a tryptase there. That's the beauty of that test. Initially, anaphylaxis was always a clinical diagnosis before 10 years. Now, tryptase actually tells you. So if you did hear a tryptase level between 1 and 4 hours after the onset, and you found it high, well, that's it. That's the clincher, right? And then you just do a follow-up as a baseline level. 24 hours later, it is low, and now you have the favorite thing, mast cell activation syndrome, right? Now, how do you go about an idiopathic mast cell activation syndrome with no obvious triggers? I'm assuming you didn't find a pattern with any of those 4 episodes. So the normal patterns that you ask for is 5 things, right? You ask for drugs, you ask for time of the day, right? You ask for any insect stings, you ask for any abnormal foods, anything new that would have happened, right? And whether they had any concurrent infection. So still till date, the most common cause of acute urticaria still remains a viral infection, okay? So that's still the most common reason why acute urticaria happens. As with most of the other viral infections, 90% of times you can't actually find the virus, right? So if it subsides on its own, it's okay. One thing I would definitely not do is start danazol on it.
So,
I'm a big believer of danazol, but not here.
Close, like online people are not.
Oh, sorry. I thought I spoke very loud anyway, so that's why I was trying to behave myself. One thing I would have definitely not done is start danazol, I think, because that's definitely not angioedema, right? Yeah. And the other thing, as I said, I would look for, if you went to the extent of doing whole exome sequencing, is c-KIT. Whether she had c-KIT mutation or not.
Yeah.
That is what I would be looking for. And with whole exome, for mast cells, yes. And the one thing about whole exome sequencing, you have to realize, although we think that it is very robust, the technology is very robust, okay? But the diagnostic reporting is not. You still get the answers for which you put the right question. We all think of it as this big black box whereby you do whole exome, it will magically spit out results. That is not how it works. You can almost be sure that if you have a whole exome sequencing report in your hand, which does not have 2 VUS in it, means that whoever was your IT person analyzing the data was not good. There is no way, as I keep saying, whole exome sequencing, I was talking to Sunil sir last night, it is throwing more questions than answers, by the way. If you don't get a VUS on a whole exome sequencing reports, means the IT person who was looking or curating the data has not looked at it properly. So if your whole exome sequencing is normal, you need to specifically ask them that question, that did you actually look for c-KIT mutation or not? Because you can imagine, 200 terabytes of data. It's very easy to miss. So you have to get VUS. So this is a standing joke which I take in our rounds. First thing we ask when someone says he's already had the exome done is, how many VUSs? If it is 0, nah. You need to take that data to somewhere else. And now, as you know, there are lots of online platforms which will analyze just your data for you. You don't even need to send them your buccal swab or your hair sample or blood or anything. You can just send them the data and they'll curate it for you. Because that's the most important bit. As to who is analyzing the data, to what depth the reading is being done, and what they are looking for, and what they are matching against. So that's one thing I would definitely do. And in terms of the questions, so now coming to the mast cell activation syndrome where you don't find any obvious triggers, what do you look for? So the one thing which is coming on very big wave with the advent of all these newer things is what we call cofactors. And the 3 most important cofactors are non-steroidal anti-inflammatories. So people don't actually come out of it very readily because they think of it as an OTC product, safe, they will just talk about it. It doesn't matter. The second thing is exercise. So you would ask them whether they were doing anything physical on that day, exertion and everything. And the third thing, I think, which is, although it is no more less relevant here, but I think it is becoming relevant, is alcohol. So you have all these idiopathic anaphylaxis turning up into emergency departments on a Friday or a Saturday night, which is very common. And this is no joke, by the way. So alcohol, non-steroidals, including aspirin, obviously, and exercise. And if you find any of those cofactors, then it is still a cofactor, right? Then you go harder looking for the triggering events, which might be some things that you were exposed to in a routine manner, but they did not have any mast cell activation event in absence of those cofactors. And that is wheat, which is the most common one, right? Rice in some cases, and seafood. Now, obviously, seafood is less relevant again here, but the diets are becoming more or less similar in Western and in our parts of the world, right? So those are the things that you would look for. And lastly, what I have not seen here, and I'm sure it is not because it doesn't happen, it is because we never thought about it, is the tick bite allergy, right? So alpha-gal allergy, as you know, I'm forgetting the name of the celebrity who recently had it and it got so much of. So that's so tick bites, the normal ticks that move around, and I'm not sure of the endemicity of ticks in India, to be honest. They are, yeah.
Alpha-gal allergy is very specific, like the bite has happened a long ago.
Exactly, to travel.
A non-veg diet
And then that non-veg is expanding. That's happening with beauty products because alpha-gal is present in lots of things, right? So those are the things. Those are the diagnostic clues. And that's why the practice of allergy is so good. You almost feel like a detective, and we all loved our novels, right? And it is excellent to crack a case, right? But these are the things that you need to look for. In cases of idiopathic mast cell activation syndromes, where there is no obvious trigger.
So I think the learning point from this case is in cases of acute urticaria, which are little unusual than very severe acute urticarias who present to emergency departments. Maybe mast cell activation syndrome is one thing we should think of if we don't have a well-defined, definite trigger present, like a drug infusion or a bite or these things. So I think with this we move to our third case.
Thank you.
I invite, thank you, Dr. Sapil. I invite Dr. Rajendra to discuss third case. This would cover the missing spectrum of urticaria angioedema.
Good morning, everyone. I'm presenting the third case for today. We encountered a 63-year-old gentleman. He's a bank manager. He's a resident of Guntur from Andhra. He's a known diabetic for the past 20 years, well controlled on oral hypoglycemic agents. Okay. He's also a known hypothyroid and diagnosed with dyslipidemia. For these comorbidities, he was initially on metformin, glimepiride, atorvastatin, and thyroxine, and was maintaining a fairly good euglycemic state as well as a euthyroid state. This gentleman came to us with recurrent episodes of episodic spontaneous urticaria, the initial one which started in 2009, followed by episodes in 2017 and 2023. These episodes had no specific identifiable triggers. They used to last from 12 to 20 hours in duration and presented as generalized hives, which used to involve the entire body, involving even the face, palms, and soles as well. There were no accompanying dysesthesias or any residual pigmentation. These lesions used to heal by themselves by 20 hours initially, then used to last for more, and they left no residual hyperpigmentation or scarring. It was often accompanied by episodic subcutaneous edema. However, there were no laryngeal edema or abdominal pain or any features of anaphylaxis. So the gentleman has been kind enough to share some of his photos with us. So these were some of the lesions that he developed over the forearms, over the face, as well as some of them had some subcutaneous edema as well. So this was the first episode in 2009, that is at the age of 49. He had a first episode of generalized urticaria, but at that time he had a history of concomitant aspirin intake, even though aspirin was going on for some time, almost 4 to 5 years prior to the first episode. He also gave a history of intake of one tablet of NSAID for an episode of headache, so that was identified as a possible trigger for this episode. This was treated with fexofenadine, oral steroids, Medrol with a serial taper, 1 dose of IM depot Medrol, and he was also added on hydroxychloroquine for this episode. It lasted for a span of around 1 month, where he continued to have possible multiple episodes, and it subsided after that. He remained asymptomatic for the next few years until 2017, when he had the second episode. This time there was no identifiable trigger, and the episodes lasted as multiple spans over a span of 1 month. Again, he was treated with oral steroids and IM depot Medrol single dose, and it was tapered over a span of 2 months. He was doing well after that, and again he remained asymptomatic for the next 6 years. And the next episode was in August of 2023, after which he's been continuing to have recurrent episodes of urticaria. This time, the patient reports that he feels that these symptoms are increased by excessive sweating or by excessive heat.
but there is no history of any increase in symptoms after taking hot showers. This time, the patient has been started on fexofenadine initially with a dose titrated up to 720 milligrams per day. He was added on Montelukast 10 mg, again without any symptomatic relief. The antihistamines were changed to desloratadine followed by hydroxyzine. At a dose of 25 mg TDS, currently he has some relief even though the symptoms are still ongoing, onto which an H2 blocker has been added as famotidine 20 mg, a twice daily dose. So he had these symptoms had no association with any physical activity as per the patient, no seasonal variation or any clear association with an episode of food intake. He has no accompanying constitutional symptoms like a loss of weight or a loss of appetite. He has no other skin lesions or any features to suggest an underlying autoimmune disorder like an edema, frothy urine, hematuria, any features of vasculitis like hemoptysis, epistaxis, sinusitis, numbness, paresthesias, or hearing loss. There is no history of any other family relative who is going through any other similar illness. On routine evaluation, he was found to have a normal CBC with a normal counts of 6,400, normal differentials, only a 1% eosinophil count, an absolute eosinophil count of 64. His inflammatory markers were within normal limits with a normal serum IgE of 97. His liver and renal parameters were within normal limits. Urine showed no active sediments, no proteinuria. An ANA was advised by a physician outside, which showed a 1+ nuclear speckle pattern with a normal dsDNA level of 43. His ENA and ANCA also came out to be normal with normal complements levels as well. So currently this gentleman is on hydroxyzine 25 mg TDS and famotidine 20 mg BD. He continues to have symptoms once or twice per week, but he is having significant difficulty in taking these medications due to the excessive sedation. So this was a 63-year-old gentleman who had come to us with chronic spontaneous urticaria, with episodes which have spanned over a course of 15 years, and now they are increasing in frequency and intensity. No single trigger has been identified which could unify all the episodes. The first episode had a possible NSAID as a trigger, and the second episode he describes as having exacerbations with heat. There was a partial response to H1 and H2 blockers, but likely initially he had a suboptimal dosage which has been tried to be up-titrated. But on the current dosage that he is having some relief, he has significant side effects. So these are the questions that we felt we should be needing. So what else could have been asked in history or any other inputs would be welcome.
Travel history, because it's very localized. 2009,
Yes, 2017, yes, ma'am.
So recent travel.
He has not given any specific history of travel. We also asked regarding his residence. There's no history of any specific exposure to some single place. No. And initially he was living in Hyderabad, and he changed his residence. After that, he was moved to his village. But again, even after that, he's not having any significant improvement, nor has the symptoms changed in duration or intensity.
So maybe a classical case of chronic spontaneous urticaria with overlap of chronic inducible urticaria. So, which is going on off and on, and sometimes it resolves on its own also. So, how best to treat these patients? Yes, sir.
So, yeah. So these are the most common ones, absolutely. And we won't even go into further diagnostic workup of this case, right? It's been exhaustively done. We've not found anything obvious. 3 episodes, the first 2 possibly short-lasting, 1 month, you said, I think?
Yes.
And the third one obviously is more than few months, so at least, we have to label them something. So now you can at least label it as chronic spontaneous urticaria. So what do you do in a case of chronic spontaneous urticaria where you don't have good response with your usual first-line agents, right? The obvious thing, as was presented yesterday, I think would be omalizumab. But it's fine to think about all these fancy ones. As I keep saying, lots of these are driven by drug companies, trying to promote there, as you must have seen in the latest Gallen urticaria guidelines. But what else can we do? So what are some of the, for want of a better word, clinical pearls that you learn as you practice these cases, as was very well documented by Vikas sir in one of those B venom allergic patients who developed tubular necrosis and hypokalemic paralysis, is 3 or 4 things that we look for. One is H. pylori. So if you dig dig it enough in terms of the rarer causes of ongoing persistent chronic spontaneous urticaria not responding. So here now we are looking at triggers which are not very obvious, but what you could do in your armamentarium, right? So that's one. So if you would do a breath test, if not breath test, we do serology as well, to be honest. That's what I do in Ahmedabad. And if your serology is positive, I think it's not unreasonable to give them a 2-week course of the H. pylori eradication program. The second thing you would look for is there is something which is endogenous and ongoing, right? And that's where it comes in. You know, I loved your last slide, food for thought. There is food. Now, whether that food is because of the food itself, or whether it is due to the alteration of the microbiome, or if it is containing something chemicals in it which are triggering it, right? So there is a definite role for food. I know we'll hate naturopaths and we say, "Paanch cheezein band kar di," but everything is not science, as we know. There are lots of things which are apart from science as well. Like there is science that we don't know of, obviously. So what do? So there are elimination diets available. There are no well-conducted scientific, randomized things to tell us which diet is better and how long to pursue and which one to start with. But there are elimination diets available. Now, I'm not going to go into detail because that's a whole talk in itself as to what are these elimination diets. But the most of the common ones are low salicylate diets, right? Gluten-free diets, and gluten-free diets in absence of your classic celiac serology. I'm not even talking about those ones which have positive transglutaminase or your deamidated gliadin peptide positivity. Just gluten intolerant. So when something starts going that, and I have a theory about microbiome, as I keep telling for anyone who is going to write a research grant, I think microbiome is the answer. Everyone has the same serology, and why someone gets a very bad lupus and nephritis and someone gets a very bad rash and the other one just keeps getting pneumonitis. There has to be something that alters that, because, and not everyone behaves the same way to all treatments as well. Some people with 20 milligrams of steroids go mad, and some people sail through with 100 milligrams of steroids. So there's something that is second line after what we do that happens, and which has to be gut, right? So I am a fan of elimination diets in these type of people, right? Now, there are online things available, so I'm not going to go into detail about which elimination diets to do, but these are the 4 ones to think of. So there is what we call elimination diet. There's an RPA called Royal Prince Alfred, which is Australian contribution to this thing. And we keep jumping onto these biologics very soon. I think we should go to these things before, right? So elimination diet, I would go for a gluten, and these things, they only need about 6 weeks. So they are restrictive, but it only takes 6 weeks to be sure whether they are working or not, right? Low salicylate diet, and the 4th one, as I keep saying, is FODMAP diet. Now, people might say these are not scientific. Don't ask me for references, okay? This is just, I think, somewhere you have to believe in wisdom as well, because you have to do something. And these things sometimes work wonderful. And the curious young brain might say, but they might have gone into spontaneous remission anyway. That's fine. You did something that worked. If that was a stroke of luck, well, so be it, right? So those are the things that you look for in the. Now, there are other things like, if there is a physical inducible component, as it was, I think, sweating, you said. So cholinergic urticaria. So cholinergic urticaria, you could try non-steroidals, as they say. People have tried warfarin. So one thing that we do with all these refractory cases is to do dimer levels. And if there is evidence of some thromboembolic, and these are all crude markers. So don't ask me about high-grade scientific evidence, okay? If we are talking about level 5 evidence here, eminence-based practice. This is what you would do.
So there's an online question, how to treat cold and aquagenic urticaria?
Avoid it.
Allergen avoidance. Another question.
Well, sometimes the more important, actually, joke apart, the more important thing about those things is actually counsel them, because those people can die. So they can't go into a pool. They can't go on the beach. These people can die. So cold-induced and aquagenic, yeah. And then there are refractory cases, like even if they're getting with like minimal splashes of water or something, that's when you start using your anti-IgE, like I'm sure you have read case reports of omalizumab being used for those ones as well. But physical urticaria, the best is, if it is easily avoidable, just avoid it.
There's one more question. So, how would you like to know something differentiating between urticarial vasculitis, Centralus syndrome, and Sweet syndrome in a 65-year-old IgM, MGUS, IgM?
MGUS. Yeah.
Neuropathy with specific episodic rashes
So the first thing is biopsy, obviously. No-brainer, biopsy. Biopsy will tell you differential between all those three. That's simple. Because there is a monoclonal protein, obviously Schnitzer's would still remain, even if shows garden variety urticaria because of the monoclonal. And the thing about Schnitzer's is that it is an auto-inflammatory condition. So you'll get a very high CRP. You'll get a very high ESR. They will have a neutrophilic leukocytosis response, right? So those are the clues that you look for with Schnitzer's, because Schnitzer's is nothing. It is just urticaria with a monoclonal protein with an inflammatory. You mean Schnitzer's? We've had some success with colchicine. Is one thing that I tend to use in these conditions as well. Again, as I said, these are all rare conditions. There are not many clinical trials. But anakinra is not available here, so I guess we are not left with lots of choices. Antihistamines obviously don't work in Schnitzer's. So,
in these chronic spontaneous urticaria, how best we should use antihistamines and H2 blockers? I think that is the maximum. Many times we ourselves are not very convinced, and we are not able to convince the patients that these are not just symptom control. If you take it regularly over 2-3 months, sometimes the episode goes in remission and stays in remission for a good proportion of it, not all patients.
I tell them it is symptomatic treatment. And I said, we are waiting for that one magical day when you'll go into remission and this will go away. Be honest. If you are honest, patient will understand what you're saying. So you tell them for some reason your mast cells have become activated, and these are usually mast cells, by the way. Although we do all basophil testing, it is mast cell mediated event, right? And you tell them they've just got excited for some reason, whatever the initial insult was. They are very stubborn cells, so they take time to readjust. And they are not like your B and T, where you wipe them off and the new ones will be made from the bone marrow, and they possibly are re-educated now to become more tolerant. Right? So you just tell them honestly.
In chronic refractory ones, will there be some pointers in which patients to consider omalizumab and in which to consider cyclosporine?
Affordability is one. So if they can afford omalizumab, I'll go for it. The very good thing about these two, comorbid, both of these things can be used. And the good thing about it is cyclosporine is underused. And the cyclosporine is another classical example of not having a pharma backup so that it does not make it to the guidelines. I have a whole talk about how these guidelines are prepared and who sponsors for you to go to the highest mountain in Europe and sit there for 3 days among 15 other people drinking wine and making guidelines. Because there is someone paying for all of that. And that's why cyclosporine never makes it to the guidelines. They are not sponsoring it. It is, Novartis which is sponsoring it. So omalizumab you can give after 3 weeks of antihistamines. How stupid is that, right? We all see patients. Am I going to take it? Obviously not. So cyclosporine, and the good thing about cyclosporine is within 4 weeks you find out if it works or not. So as I keep saying, cyclosporine is not like an autoimmune condition here. So here you use it only for 4 and 6 weeks. If it doesn't work, you stop it. So it is a toxic drug. We all worry about it, and you look after their blood pressures and you monitor their creatinines and potassiums. But within 6 weeks you find out. And the longest, at least what academics would say in terms of studies that were done, which were a long time ago, was 6 months. And it is the only drug which causes remission out of its own. Even Xolair, we are giving it as symptomatic treatment. Then, till you wait for that spontaneous remission, yeah.
Pravin will ensure that Novartis doesn't pay for your flight ticket.
No, it has to, sir.
So, a couple of quick comments and 1 or 2 questions. Yeah.
Online, Dr. Mridula Desai is asking, any mast cell receptor stabilizer, any role of chromal and sodium?
Yeah, so the mast cell stabilizing agents are for conditions, this is my belief, where there is a mast cell overload. So they definitely work for mastocytosis. So indolent or systemic mastocytosis or SM in association with non-hematopoietic malignancies, it works.
A lot of biologics are coming up in this area, so
BTK.
BTK. And the other ones like IL-4, blocker, IL-5 blocker, IL-4.
The magical drug, as I was telling yesterday. So this is close to my heart, and I'll say it for younger people out here. And let me know in 5 years if my philosophy was right. Where rituximab is today for autoimmunity, it failed all the clinical trials, it never worked in everything, and we all use it all the time for everything, and we all have our wonderful success stories. The drug for mast cells is now BTK inhibitors. the BTK, yeah, ibrutinib and lanreotide, they work so well. So now they have found out that after the intracellular signaling pathways, after the Fc epsilon receptor engagement, is all tyrosine kinases, and mainly brutins. So as I keep telling you, we were all worried about rituximab, right? 10 years ago, we would think, shit, PML is going to happen, and hypogamma is going to happen, and we'll counsel patient to the death, because we were scared ourselves. And now, you just prescribe rituximab on an outpatient basis, and they just get it, and lots of patients do well. The same thing is going to be BTK inhibitors in 7 years for mast cell-mediated events. You can mark my word. So we have just submitted for publication, which we got rejected from NEJM. That was my third attempt at it. Is a BTK inhibitor actually controlling anaphylaxis 6 hours after taking a single dose of ibrutinib? This was exercise-induced anaphylaxis. So we could actually show, so we would get him onto the treadmill, gave it, for 5 days, no anaphylaxis, 3 days, no anaphylaxis, 1 day, no anaphylaxis, 4 hours, no anaphylaxis. So BTK pathway is the most important one if it is mediated by Fc epsilon receptor. So if it is through MGRX2, as Dr. Vikas was mentioning yesterday, possibly not. But if it is Fc epsilon receptor mediated, it is definitely Bruton's tyrosine kinase pathways. So we all need to start reading about ibrutinib, start talking to your hematological friends. And the other thing is, we worry about it, that it is going to cause A-gamma, right? Because we are used to XLA story, and we are used to that molecule being so important for your B-cell development, from the initial bone marrow stage, from the CLP stage. No. When you actually use it in a peripheral manner, not that way, it doesn't cause hypogamma to an extent. With TOFA, exactly.
But it didn't happen.
With TOFA, we have fear because orthopedic surgeons have started using it. I still like the drug. So yeah, to answer the question, Bruton's tyrosine kinase is and I'm a strong believer of the drug.
One last question, after that we end up this session. Dr. Avinash.
Yeah, so one comment, he also had episodes of cutaneous edema, right?
Yes.
Probably that's why you got compliments done.
Yes.
And we'll have to counsel him if in case he starts experiencing mucosal edema, we might have to treat that too. What was the utility of getting ANA and NCA done here?
This was done, advised outside by a physician, so
Okay, because I think that's an important message. There is no point
there was no
doing ANAs and
So that was an interesting discussion among physicists.
Varying the cost, sir, we're talking about the biologics in usage in these situations, and just sparing the cost away now, cost is also coming down. And I'm a pulmonologist, so we treat a lot of severe and therapy-resistant bronchial asthma with biologics. So if we spare the cost, what is there? What's the resistance in using newer biologics? If we compare the side effect and safety profile as compared to the strong potent immunosuppressions, cyclosporin, tacrolimus, etc., we have compared using long-term OCS for control of bronchial asthma and then switching over to a biologic. There is a remarkable and a miraculous difference in the quality of life. So, leaving away the cost and the pharma-driven this thing, what's the innate resistance in using a new biologics if it is so safe and so effective?
No resistance whatsoever. Anti-IL-5, anti-IgE, although they were very important for helminths, but I think we have actually improved our hygienic habits and we've become less cohabitants with them, which used to be the case, when in our ancestors. No whatsoever. If I had asthma, I would go for anti-IL-5. I would go for benralizumab. I wouldn't go for oral corticosteroids. So now, this is just for saying because there is a big wider audience here, and they have to understand that you don't need to jump into what guidelines say. The resistance is not for using it because of any other purpose. But you have to understand that chronology. You know what I mean? If you forget those things.
I get it.
Yeah.
We cannot offer it to all.
At the cost, exactly. In India, it is a big thing.
Yeah, cost is a big thing. Now cost is coming down. Omalizumab is available for 8,000 rupees now.
10,000 rupees. Yeah, that's right. Yeah. So you would use it. Yeah.
Thank you, sir. Thank you so much.
Very much, ma'am, and thank you very much, Pravin sir, for those excellent insights into the nitty-gritty of all the allergic manifestations. So coming on next is a session in which we are discussing mastering the art of allergy detection through thorough history taking and the use of cutting-edge diagnostics. For this session, I invite Dr. Alok Nath, Professor and Head of Pulmonary Medicine, to chair this session. He is a professor at SGPGI Lucknow, and he has received numerous accolades for his work in the field of pulmonary medicine, including Uttar Pradesh Gaurav Samman 2022 from Minister of State Shri Asim Arun. And also, I would like to invite Professor Anupam Wakhlu. Sir is Chief Consultant Rheumatologist at Apollo Medics Hospital, and he is also ex-HOD of Department of Clinical Immunology and Rheumatology at KGMU. So over to you, sir, for the further session.
Good morning, everyone. So we start this session of with the art of allergy detection. So an expert testing. So to deliver the first talk, I'll invite Professor Rajendra Prasad, who needs actually no introduction. He is the mentor of mentors and a very respectable person in the field of pulmonary medicine. He has been a teacher of all our teachers. So he will be talking about the art of inquiring and mastering the art of history taking in allergy, which is a very important part for the management of unknown allergic disorders. So over to you, sir, for this session.
Good morning. Thank you, Alok and the other chairperson and distinguished audience. Well, I see my laptop, time is 15 minutes. So although in the program it was written 30 minutes, so I'll finish within 15 minutes. I'll try to finish.
25 minutes. Absolutely no problem.
Okay, in this laptop it is coming.
No, they're going to change it.
Okay. So after listening such a wonderful cases, well, all sorts of newer investigations and newer insights into the allergy, maybe allergy to skin. Now I'm going to take you to the word is very conventional one. Is which is being taught for years and years. But unfortunately the art is being vanished. I say the art of history taking is vanishing when I interact with the doctors and other people. So what I'm going to do in next maybe 20-25 minutes is the technique and importance of history taking in allergic disorder, and particularly being a pulmonologist. So I will restrict myself to the nasobronchial allergy. How it will move. It's not moving. So my objective next would be what is the relevance of history and clinical examination in diagnosis of allergy, particularly the respiratory allergy. You know, many times our minds are confused with the advent of all sorts of newer and newer investigations. You have just heard in the morning. Is there any place for history taking and clinical examination? That's always, at least in minds of the youngster, what I have experienced. As Alok said, I am teaching for last 50 years. So I used to interact with students very, very actively. Because many times my students, PG students in ERA, when they come to show the case, they show me the CT first. So I just shout on them, tell me the history first. Show me the X-ray first. Then show me the CT. So, but the clinicians and their patients still value the history taking. And the biggest complaint of most of the patients what I see, I act as a tertiary tetra penta care chest physician, I must say. So I listen patients very carefully, and what is their complaints is the biggest complaint of the most of the patients are their attendants, that most of the doctors have not talked, listened properly and seriously. डॉक्टर मेरे ख्याल सब लोग हिंदी समझते ना डॉक्टर लोग सिर्फ आजकल अभी डॉक्टर साहब ने कहा ना कि फार्मा इंडस्ट्रीज आई हैव सीन प्रिस्क्रिप्शंस व्हिच हैव गॉट 12, 15, 30. Last night I saw 32 drugs in one prescription. I don't know how they are diagnosing, what they are diagnosing, how they are writing the treatment. But that's the plight of the patients, I must say. So I don't think it will move, but this a patient narrating to me, डॉक्टर साहब ने कुछ भी नहीं सुना, बस जांचें लिख दी, उसके बाद दवा लिख दी. That's what this patient is saying to me. Unfortunately, it is not moving. So, and I must tell you why history is important. Of all the diagnoses that ever is made, most are made during the history and most of the rest during the physical examination. This is for youngster. This is all evidence. I mean, some papers are there which says that. So, and 88% of the diagnosis, I used to tell my PG students, it's true that history is so important that about 70 to 80% of the diagnosis and even the therapy comes from a good history. So 56% of patients in general medical clinic had assigned correct diagnosis by the end of good history and rose to 73% when you completed your physical exam. So there are evidence based that history and physical examination still is very important. I will like to share one of the studies, which is old one I did when I was in KGMC, that what is the prescription habit of medical practitioners regarding allergy testing. You know, allergy testing is very common in patient's mind. And all sorts of doctors, you can say, they are prescribing allergy testing, even non-allopathics, even quacks they are prescribing. In India, I don't know what is happening in other countries. And all sorts of diseases where they are prescribing for asthma, rhinitis, skin allergy, food allergy, and drug allergy, also ocular allergy. And only what we could find in our OPD in KGMC when I was, that only about 2/3 of them, they had some allergic problem. 1/3 they don't have. And then there are all sorts of non-allergic diseases where they have been advising and distribution of allergic diseases. I'll not bore you with this. And allergy testing in our clinic, because we run allergy clinic in KGMC for very long years. And so allergy testing was, to our understanding, whatever understanding we have at that time, was required just half of the patients. So what I'm trying to say that it's a very test which is very, very popular among the clinicians, and everybody try to do advise the allergy testing. You have listened yesterday a lot about the allergy because he's sitting here, because he's not here. Yesterday I enjoyed his talk. And what is allergy? Allergy, I probably will not waste time, but I'll say that misuse of term allergy led to a variety of unexplained phenomena being labeled as allergic disorders. Most of the doctors tend to attribute allergy that they do not understand. That's another issue. Among the educated laymen also, it's a fashion to suffer from allergy. When patient comes to me, मैंने कहा भाई तकलीफ बताओ, सर एलर्जी हो गई मेरे को. हमने भाई मैं नहीं समझता एलर्जी हो गई. बोलता आप इतने बड़े डॉक्टर नहीं समझते. हमने कहा मैं नहीं समझता, मुझे आप तकलीफ बताओ तो मैं कुछ निकालूं उससे क्या आपको तकलीफ है. So it's become a fashion even among patients. And of course, you know, first time allergy was defined way back in 1906, and ability of animals and humans to develop altered response. But if you go that further, the last time and in 2023, allergy definitions has somehow changed because of all sorts of allergic reaction. Initially, we used to talk 4 types of allergic reaction. Now we are talking about 8, 9 types of allergic reaction. So that even definition in that particular paper, they have changed allergy in an abnormal or exaggerated reaction to exogenous stimuli, which involves various type of hypersensitivity reaction, engaging antibodies, human immune cell mediated tissue-driven metabolic mechanism, lot of things resulting in development of respiratory, skin, eye, GI, and other symptoms, including anaphylaxis. That is what is the current definition of allergy as per this guideline. And hypersensitivity, also somehow related term, refers to undesirable, uncomfortable, or damaging response that arise from tissue cell dysfunction and immune system organ. Another word in allergy, people use atopy. Atopy to me, when I joined way back in 1976, this department as a PG student, then atopy is what I have been told, it is the genetic susceptibility to develop IgE against common allergen encountered in the allergen. Means they are the individuals who are likely to develop allergic diseases. Although 2005, little change in definition, and today what people understanding about atopy, the term atopy, though deeply rooted, has limited use today, and it is based mainly on the symptomatic definition of disease and does not represent the current understanding of pathophysiology. What are the common allergic diseases? You are listening since yesterday, but common, as I said, common is starting from nasorespiratory, ocular, dermal, GI, systematic, and all sorts of diseases are there, you have to understand. And then there is another term in allergy used, allergens. Allergens means what are the things which causes allergy. Now it may start from inhalants, pollen, fungus, house dirt, so many things. Ingestants, food, injections like drugs, and many things can be the pollen. And what are the common pollen in India? What are the common, allergen in India? We did a study again and published in 2013. The commonest type of allergen which is prevalent in India is usually, you will not believe, insects and mite. They are the commonest one, apart from dust, pollen, and animal dander, foods, and fungus. So these are the common, when we do skin test and find out the allergens, they have been there. Another, most of you are immunologists, I believe, but if you want to become an allergist, you have to understand the pollen calendar. What is a pollen calendar? Means you have to go a little bit towards the botany and zoology. Pollen calendar means when there is a flower in the particular tree or particular weeds. And it has been, in our time, there is nothing like a pollen calendar, but now it has been worked beautifully throughout the country. What are the common allergens and when they pollinate? Like, I'll give you an example that why pollen calendar is important, I'll let you know. Pollen, this is some of you might recognize, this is a very common neem tree. And neem tree is a director. Many of my PG students in my KGMC, जहाँ मेरा OPD है, वहाँ के सामने neem tree है. हर resident उसको क्रॉस करके OPD में आता था. OPD में आके एलर्जी टेस्ट करता था. एलर्जी क्लिनिक थी. तो मैं पूछता था ये पेड़ जो है ये क्या है? पेड़ तो लोग नाम बता देते हैं, नीम का पेड़ है. हमने कहा इसका बॉटनिकल नेम बताओ. जबकि उसको वो अपने किट में एज अ डायरेक्टर वाज देयर, So, so that was the first training I started giving to my student. How you have not to mug up. You see the pollen, you see the tree and around you, and you try to know what is this. And when they pollinate, that is actually a pollen calendar. And this photograph was taken in month of April, and so you see all white flowers are there. That means, as a director, this pollen would be important, if it is at all important in a particular patient, in month of March, April, when they pollinate, when the pollen calendar comes into the environment and people inhale that. Likewise, there is another common ricinus, and this is again flowering time is February. So pollen calendar, what mostly people say, it's an important in respiratory allergic diseases. It's important to know. If you don't know the pollen calendar, it is very difficult to practice allergy today. It is important in respiratory allergic disease for taking personal preventive measures, diagnostics, and even therapeutics. When we test in majority of the patient, we find there are 5, 10, 15 test is positive. Well, how to choose them? Probably if you know what is the pollen calendar, you might choose the. Question is, when you diagnose allergy, history and skin test, somebody will talk about. My job is to just say history and history and physical examination. I have a YouTube lecture because I was compelled to put one YouTube lecture, how to take history. If some of you interested, may go and see. History is a very important, is adequate and careful history. You must have understood by now, it's a very important. History is in allergy, history is directed mainly towards establishing the underlying. Disease is obvious. When patient enter your clinic, you see that whether he is suffering from rhinitis, asthma, these are two very common allergic nasal-respiratory disorders. So it's very obvious. You have to first find out what are the allergens. What are the important allergens which might be responsible? First, you have to find out whether it is allergic or non-allergic. Or second, if it is allergic, then what are the important? So objective is, when patient has allergic disease and it discovers underlying causes. How you suspect, in sitting in your OPD, how you suspect that this particular patient may have allergy in his background. Usually allergic diseases starts from, I said usually, it is not 100%. There will be family history. Most of the time we ask that family history may be positive. Combination, usually in allergic disorder, there are combination of symptoms. Asthma and rhinitis, they are most time existing, or even skin urticarias, eczemas, they are coexisting. Seasonal variation, one of the very important issue. Many people come to us, अब जब होली दिवाली आती है तो मेरी सांस फूलना शुरू हो जाती है. That's a seasonal variation, and you know that is related to the pollen calendar. So it may be perennial also. Many of the pollens are perennial. Geographical variation is another point in the pointer in the history. Geography will not differ from Lucknow to Delhi. It will differ from Lucknow to Srinagar, to Bangalore. Because their fauna and flora is different. So that's these. Many people say, अब मैं लखनऊ में रहता हूँ कुछ नहीं होता. जैसे मैं बेंगलोर जाता हूँ मुझे छींकें आनी शुरू हो जाती. So those are the pointers when you suspect, yes, allergy could be play a predominant role in this particular patient. Then you go into history. Somebody has said CBI detective. This is my famous word. When you take a history from the patients of allergic patients, you have to act like a CBI detective. CBI वाले कभी 2 मिनट में कोई काम नहीं करते हैं, बहुत दिन लगाते हैं. So pointer is that you have to spend time in history taking. In other diseases, you may not spend such time. For every allergy clinic, there are defined case sheets, which is little different than usual case sheets what we do. So you have to know like any other history, chief complaints, present illness, their duration, details of chief complaints, whether seasonal, perennial. I said seasonal most of the time, pollens. Perennial is still house dust mite, animal danders, fungus. They could be all cockroaches. They are very common allergen in India. It could be irregular, perennial, times of day and location where symptoms do occur that may throw some light about the allergen. Precipitating factors, you have to know what precipitates your attack. That may point out many things. Thorough environmental history is very important, may not be discovered by any test. So you have to go into the history detail. Assessment of impact of illness also you have to go. Actually, a case sheets in allergy clinics, they have all these details, they capture it. Past history is also very important. हमारा पीजी जब केस प्रेजेंट करता है तो पता नहीं यहाँ का पीजी क्या करता है, वो एक ही सेंटेंस बोलता है. यूजी में मैंने देखा है, पास्ट हिस्ट्री इज नॉट सिग्निफिकेंट. हमने कहा एक रटा रटाया सेंटेंस है ये, जो चला आ रहा हमारे मेडिसिन में बहुत दिनों से. हमने भाई क्या पूछा आपने जो कह रहे हो पास्ट हिस्ट्री इज नॉट. सो पास्ट हिस्ट्री कुड बी वेरी सिग्निफिकेंट समटाइम्स. Disease of infant. Suppose somebody suffered from eczema during childhood and today is suffering from breathlessness, so you can correlate. There's vaccination history, any ENT operation in the past, any drugs taken in the past, and what was their response. With that will tell you to decide what could be. Family history, I said, is also very important. And there has been many studies about the family history. One of the studies says that 30% chances are there if one parent is allergic, 50% if both parents are allergic, and 13% if neither are allergic. So it's not necessary that family history is always, and in many of these studies in India we have compiled that odds ratio is about 2 to 5 go if the family history is positive. Present personal history is also very important, what he do, what he has done in the past, job at onset, hobbies, diet, home, everything, home condition, everything you have to go, smoking. This is what I'm trying to say. History is very detailed and you have to go for detailed history. And always I'll say that you have to work like a CBI officer. Physical examination, I'll not spend much time, but physical, the 2-3 points I always say. Suppose a patient of asthma has come, we put our stethoscope, there is no wrong eye. It is possible when disease is in phase of remission. Somebody has urticaria today, he may not have urticaria, but he says historically it is very important. So that is the point you have to always keep in mind. Complete physical examination is actually necessary in areas where allergy is likely to be there, like eyes, nasopharynx, ears, lungs, abdomen, and skin. And sometimes if patient is in remission, asymptomatic, you may not get any finding. I'll not go into allergic rhinitis. I think there's a different lecture. And we have Indian guidelines, if you are interested. It was published in 2023. It was made at Patel Chess. We were part of that. I think Dr. Behera is also come. He's sitting here. So he was also, and we made Indian guideline, and there we said that what is the place of history taking and physical. Although the certainty of evidence is not very high, but the strength of recommendation was very strong. So history taking assumes a very important situation, and I have come to end of my presentation. And my take-home message is, you must have understood by now, value of history taking is undebatable, beyond debate, and first step in diagnostic workup. Needs good amount of time, as I said, for complete workup, like CBI officer. Careful history discovers underlying causes, and rather it is etiologic, allergic history or etiological history. When somebody comes with urticaria, you ask so many questions. क्या कारण इसका हो सकता है? Clinical history also guides you the interpretation of the skin test, what my next speaker is going. Unless you correlate those things with the history, probably any test in isolation may not be sufficient. So you have to all correlate with the history. Knowledge of aerobiology, I said, pollen calendar, aerobiology is also very important around you, and you must correlate skin and lab tests with the good history. That is what is. So in the end, what I'm going to say that an adequate clinical history and physical examination is very important for diagnosis of allergy and particularly the respiratory allergy. Thank you. I would like to share that even this lecture now I have also become YouTuber. मेरे को PG लोग यही कहते हैं. So I have many YouTube lectures. This is the same lecture is there on the YouTube. I have book on clinical allergy. I have one YouTube lecture on chest X-ray. Many of because chest X-ray is seen by everyone. ऐसा नहीं है chest X-ray सिर्फ chest physician देखता है. हर आदमी देखता है. तो then I put this lecture on the great demand of my students. विकास अग्रवाल अभी यहाँ बैठे थे. ये भी कल बैठा कि इन्होंने वो एक्सरे के क्लास अटेंड किए होंगे KGMC में. So they demanded कि सर वो एक्सरे आप डालिए कहीं पर. So I put on YouTube. To your surprise, 3,25,000 have viewed just a simple how to interpret chest X-ray. And I was very encouraged with this. Again, the same students advised me, sub bring book on chest X-ray. Because chest X-ray books are hardly written by any chest physician. Most of them written by radiologists. So now my latest book had just come in 2 volumes. It is available everywhere. So I would like to end my lecture. Anyone who keeps learning stays young. बेहरा साहब को देखिए कितने यंग दिख रहे हैं. We are friends together for many years. आप लोग तो सब यंग हो, हम लोग थोड़ा यंग नहीं अभी. So, but we keep learning. That's why this may be possible. That's why in the slide I always say, I am still learning. Thank you very much once again, PGI and all the people who are for giving me this opportunity to talk a very simple lecture, how to take, what is the role of history and physical examination. Thank you very much.
Insights that you have gathered through your experience so far. We are open to questions. Nowadays, the brilliant students, they say there is no significant past history of illness. The future I cannot predict, and I have no idea of what's happening in the present. So,
that's very fact, very fact. You said very rightly. Many of the presentation we do attend of UGs, mostly of PGs I attend. UGs का कम ही करते हैं. They have become habit of saying few words. Past history may be very significant sometimes.
so questions online, offline. Do we have any online questions?
If there are none, thank you, sir. Thank you for elaborate presentation on history. We move to our second talk, that is about art of, skin prick testing in evaluation of allergy testing. I'm exploring the potential. I'll call Dr. Bhagat, who is the associate professor in he is practicing allergy physician, and he is secretary of, is fellow of Indian College for Asthma, Allergy and Applied Immunology. He is secretary of ACPG and fellow of National College of Chest Physicians. He has presented various posters and papers in various national and international conferences, and he carries out a lot of camps related to education for asthma, about asthma and allergy disorders. So, Dr. Bhagat, welcome, and kindly deliver your views on techniques and importance of his the insights into the methodology and preparation of allergy skin tests.
First of all, I would like to congratulate Dr. Kunal and this ImmunoAllergy Conclave team. I think this is the first time I had seen so much of academics and the presence of people in hall for allergy. This is the first time, yes. As such, if you consider allergy, it is a significant, in the past, allergy was not considered significant at all. But nowadays, there are so many incidents and so many people awareness is there, so people recognize allergy. Otherwise, it was told that if you don't know, it is allergy. But now the scenario has changed. Allergy is more than 100 years before recognized, and the von Pirquet, he diagnosed or he gave a word for the allergy that it is an abnormal reaction and increased sensitivity to certain substance. Here, it is like a loaded gun. You don't know which is going to be a trigger. It could be a pollen, it could be a dust, it could be a food, it could be an insect, it could be a mild, it could be a moderate, it could be a severe, like life-threatening. So, very important is there to diagnose the allergy. And as absolutely what Dr. Rajendra Prasad mentioned, that history is very, very, very important in case of allergy. We saw many patients of asthma, rhinitis, dermatological conditions, drug allergy, and food allergy. So these incidents are now increasing. Most of the time, people, they develop allergy in the childhood, those who are sensitive. And second outbreak, which comes after puberty. So many patients, they ask that we were not having anything before, and why we are having these conditions right now, after 50 years, after 15 years, after 25 years. But if you go, there are sensitization of patient, around 40% of population having positive IgE without any symptom. Allergy has a tendency of march. It replicate. Most of the time in the childhood, it could be a gastrointestinal or dermatological allergy, and gradually turn up to the respiratory later on. And it is from 1 to 2, 2 to 4, like it is a replication. So single oligomolecular sensitization will go to the multiple molecular sensitization, and there would be a from few allergen to multi-allergen. This is very important, and it has to be stopped, and that is what can be done by allergologist. Different system, I think most of the system are affected by allergy, and allergy can do anything except pregnancy. Why we are going for allergy testing? So this allergy testing can give to identify specific allergen. It gives the idea what to avoid, what to do, what not to do, and also the specific treatment. And now there is allergen-specific immunotherapy is there, and it is over the more than 100 years, and it works. Of course, it prevents further allergy march. As already mentioned, that there is an allergy march from one to other like that. So it will be prevented by this allergy testing and immunotherapy. Different type of allergy, it is now nomenclated as like hypersensitivity, and here we are going just to the detail of type 1, that is IgE mediated. Sir has already mentioned that there are different pollens. Why it is important? Because if in an allergy, if you have not taken the proper history, you will not go for the proper diagnosis and proper investigation. In allergy, there are rampant investigation is available, and there are multiple labs, they are giving multiple reports. But what to do, that has to be decided with history only. There are likely to be some seasonal, there are likely to be some perennial allergen. Right now, I am coming from Gujarat. So Gujarat and Rajasthan, right now, there is a heavy pollen season right now. So we what find that this is a 6 to 8 week period, we are finding maximum number of patients with the pollen allergy, that is Holoptila. So even right now, after this much 25 years, we don't have to go to the detailed history. Patient coming with the rubbing eye, nose, breathing, so it is a Holoptila in a February, in March. And I think our practice run one Holoptila in a February, in March. There are some animal dander, That is also important. Outdoor and indoor animal. Some indoor animal, right now people are very fond of keeping dog, cat. So these are the very potent allergen. And even cat allergen, it remains in-house after removal of cat for a longer time. What we don't know, that what we are doing and where we are sleeping. So the sensitive person, they are sleeping, that is with the very important house dust mite. It is a very big picture, but it is a very tiny insect. It is an allergen that is out around 2.5 micron, which you cannot see with the naked eye, and maximum number of patients, they are suffering from this house dust mite. Food is very important. Food can cause not only milder but severe symptoms. Sometimes it may happen that food can cause severe angioedema, severe urticaria, severe bronchospasm, or even anaphylaxis. The mechanism, that pathophysiology, what you say, that is allergen when comes, it binds with the allergen presenting cells, and it will stimulate Th2 or B cells produce anti-IgE. These anti-IgE bind to the mast cell, and when they bind with the mast cell, it degranulate and produce number of events with the liberation of mediators like histamine, interleukin, tryptase, heparin, and PF. History, and history. Always we tell the students, the very important is the history. It may happen, you may be diverted in the history. Sometimes when we are taking history of a person like a child, and we ask for the family history, and there it goes to the different path. That yes, mother is having these, and grandmother is having this. You have to come to the original path and go for the proper history, and then you have to go for the direct question. Where your symptoms started, what is the progression, what is the severity, what is the season, which are the associated symptoms. These all are very important. The past history is absolutely important, as this has allergy march. Some patients may have in the past some other kind of allergy, and now they have turned up to different type of allergy. Family history, absolutely important, not only for one condition, but most of the allergy condition. It is very, very important. These are the very common allergen where you can find the dust mite. You find in-house, it is an indoor. So beddings, mattresses, pillow, sofa, in humid place, lack of sunlight, closed area. The dog, that is also indoor, that also you find in the carpet, bed, bedding. And the cat, as already mentioned, it has a tendency, the cat allergen, to remain for the very long time in the house, even after removal of cat. The cockroach, fungus, pollens, usually it is outer side. These are the symptoms where you get more when you go outside the house. Insects, either it is in-house or out-house. Different allergy testing method available, and different form is available. But here I am discussing that is a skin prick test, and it is very important. Skin prick test is just for a detection of immediate reaction, and that is IgE mediated. Here the solution is available with 1:10 dilution, that is volume, weight by volume. Intradermal test, now it is absolute, but it gives, in certain condition we go for the intradermal test, where there is immediate reaction as well as DL type of hypersensitivity, and these solutions are coming in a 1:500 weight by volume. The patch has different thing, and a prick. Certain times we don't get any positivity of food allergen, and we require, anyway the history is very strong. Here we go for the prick test, but it is also to be under observation and should be under good care. For SPT, as such, there is no contraindication except there is if dermographism, if patient is not cooperative, like elderly patients or very young patient, and those patients, those who are not able to stop antihistaminic for testing skin prick test. And the relative contraindication is like asthma, the pregnancy, infants, and patient on some medicine like beta blocker. Almost all conditions require, if you go to the history, that the skin prick test is mandatory, but only after the proper history. Which is not of my core, but still I am just going for. There are multiple, I think yesterday eosinophilia, the speaker has given very good lecture regarding eosinophilia, and eosinophil in allergy and non-allergy conditions. We find eosinophil in allergy and non-allergy conditions, and it is very, very important to go for the history and diagnosed allergy. The same way happens with the IgE. Sometimes it happens that IgE is in the thousands, but we don't get any positive skin prick test. Sometimes with the very, very, very strong history, that patient is having history of B anaphylaxis, we don't get a IgE positive. We get IgE around 50. But if you go to the specific IgE, or if you go to the skin prick test, it would be positive. So high IgE doesn't mean it is a strong allergy, and low IgE doesn't mean there is a no allergy history. These are the medicine which has to be avoided prior to skin prick test. And whatever the extract for a skin prick test we use, it should be proper. There should be a in mind for the cross-reactivity. There are chances that you may get a false or cross-reactive positivity in the test. Food allergen, which has a very small life, and it may be, so you have to replace it every month or 2 months for allergy testing. Expiry has to be seen, and it should be properly maintained in a refrigerator by 2 to 8 degrees centigrade. These are the different allergen available for the skin prick test. Different kit is available, and the site for the skin prick test is ideally forearm or back. And here you will see that testing, it should be apart around 1.5 to 2 centimeter from each allergen. Otherwise, there are chances you may get a mixed reaction of 2 allergen. This is very important, that minor things are required, but very important is always keep in clinic adrenaline. That is the first and foremost, that adrenaline. Adrenaline, some IV fluid, Avil, F-choline or steroids. Other than this, nowadays there are very, very less chances of anaphylaxis or severe reaction in skin prick test, which was there in the past with the intradermal test. In the intradermal test, which we are doing in the past, we had observed some bronchospasm and even anaphylaxis in patients. So just keeping in the mind, you should have some laryngoscope, ET tube, umbo bag, and a primary measure to resuscitate the patient, which will just as a part you require legally. Measurement of skin prick test is from either dimension, you calculate it and it divided by 2, that is your presentation of reading. There is a reading. For the skin prick test, negative control should not be appear positive. It should not be a more than 2 millimeter. But positive control should be more than 3 millimeter. Now you can go for allergy testing, otherwise not. There are chances sometimes patient may tell you that I have not taken any medicine. But if you go for the negative and positive control, you will not find positive control positive. It will not be more than 3 millimeters. So this is, here you have to stop. +1, +2 by 3 to 5, 6 to 8, 9 to 11, and more than 11 is 1, 2, 3, 4 gradation. The gradation is not related to severity of the symptoms and presence of allergen related to symptom. It is a sensitization. The same for the intradermal test. in the skin prick test, very, very precaution or caution to be taken in doing food test, fresh food, latex allergy, particularly insect and venom allergy testing, some drug testing, and very young patient. Sometimes we may get a false positive or negative, where there is a incorrect false positive. You may have introduced intradermally, injected large material, strong concentration would be there of allergen extract, irritant would be there in the extract, there would be a trauma with the lancet, and it might be a contaminated or it might be having a little air. Where it is a false negative, in spite of positive reaction, there would be a chances it may be due to atrophied or diseased skin, very thin skin, dehydrated, old age, and weak antigenic extract. The same way happens sometimes food allergen testing after 2 to 3 months, it will not show any positivity because it has lost its potency. So potency of allergen is very, very important, and it has to be maintained and it has to be replaced. Selection of allergen, that is absolutely important, and there should be standardized allergen extract, and it can be done with batch to batch, and if it is not, you will get some variable skin result because of there is an unstandardized allergen extract. But if it is properly standardized, you will say the similar response, and it is reproducible. In certain conditions where you not go for a skin test or this dermographism, patient on medicine, there are some risk of anaphylaxis, those patients who are not cooperating with the skin prick test. Food, sometimes in vitro is better than skin. We find many patients positive or sensitized with the in vitro where they are not truly having any symptom. So what to do, whether to go for a skin prick test or go for an in vitro test. There are multiple methods available, but ultimately it is gold standard and by all the authorities approved either to go for a specific IgE estimation or component or skin prick testing. When I had two things to choose, either in vitro or skin prick test, most of the time I will choose skin prick test. If patient is cooperative and if all the other formalities are fine. Skin test has a result which shows direct contact with the allergen and antibody over the skin. Sometimes in vitro we are doing that is giving a circulating antibody titer, which is not true. So skin prick test, definitely it would be absolutely important, and we go for that. Only thing is that some training is required that can be performed by the clinician as well as very trained staff. But clinician should be there when they are performing, as the staff is performing the skin prick test. Interpretation that can be done again by the clinician. So skin prick test, what I say, that is a standard for diagnosis of any kind of allergy. Sometimes it may happen that you are not getting any positive response with the skin prick test, like particularly in the bee venom. Here you can modify and you can go for the intradermal test. That will give very good result and very good clue. But of course, with the intradermal test, be careful and take all the precaution for anaphylaxis. Thank you. Thanks for listening. Thank you.
Can we have the lights, please? Thank you, Dr. Bhagat. Not around. Definitely. So, questions, please.
Hello, sir. Dr. Dahivat from Ahmedabad. Yeah. Sir, skin prick test normally indicates sensitization only, right? Not truly allergy. So, if it is positive for 2-3 allergens and diet history is very complex in a country like us, do you give oral food challenge after with all those 3 antigens separately, or how do you proceed in such cases when skin prick test is positive for, a sensitization is positive for 3-4 antigens?
Yeah, very good question. It may be possible that you may have a sensitization with not one, there are multiple allergen positivity. But again, your clue with the skin prick test would be absolutely with the history. If you take a history, you will get a clue that patient has taken these things on this day, these things on this day, and skin prick is positive. Altogether, history and skin prick test, you will have a correct result. But if not, absolutely, we can go for a challenge test. But where the food is giving challenge, which giving the major reaction. If it is a minor reaction, I will not go for the challenge. But if it is a major reaction, definitely I will confirm with the challenge.
So I just had two queries. That
Yeah, madam.
when you find, how much is your matching between the skin prick test and the history? How many allergens do you identify? And second, I mean, how much useful is it in your clinical practice? I mean, people do it, but does it really help you? And how much does it help you?
Yeah, madam. The first, that clinical history and positivity, usually we find in many of the patients. Like right now, it is a season of pollen allergy. So we are getting upper respiratory and lower respiratory patients with the history. They are only coming in the February and March. And they diagnose themselves. And here we go for the confirmation with the skin prick test, it comes positive. So this will happen. Sometimes it may happen that history is positive, but we are not getting positivity, or history is negative and we are getting positive response. So it could be a cross-reactivity. So history and these together, definitely it works, and we are getting very good response in that. And the second, skin prick test, how much is helpful? I am very sorry to say, madam, but there are so many laboratories and so many quacks. They are doing skin prick test and in vitro test. Absolutely, to these people, we are spoiled, and we are getting very, very ashamed things, allergologists, that it is a branch which is not reliable, and the testing which is not reliable. But I can say, madam, in my 25 years, I had treated around more than 70 patients of honeybee anaphylaxis. So that is a great pleasure for me that not a single patient has reverted back with anaphylaxis after immunotherapy. Skin prick test, definitely it works, and if it is done properly, genuinely, definitely it is very good.
One question, sir. So I came across a couple of systematic reviews and meta-analysis in management of allergic disorders, including bronchial asthma. Skin prick test based allergen avoidance and elimination diets, etc., did not have any benefit in the outcomes in form of number of episodes, absenteeism in children, or number of school days, or number of absenteeism from the work. So, as Dr. Amita was talking, actually on ground, when we ask for a commercial extract, multiple antigen skin prick test, you might get a number of allergens which are positive for. And when we apply that in clinical practice, it is very difficult to find what is the source and where is actually the allergen at the workplace, at home, or on the way. So, I'm just talking about the hard evidence. I have come across at least 2 meta-analysis for skin allergy, urticaria, etc., and one for bronchial asthma. In bronchial asthma, contrary to skin allergy, there were fewer absenteeism from school, workplace, and episodes of exacerbation if we do a diet elimination and a skin prick test based allergen avoidance. However, in skin allergy and unknown allergic manifestations, it was not very useful. So, what is your take on that?
Yes, very true. That for the children properly, if they are going to school when there is a proper history that they are having particular symptoms in particular season, probably they have some family history positive. Around 30 to 40% of patients have a positive family history. And absenteeism is there in school, but there would be some allergen positivity. And this is the symptoms, asthma. It is not provoked by allergen only. There are multiple factors which provoke asthma. For the pediatric patients, you can say some psychological stress, hidden stress, some diet, some environment, sometimes infection, viral infection. But if you go to the adult, there are few more causes which causes there is a triggering of asthma other than allergy. Like if female is there, there are hormone disturbances. If there is a physical exertion, even child, if exercise, sometimes exercise-induced problem is there, some closed area, and over and above, the irritant. Irritant, I had seen many of the patients, they come with the allergy diagnosis, those who are having symptoms of allergy due to irritant. It is a perfume, it is some color, it is some polish, and these are the patients. So there are multiple triggers. We have to go to the deep history, and after that only we can go for the skin prick test, but not for the random skin test.
One thing I would like to learn from the house and from yourself also, that subcutaneous immunotherapy and sublingual immunotherapy is being practiced a lot for asthma in childhood as well as adults. Adults it is not being found to be so useful, but for children, yes. So, I mean, how much effective is systematic desensitization, which was kind of a thing which people used to enforce that it might be cure of bronchial asthma according to the Dutch and the vaccine hypothesis. So, is there actually any role by the practicing immunologist, because we are not into too much of systematic desensitization. So, whosoever in the house has got experience for that, kindly enlighten us.
If anybody, then I.
Yes, sir. Please.
Yes, sir. The first thing, what I explain to the patient, those who are adult, those who are having asthma, which is a moderate, which is not severe, I explain them, we go for the allergy test and we desensitize, doesn't mean that you are cure of the disease. You will get a decrease of the symptoms, you will require, and there would be a decrease of exacerbation in your case. But yes, if it is a seasonal, I will tell them you will get cure. And the pediatric patient, as you mentioned, sir, absolutely right. The pediatric patient get very good result, and that is what we are preventing further diseases in their adulthood. But some rhinitis patient, very good result. B venom, we are getting very good result, very good. And that is a life-threatening condition. The patients are coming just keeping in a mind that we are God.
These are some positions, places where actually ISAC test is strongly recommended to be done.
But in asthma, if it is a seasonal, yes. If it is a perennial, we go for immunotherapy, but there are chances it will not work 100%. It will work around 60%.
Let's get a dermatologist's opinion.
Yeah, just Abir Saraswat, I'm a dermatologist. I was interested in house dust mite allergy because many cases of atopic dermatitis, children are sensitized to house dust mite. And the evidence, as sir said, is conflicting whether actual avoidance helps or not. But there seems to be a small subgroup where it does help. So what is your protocol? What exactly do you tell your patients how to avoid house dust mite exposure? 1, 2, 3 things, practical, solid things to do.
Yes. The first and foremost is there should be a ventilation in the bedroom. There should not be carpet. There should be sunlight if it is possible. And there should be change of linen, bed sheets, cover every second day, which should be cleaned, and after that it should be placed in the sunlight for at least 2 to 3 hours. And then only it should be used after pressing or whatever. And there should not be more dumping in the house. There should not be a book. There should not be a teddy bear in the room. There should not be a books. There should not be a cloth which has been dumped for a longer time. It should be clean. There should be only bed. And it should be properly clean. And the sofa, if they are using, it should be covered with some linen whenever patient sits on that. Otherwise they use a chair.
Do those proprietary covers that are available for pillows and mattresses, are they effective?
It was available. Now with the very difficulty it is available. Previously it was available with the Allergo and a Merck. So it was a mic end casings for the pillow cover, which was a little bit expensive, but it works. I had seen in the patients, yes. Thanks.
Okay, sir.
Alok, what you have pointed out is very right, that allergy actually is being practiced in this country for so many years. And it has come to disrepute, no doubt, because things were not done properly. I say usually, what Dr. Bhagat is saying is very right. If you choose a right patient, means if you do allergy testing where it is really required, and then if you get a quality allergen for testing, that's another important issue in this country, that suppose many times you are getting allergen from western part of the world where probably it is not very correlating. So if you select a proper patient where it is really indicated, and if you get a proper antigen for testing, and then finally after a correlating history and testing, and even in some cases in vitro testing, if you combine all these things and if you find the real culprit, at least in my own experience, we have treated many patients like this, they show a wonderful result. Even you know that even GINA latest guideline in certain stages, they have also advising that role of immunotherapy, but they are advising only after getting everything properly done. But it is very unfortunate. But many of the clinics, as Bhagat also told, that अब तो बिल्कुल commercial level पे आ गया है. What I read in the newspaper, that person is moving from one place to another, every district, and what he does we don't know. So no doubt that a limited evidence is available, but some evidences are also available where if you find the right sort of a patient and right thing, then it might work. Thank you.
Thank you so much, sir. Sir, we'll have to really, sir, we'll really have to close the session.
Just one sentence.
Go ahead.
That allergy testing has to be decided whether it is to be done or not. Because sometimes patient comes for the allergy testing and you find it is related to some irritant. Here there is no role of allergy testing. Thank you.
Thank you so much, sir. So, just a quick note for the subsequent speakers. We are running about 20 minutes behind schedule. So, if each speaker could give us about 2 to 3 minutes short on their talks, it would be 2 to 3 minutes. We'll be back on time. It is my absolute pleasure to introduce Dr. Pravin Hissaria, who I think by now needs no introduction. Pravin and me were co-conspirators and colleagues during our DM days. It is a pleasure, but I am actually jealous because not only has he become more famous and more well-read than me, but with age, he looks even better than me. So, hi Pravin.
सर मैं यंग था तब अच्छा नहीं लगता था.
Dr. Pravin, Professor Pravin Hissaria. Oh, give me 2 minutes. I have some things up my sleeve. Professor Pravin Hissaria is a senior consultant immunologist at the Royal Adelaide Hospital, immunopathologist at SA Pathology and clinical associate professor at the Adelaide University Department of Medicine. He is medical director of COVID vaccination program for South Australia. He is member of several national councils, Allergy, Immunopathology Advisory Board. Pravin always used to tell me he likes to have his finger in every pie, so to speak. And his main interest in allergic diseases focuses on the use of basophil activating test as a biomarker to bridge the gap between sensitization and clinical allergy. Pravin, do they even put the steak on the barbecue before asking you whether it's to be medium rare or not?
They still do, yes. And I tell them I'm a vegetarian.
Pravin has almost 100 publications and an H index of 24. And believe me, so just to remind you, Pravin, you have 10 minutes for your talk, 20 minutes for philosophy, and then question answers.
Love that. There'll be some science as well. That was a very interesting discussion in the previous session. So first of all, thanks, Kunal. This was absolutely fantastic, what you've done in terms of creating this, this program. A bit more intensive. I would have liked a 10 a.m. start, but you can't ask for everything and get it. Most importantly, the first thing I want to tell, actually, mention here, actually, is that I'm standing here and I live in Adelaide because of one person, Dr. Debashish Dhanda. So, I'm not sure how many of you know about my life history, but it has been, so I'll start with 20 minutes of philosophy and then 10 minutes of science. Is that I went for a bone marrow transplant fellowship facilitated by Sunil sir. Realized within 1 year that BMT no one does well even in Western countries, except that the whole family does not die in West because the government pays for it, whereas here the whole family dies after the index patient dies. So I decided I'm not going to do bone marrow transplant. And then I was going to come back, and Dr. Dhanda sir and Sumita ma'am, because Sumita ma'am was a geneticist and there was this big world genetics conference, so they stayed with us in Melbourne for 2 weeks. And he told me about this immunology position. He said, why don't you just go back to immunology? And I said, no, I think I'll go back to India only and practice. And he said, no, there's an immunology position coming up in Adelaide. And that's how I landed up in the job. So that's how helpful and well-connected and real humble human being Dr. Dhanda was. And we've heard absolutely fantastic eulogy yesterday from Vikas sir and Amita madam. So I won't go into detail, but I just wanted to put it out there that, yeah, I'm here today talking about allergy because of that person, because all that I learned allergy was after going to Australia, because as you know, we didn't have that in our curriculum now at that stage. So moving on with the science now, which is, let's just use this, I think. This works? आगे नहीं जा रहा है इससे जाएगा ये जाएगा ठीक I don't have any conflicts of interest except that as you all know I am a lab immunologist as well and I sit on the QAP, so it's not quite conflict because we don't get paid for it, but we do see other labs as to how they perform when they do the specific IgE testing in their labs. I think the previous the discussion that we had just previously was very useful because that put into the context about one big unknown thing about allergy, right? And that is what I want to really stress upon today, is the concept that you need to take before we start questioning the science behind allergy, because that is unknown currently. Even with the advancements, you know, of in last 5 years about the various intricacies of the immune system and its aberrancies as to why you start responding to something which is as innocuous as a pollen or a food protein which you've been having for lifetime, is that it is unknown. But unknown doesn't mean there is no science behind it, right? There is very good science. And if there is one branch where precision medicine always existed, that was allergy. So there is no asthma patient which is similar to one another if you do the allergy skin prick testing. And that's why you do the skin prick testing, because that is the precision medicine. And I think the problem that we have in India in terms of underplaying the importance of immunotherapy and its successes is because, as Raj very elegantly put it, is you have to have the right patient, the right test, the right reagent. And when you offer immunotherapy, the right product. The medicine is important. So if the extract that you are giving has not gone through those rigorous processes, although we keep calling it allergy vaccine, it does not undergo those rigorous cold chain practices that a vaccine should undergo. And we all have learned from vaccines, right, that just a change in temperature by 2 degrees for 20 minutes and you can't use the vaccine. But that is controlled by the global phenomenon, and that's why you see that most of these allergy vaccines, or they are not as helpful as we find if they are not done in a proper setting. Like you have to see Raj's setting to know how rigorously you have to maintain those cold chains and have to prepare those extracts. So your treatment is going to be as good as the product, as good as the pharmaceutical thing that you are using to treat it. So I think it is the fallacy is that. And when I say right patient is, there is nothing called skill allergy. That word is not existent. So when you say that skin allergy doesn't work, well, there's nothing called skin allergy, by the way. There is a manifestation on skin of some allergy. That allergy is a food allergy, that allergy is an aero allergy or anaphylaxis. Eczema is not skin allergy. Chronic urticaria is not skin allergy. So when we've already said they're not allergic conditions, how is your immunotherapy going to work in it? So that's why it is very important to use the right terminology. So when they say that, when you do the meta-analysis, it doesn't work, well, it doesn't work because there is nothing like that exists anymore. Asthma, yes, but a very small phenotype, as we all know, actually is allergic manifested, right? And the skin prick testing for eczema, for asthma came in after the biologics were commonly discovered, right? Because you need positivity for the anti-IgE to work, which was one of the entrant criteria for the clinical trial. But that was not to actually work out whether that was the thing. And that is where, as Raj said, that history comes in, right? That what are your exacerbation factors? Is it always during springtime that you require your oral corticosteroid courses, right? Is it springtime when the good thing about, bad thing about the history taking in India, as I keep telling, is our spring is now, which is kids' exams times, which means people can't travel. And that's the most important history when you actually decide which allergen immunotherapy to use. You ask them that when you go for holiday or when you go to your nanny's place, do you get better? Now, you can't get that history if it is spring-induced asthma because kids' exams are coming. So we saw someone fighting, right, in a Sunday morning household. That's a very common thing because you're not going to travel from January to March. And if you're not going to travel, you don't get that history. If you don't get that history, how are you going to place an importance of that allergen, whether it works or not? So I think it is a precision medicine, sir. It is a detective work. And that's why as many clues as you can get to find out what is the significance of that particular environmental agent into the symptomatology is when you will benefit. And most importantly, the tests are only as good. Why? Because there is a very big knowledge gap in allergy, the biggest knowledge gap. So after all the elegant type 2, Th2 pathways and how they get sensitized and everything, one thing actually is still missing, right? Very important thing is missing. And what is that? So we've heard about this, and I'm not going to talk about it, that you get exposed first time, your antigen presenting cell, B cells fire up, they have Th2 mediated thing, they get sensitized, start secreting the specific IgE antibody, and that IgE antibody now goes and binds to the mast cells, right? To the high affinity receptors. Yeah? So, but what we have to understand is this is still sensitization. This is not clinical allergy. Clinical allergy is when the allergen comes and binds to its specific IgE present on the mast cells and the mast cell fires, right? And why am I making such a big bone about it? Because specific IgE is found in lots of many people. It is found on lots of mast cells. But not every allergen which binds to it can trigger the mast cell degranulation. And that's why there is this big knowledge gap between sensitization and clinical allergy. And when you say what is the utility of doing skin prick testing or specific IgE, this is where we miss. Because we don't have that test. And despite us knowing so much about immunology, we still can't work out that there is an specific IgE which is present. It is actually even loaded onto the mast cell. You have exposure to allergen. Well, how does the degranulation doesn't happen? And that is the missing link, why we can't answer those questions about what happens. And that is what needs to be borne in mind when you order this test. So what can we do in the lab, right? So you can ask for, normally people ask for total IgE. I think Raj put it very elegantly. No use whatsoever in allergy. Don't even bother ordering it, okay? It is I'll talk in my next talk as to where it is useful. Then the second most common thing, which is possibly some useful, is your allergen-specific IgE. But again, as you have to understand, IgE is the least circulating antibody amongst all of the other isotypes of antibodies. So you have to know the test as to how it was done. It is, like how an ANA was done. You almost looked, right? Whether it was done by an ELISA and reported as an OD, which is bullshit test, or if it is an ANA done by an ELISA, maybe international units somewhat better. You still want to know what were the allergens quoted. ANA, indirect immunofluorescence, you actually pay some substance to it. It is the same thing. You need to know how it was done, right? But even the presence of that still tells you only one thing, which is that there is a tendency for it, because that knowledge gap is still existing as to what happens with the fire event. The third thing that you can do lab is to test for an actual mast cell degranulation event. and I think I've stressed upon it enough yesterday, that tryptase is an extremely good test for it. And why tryptase has become so fashionable, and why we didn't have anything before? That's because this potently active vasoactive amines, they actually have a very short half-life. So why couldn't you test for histamine? Because histamine gets released in 1 minute, half-life is 2 minutes, everything is gone by 3.5 minutes. So if a patient had a reaction somewhere and, by the time he even tells his partner about having an allergic reaction, the histamine is gone. It goes and binds to its receptors and can have symptoms later on, but the histamine is gone, so you can't measure it. People tried 24-hour histamine metabolites, quasi-helpful, especially because, it requires all those heavy instrumentations like HPLCs and so forth. And for all of us, people like us who worked in lab, we know you can't standardize it for a routine diagnostic purposes, right? And that's why it was not useful. Tryptase was helpful, and I'll talk about that. Okay, that might come later. So now I'll hurry up because lots of this has already been discussed actually to death in last 2 days. So total IgE, without going into the history, most important, it has no role in screening for allergy. So the normal values that you get were derived from few studies that were done in West, where there was not much of parasitic load. They did not sample people from different geographic areas, from different, so you can imagine from what has been told already about the nuances in terms of the responses to these across, the geographical regions, the time of the day, the time of the year, right? Whether you're having symptoms or not. So all those have to be taken into consideration if you were to develop what we call a normal range, right? Which was not in this case. And that's why it is useless. You can have a total IgE of 50 and you can have severe reaction, and you can have 100 and you can have thousands and not have allergy at all, right? But it is useful for skin problems because it is related to the extent of skin involvement. So if you have a severe eczema, generalized, well, it's very helpful. If you have a primary immunodeficiency disease with cutaneous severe viral infections recurrent, very important, right? So that's how we use IgE in our diagnostic conundrum when we talk about the primary immunodeficiency diseases, because that's what it tells you, the burden of the involvement of the skin. It does not have anything to do with allergy. And its most usefulness actually in allergy fields is possibly to put your specific IgE results into the context. So people say that because you can have non-specific binding, right? As we all know who worked in lab. So although specific IgE should bind specifically to that particular protein that you're looking for, if you have very high IgE, that might be some non-specific binding. So that's where I think is its only use in terms of using it in an allergic field. And that's the only thing where it should be used for. Its most use is in non-allergic conditions. So if you have parasitic infections, so if you have a high IgE and a patient has been referred for allergy, look for parasites. Okay? If you are urticaria patient, as I keep telling in my urticaria talks, high IgE, you have to look very hard for strongyloides, right? And if you have systemic features, you'll look hard for filaria or anything. It does not mean allergy at all. PIDs, this is for another day, but they have become so important part in your workup of primary immunodeficiency disease. We almost always used to think of Gs and IgGs and IgAs, right? And IgE has opened up a totally different field about in primary immunodeficiency. So if it is very high, think about it. Eczema, we all know. Allergic bronchopulmonary aspergillosis, we all know. And now, once we have started finding out this IgG4 related diseases or vasculitic syndromes have IgE as well. So it is more important in non-allergic diseases. And for allergic diseases, I think one most important use obviously now is the dose to decide when you're treating your asthmas, right? So it is based upon your IgE levels, whether it is more than 150, less than 50, and you decide on the dose. So I think that's going to be the most important use of it in allergic situations if you're going to treat your asthmatics with omalizumab. As I said, very important to know what is being used, what method is being used to detect IgE, because it is present in minute amounts. You cannot have an ELISA detected. We tried setting up an ELISA to detect IgE to non-steroidal anti-inflammatories in aspirin-induced respiratory diseases. I can tell you from personal experience. If someone tells me they can find an IgE by doing a simple ELISA, they are actually kidding. It's not possible. It is in such minute amounts. And even by using amplification methods, I was talking yesterday, biotin, avidin and everything, even then it is very difficult. And that's why actually the FADIA or the fluorescent enzyme immunoassay is important. Because what FADIA does is they have what we call immunocap, right? You've heard this word, I'm sure. What is that cap? So it's a sponge basically. And what does that sponge contain? As you know, with any sponges, you can put it into any material and it will soak it, which means it will create very high environment of concentration of that particular protein in which it was soaked. Yeah? That's what immunocap does. And because of that high degree of concentration that immunocap actually makes is why you can detect your specific IgE. So it is antigen excess what is required to detect this low antigen concentration, low antibody concentration that you're looking for, right? And that's why the method is so important. You cannot do a dot test as they do, and then obviously there are hundreds other labs which do hundreds of tests. And if someone is telling you they can do 500 blood tests, because you have to look for them singly, right? You can imagine 500 blood tests, if someone is charging you 1,500, they got to be kidding. 3 rupees mein ek test koi nahi kar sakta hai. So if you have 150 allergens and person comes and tells you that they've done it for 1,500 rupees, come on, that is a useless test. Yeah? So just ignore it, and there are lots of them going around. So you should know what is the test. So there are only 2 currently WHO or World Allergy Organization, recognized tests, which is ImmunoCap, which is here it is marketed by Thermo Fisher, and you have Immulite, which is a liquid-based test, where again it is the same method, they use the antigen concentration. I wouldn't go into details, I think in interest of time. Now, I think this has been mentioned by Raj as well, because basically, specific IgE is similar to doing your skin prick testing, right? Except that some people do believe that skin prick testing is actually more clinically relevant. I still don't think so. I still think, it is as good as, because there is nothing called skin allergy. I don't believe in that word. So I still think, this skin prick basically tells you the same thing what specific IgE does. Definitely it is more helpful because it is done by trained hands rather than these quacks who do the lab tests. So I would still have more faith in a skin prick test result done by a practicing allergist. The amount just tells you what is the amount, actually just tells you the likelihood of having a reaction. It is by no means tells you the severity of the reaction. So that is to be borne in mind. We always have this referrals where they come and say specific IgE is 100 for Hissaria. This must be the thing. Nah, that just makes it more likely that is what is causing the symptoms rather than associated with the severity. What about the role for screening for atopy, right? And we all keep hearing this, like, sir, thode allergy test screening karwa do. Where is it helpful, right? It's not that it is not helpful, okay? Everything is helpful when put into the right context and you're asking the right question in the right scenario. And the only scenario where it might be important is in pediatric setting where someone comes in with eczema. So eczema, most of the times endogenous condition, not allergic driven, but specific IgE presence in high levels has been shown to predict the typical allergic march as was shown by Raj, right? So you have your food allergies, then you develop your, eczema, then you develop your food allergies, allergic rhinitis, asthma. So it can predict it. And why would you want to predict it? Well, you can intervene to prevent that atopic march. And that's a big thing, to prevent asthma in a child, right? It's such a quality of life nuisance if you get asthma, as you all can imagine, in your growing days if you can't play sport and can't take part in recreational activities. So that is the use where it might be. And what would you choose is important for screening. So I still couldn't find Indian guidelines for what is important in terms of screening for atopy. What we normally do is we say that you should put in at least 2 seasonal pollens, usually the ones that are in spring, because as you can imagine, spring is the time when there is highest amount of pollen, right? As Raj was telling, this is the time, January to March, depending upon which month everything pollinates. You would put in a perennial allergen, and that is house dust mite, because that's just omnipresent. You'll put in an animal dander. Animal dander is very important. And I think for Indian context, insect is more important than animal dander possibly, because I do have a couple of patients with cockroach, some very, very high flying person, as I was talking yesterday, who was desensitized for house dust mite for 3 years without any response. And the problem was cockroach allergy. And as you know, cockroach desensitization is not as good as house dust mite. And that's one place where allergen avoidance works. And I think I heard about the meta-analysis about this avoidance not working. It can't work. How are you going to avoid something which is an allergen, right? It is like saying you are allergic to your wife. Well, in India, at least, we can't divorce. So you have to live with them. So that is the same thing with environmental pollens. Well, how are you going to avoid? Like, how are you going to avoid a grass pollen? You can't be living in a bubble, right? You will go out. Masks have shown to have minimal effects. And people have shown HEPA filter masks to reduce the amount of. Well, are you going to wear that? And wear that like 24/7 each time you step out, and that's too if it is an outdoor allergen. Indoor allergen, yes, there are some measures, as Raj elegantly put the measures for house dust mite reducing things, which definitely help. And they, if anything, they also help in sensitization for future asthma. So you would do that not for managing your eczema, bad eczema. What they help is that eczema patient won't get asthma then. So that becomes more important. Because your prevention is, obviously, that is one of the things that we all doctors do, right? So those things, so indoor you can still do certain, and there are guidelines for doing the outdoor allergen. How are you going to stay away from them, right? So, but you would still do the test because that will help you guide the therapies, right? So that's very important. So don't even look for allergen avoidance. As allergen avoidance can be done if it is physical urticaria. Physical factors, yes. But for something that is there everywhere, well, how are you going to do it? It's very easy to say, that, yeah, this thing should be done and that, but we can't keep sitting in a room which has HEPA filters or everything or wear a mask when you go out each time. That's just not possible. Not saying it should not be done, because it is important part of your counseling. And especially if you had bad asthma, it is important part, because as we all know, the thunderstorm asthmas and the environmental factors which lead to asthma deaths, and that the asthma deaths, the very severe ones almost always come in clusters, and that are due to environmental events, and that is important. But at the same time, if you were telling me that it will definitely fix the problem, possibly not, because it's not possible. And definitely for patients with anaphylaxis, it is very important, and especially because there are certain hidden allergens that we are now increasingly coming to know of, which cannot be tested by skin prick testing, right? So we spoke about alpha-gal yesterday. I'll be giving you an example of omega-5 gliadin. Those things you can't do. There is no skin prick testing extracts available, right? So for those things, specific IgE is important in terms of giving you that answer. As I said, chronic urticaria is a non-allergic condition. It is possibly immune-mediated, right? And they have found at least in 30 to 40%, if you did have a very high throughput, very high flying lab, you could find an antibody which was directed to the high affinity IgE receptor, but it is an immune-mediated condition which activates mast cells, not allergic. There are mixes available, as you know. Mixes don't have much of a role except for screening. So if you're doing maybe screening, we do lots of things in allergy also for patient preferences and what patient wants of us. If you don't do anything and tell them, look, I'm the expert and I'm telling you don't have it, they're going to go to the next person, right? So you might as well do the test and show them the negative values. And that is where I think the mixes end. Usually, if you are going to be more specific about your counseling, you should do a specific allergy testing or do an ISAC, which is becoming easily available, because that tells you about the individual allergens as well as the pattern of cross-reactivity. So when you find multiple pollen positives on your skin prick testing, it is not saying that multiple positivity is not relevant. No, it is because there is a single cross-reactive allergen. We know that there are about 89 grass species, right? But they share some common protein antigens in them. That's why they are grasses, they are not trees, right? So there is some phylogenetic relations. And there are certain preserved protein components in them, which are the ones that are responsible for cross-reactivity. So multiple positivities doesn't mean that they're not relevant. Multiple positive means there is a common protein component that is there in it. And you just need to tackle that one protein. That doesn't mean then that you have to make an extract which encompasses the full spectrum. Then you just pick the one which is most likely to have the highest concentration of that preserved protein across that phylogenetic species. Yeah? So it is important to have multiple positives. Don't disregard if you have it. You have to then explain it properly. Yeah? I'm going to skip all of this actually, because lots of this is based upon Australian data. I couldn't find anything specific for Indian data about what should we do for screening. But as I said, you should be knowing as to why you're ordering the test and obviously put it into the clinical context. There are cutoffs. I'm not going to go into detail of this slide, and this is there for teaching purposes, and you guys can read it later, is that apart from diagnosis, which is usually clinical, right? You would think that you had food and you developed you develop lip angioedema, you develop general, well, it is food allergy, right? It is your cow's milk allergy. Why do you want to even do it, right? No, it is important because that tells you whether you're going to outgrow or not. That tells you something as to how you're going to monitor later on. Whether you're, most of these, apart from peanut and seafood, you're going to outgrow, right? There is good 85% chances. And especially the pediatric allergies. If you developed an allergy as an adult, you are less likely to outgrow, but in pediatric, you won't. So it is important to do it. And there are some cutoffs established to demonstrate that at lower than that value, you might develop tolerance. And here again, that magical question comes in as to why, if there is specific IgE is still there, you are allergic to it before, you are still having this specific IgE, and now you are not allergic. And that is the biggest conundrum currently to be answered by the immunology allergy fields as to why that happens. So that means there is something else as well, right, which has to be host-based. And that also tells you that allergy actually is very environmentally based problem, right? So when we say, and as Dr. Rajendra Prasad sir mentioned about the family history being important in diagnosis, that is not because of genetics. So normally what we think that if your mom and dad is having allergy, you have it, that means it must be genetic, right? That's what patients think as well. You have to tell them, no. That's not the reason we are asking you that. That's because of the common environment that you are having a positive family history, right? If you have parents, siblings, you are living in the same household. That is not because of the genetic component. Your mom and dad having it and you having it, that is telling us you are living in the same environment. And there are elegant studies done about this, that there are two siblings, and especially from India, most of them from India and China, because we tend to be the most number of migrants in most of the other countries. So they've done these studies in UK and in India, that the siblings who stayed in India, they didn't develop allergy. The ones who migrated actually developed allergy. So there has to be environment. And this environment keeps changing, and that is what develops tolerance. And that's what needs to be worked out. And that needs to be borne in mind when you're looking at your specific IgE results. I'm going to just tell you last about tryptase, and then I can stop, I think. So tryptase, as I said, it is important because you can see the graph of histamine on the left. And as you can see, that's not clinically possible, right, to do anything within 20 minutes. And it peaks within 4 minutes and then starts going down. So it was not possible. But tryptase is now important because after its discovery by Professor Lawrence Swartz, it was 4 hours. So this was still manageable. And especially manageable when you can give it to the patient, right? So you can give a thing that next time you get a severe reaction, get this blood test done, if you think it is anaphylaxis. And as I said, it's very important to be done because it gives you a lifetime diagnosis of something that you can put, and you can rule out, your cardiac causes, and they won't require the loop recorders or go to endocrinologists to find out why they are having this unexplained fall or seizure disorder or something. So it is very important, okay? And lastly, as I said, the holy grail is still to find out why you have all this and it's still not firing up, right? And we don't have an answer to that. But we do have an in vitro test that can be used to make sense of this specific IgE molecule, which is what is basophil activation test, as I mentioned. And we've just published an article on it, and I've not quite a few articles because that is what my current grant is, which is, it is very simple. So what basophil activation test does, sorry, I don't have that. So you just isolate patient's blood, and this can be done on a whole blood. You gate your basophils, so that's the power of flow cytometry. That is the technique that has revolutionized everything, the workup of primary immunodeficiencies, and we all know about every small population that can be circulating, and hence we know so much about immunology. And the same thing here. So although basophils are only 1.5 to 2%, you can easily quantify them based upon the gating. And there are 3 different gating strategies. We use CD123 and HLA-DR negativity. You can gate them nicely, and then it is like doing a challenge in a test tube, basically, okay? So if you're peanut allergic, you have patients' basophils in the test tube, you put some peanut proteins on it, right? They should get activated, and once they get activated, there is this upregulation of CD63 molecule, which is present on the endocytic vesicles. So when these vesicles fuse to the membrane and release the contents, that is when the CD63 gets upregulated. Simple test, very simple. And you just measure the CD63 before and after incubation with that particular allergenic protein that you're thinking of. And if that gets upregulated in a significant amount, there are cutoffs abolished, well, at least you know that their basophils are getting degranulated. So that is more like functional testing rather than specific IgE, which we all know cannot mean clinically significant at times. So, think I can stop at that. Recombinant testing, so this is, I think, still maybe for the next workshop.
Thank you. Can we have the lights, please?
Science. So, any questions from the audience? Regarding specific indication of these kind of in vitro evaluation, where actually do we need to any questions regarding from the students? So let me put just one question, sir. Can you just tell in brief the in real world scenario the utility or the major indications of in vitro evaluation for allergy conditions? I would do it on all patients, even if you had, unless you had very extensive skin prick testing reagents available, you were very happy with your extracts, you had all those quality assurance steps in place to be confident about the skin prick testing that you're doing. This is for allergy practitioners, and I understand most of us are not. Like, I don't have skin prick testing facility, and I do an allergy clinic in Ahmedabad every 3 months. I would do specific IgE for all of them. For a patient of simple bronchial asthma, a patient with bronchial asthma comes to you, young male, who is reasonably controlled with inhaled medications. How would you put allergy testing in form of SPT as well as in vitro testing in front of that patient? If he's well controlled, I won't do anything. I would do it as Dr. Rajendra Prasad sir mentioned in his first talk, if there were seasonal variations, if he was using corticosteroids during springtime. Some of them, actually autumn ones are more important, as you know, for asthma, so I would be asking for around Diwali. And we keep telling in Diwali, whoever flares up is because it's suddenly become cold because of patake. It actually could be your pollens that are pollinating during autumn time. So I would do it for that. And, but I would do that only if his asthma was not well controlled with dilators. I would leave it otherwise. But in general, recommendations for basic allergy, for basic screening and aspergillus specific IG for aspergillus fumigators is recommended in all patients of bronchial asthma, all patients. Who? So, which recommendations are this? ISHAM, International Society for Human and Animal Mycology, guidelines for ABPA. So, mycology, yeah, I can understand those guys making up guidelines for aspergillus. No, I wouldn't think my clinician would do an aspergillus IgE. Gina doesn't say that, I think. Gina says? No, that's only for difficult asthma. No, this is for all screening. The prevalence, you know what is the prevalence of aspergillus hypersensitivity? Is 35%. Yeah. 35%. And in but how is that? The prevalence of ABPA is 25%. Oh, yeah. If you are suspecting severe asthma or ABPA, yes. But for any asthma screening, for any asthma. Look, I'm not across asthma literature, so I take your point. Yeah. And once you have excluded house mite, dander, and common allergens, then allergy testing has to be recommended for patient with asthma, otherwise not. So, as an expert of allergy, I would, in fact, we want to learn from you that in what conditions allergy testing should be recommended, should be taken as a second number after ruling out several conditions, and some conditions where it should not be done. Like there is red, green, and orange. Yeah. So I've told you my views on asthma. I wouldn't difficult asthma or seasonal asthma requiring systemic, I would do it. Atopic eczema, I wouldn't do anything. So these are the common conditions where we get referred to. I wouldn't do anything. So the most important thing I would do is allergic rhinitis, severe. Allergic rhinitis with asthma. So CRS, I wouldn't do it. So CRS with nasal polyposis is another mediator, and we talked about the type 8 allergy yesterday. So that is mediated by totally another pathway, which is aspirin. As you know, 80% of them are aspirin exacerbated diseases. So, but a chronic garden variety CRS with nasal polyposis, I wouldn't do allergy testing. That doesn't mean anything. No intervention has worked ever. And people have found biofilms and people have found, fungus growing and everything. That doesn't work at all. So CRS with nasal polyposis, I normally won't do anything. CRS with nasal polyposis, one thing I would do is immune workup. because lots of them turn out to be having some form of immunodeficiency as well. But allergy worker, possibly not. So allergy, I reserve it for allergic rhinitis, asthma, unexplained episodic symptoms, which might be just respiratory. Even then I would do it. If they are full-blown anaphylaxis, obviously you would. But yeah, recurrent acute urticaria, most certainly, definitely you would do it, yeah. So those are the conditions. But for your garden variety asthma, garden variety atopic eczema, garden variety chronic rhinosinusitis, nasal polyp, possibly not. If I was struggling with management or something, and if I'm looking at the ends of the threads, then possibly if they are very difficult to manage, I might do it to find out that one more inciting factor. Garden variety of these conditions, I wouldn't do any testing.
Basically, unknown allergy, if somebody presents with manifestations of allergy, as you said in the semantics, let me be corrected this time. So, unknown allergies without any known triggers, and which is really, disturbing the lifestyle of a patient, and allergy testing should be undertaken.
Yes.
In an unknown allergy, when maybe you are not able to point out in the lifestyle after digging into the history in detail.
It depends upon the symptoms, as I said.
Which test?
Depends upon the symptoms, as I said. You're talking respiratory symptoms?
Are mostly cutaneous and
respiratory.
spasm, rhinitis, lacrimation, cutaneous manifestations. So in these patients, what kind of comprehensive allergy testing should you?
So this would be like rhinitis, right? Yeah. And if you suspect any rhinitis, before you call it allergic rhinitis, you have to do allergy test, as I keep saying. So you can put A before R rhinitis only if you've done an allergic test. Because lots of people, and especially in India, I have found, lots of them are vasomotor rhinitis. So in those cases, all cases of rhinitis, I would do it, regardless. Because you have to, that is part of this subclassification of rhinitis. Whether you call it vasomotor or whether you call it irritant or whether you call it allergic, you have to do allergic test to call it non-allergic rhinitis. So yeah, all rhinitis I would do it.
Can this replace skin testing?
Skin prick testing is a money maker for allergy practice.
No, scientifically.
So,
thank you for enlightening us with your valuable experience and insights.
we don't have all extracts, all specific IG available to everything. So lots of times we do.
And cutoffs also are not defined for various populations, and cutoffs are not available for Indian population for various things.
But that's
also a problem.
Yeah, that's true for skin prick as well, though.
Yeah, exactly.
Yeah. But skin prick you can do with anything. Like you can do a fresh allergen and you can do it.
T.
In certain situations where you are not clear, then you can go for
That's because many a time patients keep coming and asking us and try to see whether we should start testing.
Do you want them to bring it in?
Nobody is actually interested in anything beyond.
Side of the organizers is that it would be great if you could, other than your washroom break, bring in your teas and then we can continue with it, so we save at least 10 minutes on that. And thank you all for a lovely hearing.
I request all of you to please settle down so that we can start our next session on time. And for chairing this session, I would like to invite Professor Amita Agarwal ma'am. She is professor and HOD in the Department of Clinical Immunology and Rheumatology at SGPGI. And to co-chair the session, I would like to invite Colonel Dr. Vikas Pathania sir, professor and HOD of Dermatology at Base Hospital.
Important speaker for the next session. Dr. Digambar Behera. I don't think anybody in this audience don't know him. I have known him for almost 40 years, and he has been the backbone of Department of Pulmonary Medicine at PGI Chandigarh for a decade. He also spent 5 years in Delhi and transformed the institution where I used to go and see patients with tuberculosis when I was doing my undergraduation. And that institution has absolutely changed. So he has done remarkable jobs. And he's a very simple, if you see him, you won't make out that he has so many accolades to his career and to himself. And the talk which has been given to him is also very important. And all of you are waiting for that talk, because most people nowadays, the youngsters, because I see 90% are youngsters, they all want to prescribe biologics. So I think Dr. Behera is going to put it in perspective, when to use biologics in patients with allergic disorders. Over to you, Dr. Behera.
Yes, thank you, Amita, and very good morning to all of you. In fact, the topic which is given to me, it was really took some time for me to clearly understand the heading and what I should speak. But anyway, I think as Amita made it very simple, so I am going to talk to you about the biologics that is to be used or they are used for the allergic diseases. And actually my focus of my talk will be bronchial asthma as an example, although I will try to touch upon other allergic problems. Can I adjust? Sorry. ये हो नहीं रहा है. Not moving. Not moving. Yeah, so I am not going to, I'll just skip some of the initial slides because you are all hearing what is allergy and then the burden of allergic diseases both in the world and in the country here also. All the allergic diseases, they are all increasing, that we all know. And then these are some of the common allergic diseases that we know of: allergic rhinitis, bronchial asthma, food allergy, we have skin allergy, drug allergy, insect allergy, anaphylaxis, and so on. And these are the different, this is the prevalence of different allergy conditions in our country, but I think that is not very specifically relevant to my talk, so that I'll just skip. And allergic march already you have heard from my earlier speakers. So basically the allergic lung diseases for a pulmonologist these are some of the common allergic lung diseases. Of course is the bronchial asthma, then the others like lupulars, tropical pulmonary eosinophilia, ABPA, hypersensitivity pneumonitis, particularly the extrinsic allergic alveolitis, then the chronic eosinophilic pneumonias, then the bronchocentric granulomatosis, idiopathic hypereosinophilic syndromes, then the Church-Strauss or the eosinophilic granulomatosis with polyangiitis, and of course bronchial asthma. And there are other types of eosinophilic lung diseases also which are part of allergic diseases. When we start with the allergic diseases, you see the basic thing, this cartoon, I have just tried to show you the allergic inflammation, then there are certain cells and then some cytokines. Actually, they play important roles in bringing about the allergic inflammation. And therefore, the biologics are then some drugs which are specifically targeted to these cytokines or these cells. So they should be effective in tackling with allergic inflammation. The entire slide tells that, and that the individual cytokines, etc., will come subsequently, and then the biologicals are about this. Some of the specific cytokines are taken care of, are handled by these biologicals. So that is the basic thing about this, although it looks a little complicated. So biological agents are a rapidly expanding class of medications that accounts for about more than 20% of all drugs approved annually by the US Food and Drug Administration since 2014. So they are very rapidly expanding group of drugs. The monoclonal antibodies constitute the majority of these biological agents which are approved, and there are several options are now available
for the management of allergic and immunological disorders. They include diseases like moderate to severe persistent asthma, then chronic sinusitis with nasal polyps, then chronic spontaneous urticaria, then hypereosinophilic syndrome, and eosinophilic esophagitis. So there are several factors must be considered when you are initiating and monitoring therapy with these biologicals. So as the asthma, when as I told you, I'll focus, I'll put this as an example. So asthma, it is a common chronic inflammatory condition of the airways, and about 350 million people globally have got bronchial asthma. And in India, it exceeds that of HIV and TB. This is the number I have just given about that number. So the goal of management is the disease control by reducing the symptoms and exacerbations. And then second thing is reducing the corticosteroid related morbidity, because that is another drug which is very commonly used or abused in this country. So there is an issue of corticosteroid related morbidity also. Then the repeated exacerbations and persisting symptoms of asthma that requires management with the repetitive bursts of oral glucocorticosteroids or maintenance therapy with oral corticosteroids, and asthma which persists despite adequate therapy with long-acting muscarinic antagonist, long-acting beta-2 agonist, and high-dose inhaled glucocorticosteroids, that is termed as severe asthma. That we'll see in subsequent slides. And here comes the role of biologics in this type of, or this subtype, or this variety of bronchial asthma. So this is again a brief the same thing again, which I said, this is just a cartoon. As you can see, have I got it? Sorry. As you can see here, this is the airway epithelial cell, and then we have got the allergens. There are of course other things, but if you focus with the allergens, then there are different types of cytokines are there involved, and then various cells. As you can see, the important cytokines here are the interleukins, and the interleukin 4, 5, 13. So these are the three important cytokines. There are also other cytokines, but some of these drugs, they are specifically directed towards these interleukins, particularly IL-4, IL-5 and IL-13, and then some of the other types like, say for example, thymic, that what we call as the TSLP, or the thymic stromal lymphopoietins. So these are the 4 or 5 important cytokines against which these biologicals are developed or they are available. So these are the FDA approved indications and dosing of biologics. They are used in the various allergic and immunological conditions. There are about 7, the omalizumab, mepolizumab, regeluzumab, benralizumab, dupilumab, then tezepelumab, and then tralokinumab. So these are the 7 different types of biologics, and these are the, for different conditions they are available. Say for example, omalizumab, so it is for the, the chronic spontaneous urticaria, or the CSU, which is refractory to H1 antihistamines, usually indicated for people more than 12 years, and it is IgE-mediated allergic asthma, not controlled by inhaled corticosteroids, and the age group is 6 years and above. Then the third indication is nasal polyps, not controlled by inhaled corticosteroids, and in adults more than 18 years. Then the mepolizumab is again recommended for EGPA or the Church Truss in people above the age of 18 years. Then the hypereosinophilic syndrome, nasal polyps, and then severe eosinophilic asthma in patients who are 6 years or elder or more. Then the regeluzumab, I'll tell them what is their mechanism and how they act. We'll come to that little later. Then Resiluzumab, it is in severe eosinophilic asthma in persons who are 18 years or more than that. And then Benralizumab in severe eosinophilic asthma. Dupilumab, it is a moderate to severe eosinophilic or steroid-dependent asthma, 6 years and above. And then moderate to severe atopic dermatitis, not controlled with topical therapies. And then chronic rhinosinusitis with nasal polyposis. And then eosinophilic esophagitis. And tezepelumab again in severe asthma. And then tralokinumab in moderate to severe atopic dermatitis, not controlled by topical therapies. So these are the important biologics. They are being approved and they are of the various conditions, as you can see. And then the next column shows you the dosing and the route. It is not possible to go on reading everything, but the more important ones we will discuss later. And then they have got a black box warning, although by and large they are safer drugs, but some of them one should be careful about, the anaphylaxis. So this is how this slide shows how they are to be given. Many of the things I have already told you, and then these are the drugs and how they exactly do, how they reduce, what is the mechanism of action, and how what are the different type of things they bring about. So therefore, what we have discussed about, so the discussion point will be mainly focusing on the asthma and eosinophils, then what is severe asthma, the inflammatory pathway, and what does the guideline suggest, and choosing the right biologic for the, severe eosinophilic asthma. In the asthma, the broadly we can divide it into the middle of it. You can see it is a healthy bronchial epithelium. That is all. It is all perfect. But we have got two extremes. It is eosinophilic asthma, or there can be non-eosinophilic asthma. Then the eosinophilic asthma, it can again be allergic, or it may be non-allergic eosinophil type of inflammation. And in a non-eosinophilic asthma, we have got pussy granulocytic type, or then the T1, T17 neutrophilic inflammation, and then there is a variety that is called mixed granulocytic inflammation. And mainly for today's discussion, we will be confining to the eosinophilic asthma. And the allergic type of eosinophilic inflammation, it is we have got these important players are the anti-interleukin 5, these are the drugs, and then anti-IL-4 receptor antagonists, and then anti-IgE, and then anti-thymic that I was just telling in the lymphopoietins, then anti-IL-33, and then the anti-S2, and then anti-IL-13, because 13, 33, there are also other important cytokines. Then the ones which are shown in blue, actually drugs for those or the biologicals, for them are already available therapeutically, and the green ones and the yellow ones, they are under the process of development or they are under trial. They are not yet available for the therapeutic use. So again, it is the same type as I have shown. It is only there are so many cytokines, and the important ones I have already told you. So then some of the terminology we have to understand, that is uncontrolled asthma. There will be frequent symptoms and there are flare-ups, particularly the exacerbations. Many of these patients may potentially have mild asthma. That means their asthma could be well controlled with low-dose corticosteroid if taken regularly. Then there is a type which we call difficult to treat asthma. That means the patient is not difficult, but the asthma is uncontrolled despite prescribing high-dose preventer treatment. The contributory factors may include incorrect diagnosis, incorrect inhaler technique, poor adherence, or the various comorbidities associated with the bronchial asthma. Then the severe asthma, actually, it has got many different meanings. So now it is defined as asthma that is uncontrolled despite maximal and optimized therapy and the treatment of contributory factors. You have taken care of that, or that worsens when high-dose treatment is decreased. So this is and therefore they are relatively refractory to corticosteroid also, although they are rarely completely refractory. So it is a retrospective definition, depends on how thoroughly the contributory factors are excluded. So this if you see the GINA guideline, where this is the step care management guideline, so only when the patient reaches the step 5, so and then where there will be add-on LAMA, or when the patient is referred for assessment of the phenotypes, and there the biologicals are to be actually to be used, or they are indicated. And then at this stage 5, in some cases in step 4, so then we call it severe asthma. That is a very simple type of definition of severe asthma. You can remember that. So this is a finding from a Dutch population survey of peoples when in a population of asthma. On the first side you can see most of them will be controlled, but about 24% of them, about a fourth of them, they will require GINA step 4 or 5 treatment. Then out of that, among these step 4 or 5 treated or who require this treatment, so there will be 17% of them will be difficult to treat asthma. That means despite GINA step 4 or 5 treatment, their symptom control will be poor. Then amongst these 3%, among these patients with difficult to treat asthma, about 3 to 4% will have severe asthma, meaning thereby they will have GINA step 4 to 5 treatment. They will have a poor symptom control despite good adherence and inhaler techniques. So this is how, that means a subset of patients of bronchial asthma overall, they will having severe asthma. That is about roughly 5%, or you can say 5 to 8% of these patients. So then what is that, as you can see, if you have got about 340 or 350 million people with asthma worldwide, so that means around 34 to 35 million, that is 1 in 10 with asthma people will have severe asthma worldwide. That will be the overall burden. So the clinical outcome of this severe asthma will be that there will be having a lot of difficulties. They will have more frequent exacerbations that will result in 10% risk of hospital stays, 8%, 8 times more risk of deaths. There will be significant poor quality of life. So patients with these severe eosinophilic asthma, they are up to more than 5 times likely to require the health care. They take care of all the health care facilities because that will be diverted for them. So therefore, these people require something, and there comes the role of the biologics. So here, this one again shows another recent study that again shows that of these whole asthmatic patients, the prevalence and the characterization of eosinophils and non-eosinophilic severe asthma phenotypes, you can see most of these severe asthma phenotypes will be by and large eosinophilic. About 84% of them will have eosinophilic inflammation, and then the non-eosinophilic will be least likely, and the likely eosinophilic, that means most of them, as you can see, they will be eosinophilic type of inflammation in these severe asthma patients. So this is how will be the distribution, both the allergic, non-allergic and eosinophilic type. That means most of these severe asthmatic patients will be eosinophil type asthma. Then the question is therefore, is eosinophil a right marker for severe asthma? Yes, we know that these eosinophil impacts the severe asthma in different ways through the IL-5 and other eosinophilic activating cytokines. You can see IL-4, IL-13, B cells, IgE, so that lead into inflammation, and then the non-immune effects will be also, they will be brought about by the eosinophils. So the prevalence of eosinophilic and non-eosinophilic phenotypes in the population with the asthma, most of them will be eosinophilic, as you say. So again, you see patients with elevated eosinophils, they have got frequent, there will be increased risk of severe exacerbations, their control will be decreased, and the overall asthma control will be very poor. You can see in the extreme right hand side, there the lung function also will be very poor. So the presence of eosinophils in a case of severe asthma or in asthma, they will have this type of clinical effects. So this is the Indian data that suggests that about 50% of the severe asthma patients are eosinophilics. So this is what is the distribution, that is the importance of eosinophils. Then the second thing is the severe asthma pathways. We have now, it is called as the type 2 inflammation and the phenotypic characteristics of asthma. So the type 2 high asthma, they will have cytokines like IL-4, IL-5 and IL-13, whereas the type 2 low asthma, they will have a different type of phenotype. Like say for example in type 2 high asthma, there usually blood eosinophilia will be there, more than 150 cells per microliter. Then there will be elevated tissue eosinophilia. There will be elevated serum IgE, surpassing the normal range. There will be elevated pheno, and the upper airway comorbidities including allergic rhinitis and chronic rhinosinusitis with or without nasal polyposis. And then there will be other type 2 comorbidities that includes eosinophilic esophagitis and atopic dermatitis. On the other hand, in a type 2 low asthma, the blood eosinophil counts are usually less. There will be sputum neutrophilia instead of eosinophilia. There usually obesity associated asthma is also, it is a type 2 low asthma, and they will have a poor response to corticosteroids. So this is how the T2 high, they are commonly severe. There will be more steroid responsive. They will have eosinophilic. There will be atopic or there will be IgE component, and the response to T2 inhibition is it is quite good. Whereas in T2, they may be less severe, but they will be poorly responding to steroids. There will be absence of eosinophilia. They will be linked to obesity or neutrophilia, and there will be poor response to T2 inhibition. Then these are the, so therefore there is a paradigm shift to a more personalized approach to asthma therapy. As you can see on the left hand side, we have got the traditional guidance-based asthma management, the diagnosis, the assessment and the stepwise approach, as I told you and showed you, the GINA approach most commonly. And then the personalized approach to asthma. After you diagnose, there will be a characterized subtypes based on the endotypic and phenotypic types, that is the sex, age, obesity, ethnicity, etc. And then some of the endotypes which are very important, that is the blood biomarkers in the form of IgE, eosinophils, then the periostins and other cytokines, if you can measure them, and the sputum biomarkers like eosinophils, neutrophils and cytokines. Accordingly, you will decide them whether it is T2 high or T2 low, and the others like pheno. So they will be so these are the group of patients where you can give this tailored therapy, and where the biologicals will be more useful, particularly the eosinophilic type of bronchial asthma. And then of course there is genotypic type that is no relevance for the clinical management. So beyond the elevated blood eosinophils and eosinophilic asthma, also there are patients which will have recognizable clinical characteristics, like those will have the eosinophils in the peripheral blood, frequent severe exacerbations, the response to oral corticosteroids, then chronic rhinosinusitis with nasal polyposis. If it is adult onset asthma, if the FEV1 is low, often with persistent airflow limitations. So these are some of the other characteristics of severe asthma or eosinophilic asthma or type 2 inflammation. So these group of patients will try to choose for a biologics when they fail or they reach into the the step 4 or 5. So so therefore the management, then the another important thing is the oral corticosteroid use. Most of these patients, they will require very frequent oral corticosteroids, and you all know this only shows the side effects of oral corticosteroids. So you have to avoid that, or there may be a time when there will be difficulty in using oral corticosteroids. So these will be another group of patients who will be benefited from the biologicals. So this is what the, I think, summary of when you will give these biologicals, but that I just require 2 or 3 more slides, madam. So there are now key changes to the GINA severe asthma guidelines. So that shows that anti-IL-4 receptor, that is dupilumab, that has been added for severe eosinophilic type 2 asthma. It is not suggested if blood eosinophil count is more than 1500. So dupilumab now also approved for children who are having severe eosinophilic asthma and those who require oral corticosteroid. Then the anti-TSLP, that is the tezepelumab, now approved for severe asthma, aged 12 years or more. There is greater clinical benefit with higher blood eosinophils and those who require oral corticosteroids. So these are the classes which I have already told you that can be anti-IgE, that is omalizumab, then anti-IL-5, that is mepolizumab, regeluzumab or benralizumab, these are 3. Then anti-IL-4R, that is dupilumab, and then the anti-TSLP is the tezepelumab. So these are the 5 or 6 drugs. And in India, we have got 3 biologicals that are available. That is the omalizumab, mepolizumab and benralizumab. So the indication for omalizumab is the moderate to severe persistent asthma, uncontrolled by ICS, those who are 12 years or more, and then if they have got positive for perennial aeroallergens. The dose is 75 to 375 milligram given subcutaneously. So usually the dose is weight-based and depending upon the level of IgE, the frequency is every 2 to 4 weekly. Then mepolizumab, as I told, it is anti-IL-5. It is add-on maintenance. Remember, these are add-on maintenance for severe asthma in ages 18 years or more with eosinophilic phenotypes, which I have just described. The dose is 100 milligrams subcutaneously every 4 weekly. Then benralizumab, it is again an add-on maintenance for severe asthma in people more than 18 years of age with eosinophilic phenotypes, and it is given as a dose of 30 milligram subcutaneously. So, so then the question, I think 1 or 2 lines about their safety concerns, because they have got anti-eosinophilics, and in our country, particularly there is a question of, whether there will be a flare-up of the parasitic infections or not, but actually it is not so, it does not happen. But even if to be more safe, whenever you are thinking that there may be chance of parasitic infection, usually it is recommended that the patient can be, dewormed before starting this therapy. Of course, there is some question of the recommendation of what should be the level of eosinophils, since eosinophilia may be common in some parts of this country. So there is some controversy what should be the exactly some debate, but I think if we follow the guidelines, if it is more than 1500 or so, so that is quite okay. So now I think I will stop here. So the biologicals are now available. They are used for specific indications as add-on therapy, and their mechanism of action, I told some of them. So which one, and of course for the timing we have got only 3 drugs, that is omalizumab and the other 2 drugs, mepolizumab and benralizumab. The point is, out of these 2 anti-IL-5 drugs, which is better, I think both having equal efficacy. The only issue is the cost. They are very costly drug. For even omalizumab, which was earlier costlier, now the cost has come down, but still many people cannot afford it. It still cost around 15,000 rupees will be costing per month. But the benralizumab and mepolizumab, they are still more costlier, so around 60,000-70,000. But question is, those who can afford, they can be used, and many people are using it. So the point is, there is something is available for patients who can be benefited with this. So I think I will stop here. If there is any comments or any clarification, that I will be happy to give you. Thank you.
Thank you, Dr. Behera. Any comments? Yes, Vishad.
Before starting omalizumab or other anti-IgE agents?
For any?
Like in biologicals, we screen for TB before starting anti-TNF. So similarly, any role for screening for helminths?
No, these things they don't go for the TB. There is no.
I'm not asking about TB, sir. Helminthic infections.
That's what I told you. Yes, helminthic infection, it is ideally to be ruled out. And I think for our country, most clinicians, they try to find out helminthic infection, or even, electively they deworm. Many people do that, but at least I don't do that. We don't give, because helminthic infections by and large, they are now coming down. And those where the helminthic infection will be more common, fortunately or unfortunately, they cannot afford this type of drug. So that is you have to think in that context.
Any more questions? So if there are no more questions, we will like to thank Dr. Behera, who has put in his last 3 slides, he has shown you what is the indication, what is available in our country, and what are the risks involved. So I think if you can carry home that 3 slides, it will give you food for thought. Thank you, Dr. Behera.
Thank you.
Moving on to our next speaker, it is said that skin is the mirror of the body, and it would be more apt in the balance of immunology and allergy. And one such challenging condition happens to be atopic dermatitis, which is seen a lot of strides in our understanding of the pathomechanisms and the new therapeutics evolving thereof. And to shed insight, we would have asked for a better person. I now invite the next speaker, Dr. Srivastava. Dr. Srivastava needs no introduction, but just to go through the motions, he is the leading consultant dermatologist of Lucknow. He is the alumnus of my college, the Armed Forces Medical College, and he's done his MD dermatology from PGI at Chandigarh. He has numerous publications in Indian journals, most of which are international repute. And he's got a triple figure invited lectures in various conferences, and I can vouch for him for his oratory skills, and I always look forward to hearing, and I'm sure you will also gain. And without much ado, I'll request you, sir, to bring your talk.
Good afternoon. Thank you very much, Vikas, for that kind introduction. With your permission, chairpersons. My job today is supposed to be current management approach to atopic dermatitis. And it's very fortunate that this audience has been primed by excellent lectures on dermatology's pathways and all the various mediators that underlie the type 2 inflammation. So I have vowed not to show you any cartoons with complex immunological pathways, and I'll try to stick to that. So atopic dermatitis, which is an interchangeably used term with atopic eczema, there is no difference between the two, is a chronic inflammatory skin disease characterized by either dry or oozy, itchy, scaly skin lesions in a characteristic distribution. This distribution varies with age. In childhood, most affected areas are the cheeks and the extensors of the arms and legs, and as the child grows older, it comes localized to the flexures, and in adults, typically the commonest sites that are affected are hands, feet, and nipples, and certain other flexures like ankles. The onset is bimodal. It either starts in infancy, so the vast majority will start under the age of 2 years, but it does keep sporadically, kids keep having onset of atopic dermatitis even in school age. And of course, there is another around a chunk of 30% or 40% patients of atopic dermatitis which have an de novo start in adulthood. And that is what complicates the issues of epidemiology, etc., because we exactly don't know how to define adult onset atopic dermatitis. That is one of the enduring controversies of dermatology, and if we don't know how to define something, we can't count it or know its epidemiology. But there have been some steps taken forward in this direction, and I'll talk about that. It has a relapsing and remitting course, and the basic problem is twofold. It is an immunological problem, which is a genetic tendency to mount a Th2 type inflammatory response to common environmental allergens, otherwise called atopy, which has been discussed in earlier talks today, and also a breakdown in skin barrier integrity. So this is also genetically determined. So they have mutations in filaggrin genes and certain other genes which are responsible for epithelial barrier production. So desmosomes, tight junctions, not those kind of things, but the envelope proteins of the keratinocytes of the skin. So they let in a lot of allergens which otherwise a normal healthy skin wouldn't, and that in a person who is primed to mount this kind of a response produce atopic dermatitis. But this is only again a initial part of a very complicated story. As they grow older, Th1 inflammation supervenes and the Th2 pathways kind of settle down, and it generally behaves like a type 4 hypersensitivity and a combination of type 1 and type 4 later on in adulthood. It is often accompanied by allergic rhinoconjunctivitis or rhinitis or asthma, and it may be intrinsic or extrinsic in type depending on whether the predominant problem in a particular person is this, which according to various studies is up to 30% of patients who have a predominant problem in the barrier function of the skin, and the immunological problem is secondary to it, and or otherwise there is not much of a problem in the barrier, but the predominant problem is the immune system acting up. This is what it looks like. So this is in around the age of 5 or 7 when you'll see typical flexural eczema. You can see lichenification where the skin markings become more prominent and skin becomes thickened. This child has very, very extensive eczema. And the other common sites affected are the front and sides of neck, front of ankles, back of the knees, popliteal fossa, etc. And of course, face also, periorbital eczema is also quite common. This is a milder case, and it's not projecting very well, but you can see excoriation marks in this young child, about 3-4-year-old child, and where they have scratched. And atopic dermatitis is famously called the itch that scratches. So the skin is inherently itchy. And the problem very often starts with the uncontrolled itching, and the eczema lesions appear later on. So the skin is inherently itchy, and it responds to itching due to exposure of various environmental stimuli, mental, psychological stimuli, and once the itching starts, the eczema follows. And that is why, as an axiom, you can say that if you control the itching very well, especially the milder types of atopic eczema do settle down pretty well. But it's easier said than done, but this is how it looks like in adults. I'm sure the rheumatologists here who keep seeing psoriatic arthritis patients will appreciate our difficulty in differentiating it from psoriasis. So it can look a lot like palmoplantar psoriasis. There are some subtle signs. The cracking and the scaling is a lot thinner and less deep than psoriasis. Itching is more, but these are all relative terms. I mean, every day I cross out my earlier diagnosis of palmoplantar psoriasis and put in a diagnosis of hyperkeratotic eczema and the other way around. So it's not very easy at all. Now this is a exemplification of what atopic skin is like. This man had extensive tinea, and the tinea is gone with antifungals, and these are the patches that you can see the tinea was. And now he has developed an eczema, which is almost clearly localized to the patches of tinea. Why is it there? Because he scratched his tinea because of the dermatophyte infection. And that, with the background of atopy, he had a history of mild allergic rhinitis. Now it has precipitated an eczema. And once we treat this eczema with topical corticosteroids, sure enough, the tinea will come back because it's just lurking there. It's an intractable problem these days, and we have a very, very resistant strain of dermatophyte going around for the past 10 years in our country, but that's another story. Complications of atopic dermatitis, this man has a herpes simplex infection. In addition, he has an erythrodermic atopic dermatitis. This is called eczema herpeticum. You can see these umbilicated papules, pustules, etc. on his face. And this can happen. It's very common because of the peculiar immunodeficiency and the type of response they put up and the barrier defects. They are very prone to both bacterial and viral infections. Molluscum, herpes, and of course, impetigo, etc. Now, one of the earlier studies, the pulmonologist had shown a very nice graph which showed the atopic march, which shows you a big peak of childhood food allergies, which comes down pretty quickly. Then another equally big peak around the age of 1 or 2 years, 3 years, 4 years, which shows the atopic dermatitis coming up. That peak is also shown to go down as the child grows up. And that was the traditional teaching in the epidemiology of atopic dermatitis, that the vast majority of children will outgrow it. And that's what we've been telling our parents of the kids who come to us and parroting like that most likely your kid will be okay once he grows up, becomes 5, 7, 8, 10, 12 years old. But not considered true anymore. We have a lot of conclusive epidemiological evidence now. Fortunately, we have some evidence from India as well, and we dermatologists can take no credit for it. The Global Asthma Network did the job for us. So this was a huge study that was published just last year, I think, which looked and community-based study with huge numbers of patients, you can see. And the prevalence of physician-diagnosed eczema was about 2.5% in 6 to 7-year-old kids, slightly higher in 13 to 14-year-olds, and this is where the surprise was, 9.9%. So, like I was saying earlier, the problem in diagnosing adult eczema is one of diagnostic criteria. There has been, and of course, serum and clinical markers. There's no consensus. That's why a lot of eczema that occurs in adults is dumped into a dustbin diagnosis. We used to call it endogenous eczema, or various other names are given to it. But it seems that atopic dermatitis really doesn't go away in a vast majority of children. It continues to come back in some form or the other. And these are the various disease trajectories that are now identified in atopic eczema. So the classical, like I said, early onset, relapsing and remitting course in childhood with a gradual remission in adulthood or in late childhood adolescence. The alternate one, which is the early onset, it can have a lifelong relapsing and remitting disease, and this is very common. A chronic persistent disease which never really goes away, needs almost continuous treatment, and of course there can be long periods of remission followed by recurrence at unpredictable times later on. And of course there's this huge other part of adult onset disease which often has very low eosinophils. Again, very hard to understand why it is happening. There are no filaggrin mutations in these patients also, but this also looks exactly like atopic dermatitis. Flexural and generalized, it can be localized to hands and feet, nipples, ankles and neck. It can be photosensitive, and it can present with just a prurigo lesions, which are those big papules which are excoriated. The comorbidities we all know. I've just highlighted a few of dermatological interest. Alopecia areata is very, very strongly associated in this forest plot. Vitiligo, strep throat, hand eczema, a whole lot of others. And of course, the classical triad of asthma, food allergy, and rhinitis is also pretty strongly positive. Odds ratios are 3, 4, and above for all of these. So these are markers. We diagnose it clinically. We suspect that there are endotypes of atopic eczema, like Professor Behera was talking about endotypes of asthma, but they are not well characterized, and a lot of work is going on serum markers. But now I'll stop about this. I'll talk about what I was supposed to talk about, which is the treatment outline. The aim of atopic dermatitis treatment is to improve the symptoms, which are mainly itch and skin pain, and of course thereby prevent complications and make the lives of the patients better. So the second is to establish long-term disease control, prevent complications, infections, and contact sensitization, which subsequently Sunil will talk about. And atopics are much more prone by virtue of their barrier defect to develop various types of contact allergies, which are type 4 reactions. So we can prevent that if we maintain the intactness of the epidermal barrier and do not allow them to get sensitized. So like avoiding piercing in childhood, etc. in atopic children is a good idea. Otherwise, they get sensitized to nickel and chromium. And of course, identify and manage those various comorbidities that I showed you in that forest plot. So it is a multidisciplinary management, especially in severe patients with atopic dermatitis. We need the help of an allergologist, pulmonologist, even an ophthalmologist, because keratoconus, etc. are also quite common in these children. And with the use of biologics, we get a lot of ophthalmic complications in patients who are given dupilumab. So the diagnosis is still clinical. There are a lot of very good, very well validated clinical criteria. The UK Working Party criteria are quite simple. The more comprehensive ones are SCORAD and EASY. And these are also severity scores. And the criteria are more helpful in children, like I said. In adult atopic dermatitis, still very few, till about 10 years back, there was even controversy whether it existed or not. And gradually we are learning to identify this new subset, which has an onset in adulthood. It can have an onset in 60s and 70s also. And so the essential clinical features are a chronic or relapsing eczema with characteristic morphology and specific patterns, like I said. The stage can be any, depending on how old it is, acute, subacute, or chronic. Th2 cells are the ones that are responsible for this, and the central symptom is pruritus. Pruritus provoked by trivial stimuli. So contact with clothes may provoke pruritus, which otherwise it wouldn't. And of course, early age of onset is a helpful sign, but like I said, the other group is there, adulthood. Atopy, personal or family history. Again, the problem of identifying what is atopy in Indians has been well said. We don't really have Indian criteria if you're going to do a study. We still use cockroach and a couple of grass allergens and do a skin prick test, but generally it's taken as a family history of if the parents have wheezing or asthma or an eczema, first degree relatives, then that's a very broad, crude way of saying it, but that's how we do it clinically. And there are various associated features, minor signs of dermatological signs. I won't bore you with that. There are a lot of minor markers of atopic dermatitis. So treatment starts as it is clinical. You have to take a good history of age of onset, etc., localization of lesions, rule out other things. But eczema is quite easy to learn to recognize. It's not that difficult. And the ferocious itch will often give it away. Few other conditions are as itchy as atopic eczema. We can score it if we want based on either our clinical impression or using any of these scores. And then we do the basic treatment, and this is the most important part of atopic eczema, because if you have a defective barrier, it is going to remain defective throughout. You have a genetic problem. So moisturize, moisturize, and moisturize. So the first 3 steps of atopic dermatitis care are regular and proper use of moisturizers all over the body. It's easier said than done. It can be very bothersome and irritating to the patients to do, but if they do it, then exacerbations are much more. Very, very well documented in history, in various studies. If you do this part well, you won't need to go down the chain in the vast majority of patients, say at least about 60 to 70% of them. So avoidance of triggering factors, identify them again by history. No reliable tests. Patch tests will not help you. Skin prick tests will not help you. It's already been said. In atopic eczema, even in chronic spontaneous urticaria, practically no role of allergy testing. And of course, the education on how to do the avoidance. That's the difficult part. How do you avoid an environmental allergen? Topical calcineurin inhibitors have been a godsend. So topical tacrolimus and pimecrolimus do very well in atopic dermatitis as alternatives to topical corticosteroids, which still remain the mainstay because these are usually not as potent as the most potent steroids. And of course, active treatment is done as needed and then gradually tapered down. I'll talk about this a little bit. Systemic treatment, the number one conventional drug that we have is cyclosporin. We try to avoid oral corticosteroids in atopic eczema as much as we can. And we strongly recommend against their use because cyclosporin is almost as fast acting and as effective as steroids, and should be stopped after the acute exacerbation, but works pretty well with less of problems compared to, and especially in children, it is fantastically well tolerated. We can really give higher doses and they do very, very well with cyclosporin. Short-term steroids can sometimes be needed, and of course, azathioprine, mycophenolate, methotrexate, etc. are all used. Phototherapy can be done if the facilities are there, but difficult to do. You have to come 3 times a week to the clinic and take the phototherapy. And the rays that are most effective are the UVA1 rays, for which the equipment is fantastically expensive. I don't think anybody has it in India except 1 or 2 machines. Allergen-specific immunotherapy has a very small role in a subset of patients where you have clear history that the eczema aggravates after a particular food or an exposure repeatedly and reproducibly, and if you can show it. Otherwise, no real role, and there are, of course, biologics are there. Dupilumab is the main one. So the best way to treat atopic dermatitis, like I said, is proactive treatment. So every patient recognizes his or her hotspots for eczema. They know that if your eczema is going to flare up, which sites it usually comes back. It might be the neck, it might be the antecubital fossa or the popliteal fossa, and a proactive application of a topical calcineurin inhibitor or a topical corticosteroid to those sites maybe a couple of times a week in patients who relapse frequently is a very good way in conjunction with regular use of moisturizers. And of course, there are a lot of adjunctive treatments with relatively poor evidence, except for vitamin D, which seems to have good evidence for almost everything under the sun these days. So these are the various things that you need to take care of provoking factors. The skin irritants, the number one are soaps, detergents, and antiseptics. So the common practice of adding a bit of Dettol or Savlon to your bath water or hand wash water, and of course it has wreaked havoc in atopics due to COVID because of the hand washing epidemic. And now we are furiously telling our patients to stop washing their hands, because we get bloodied, horrible eczematous hands coming because they are the habit of sensitizing and washing, and all subclinical OCDs have surfaced because of this COVID, and our atopics are unfortunately bearing the brunt of it. Like I said, itch is the preeminent symptom. It makes life miserable. So itch control, again, this is the single most effective way to control itch, because unfortunately it doesn't respond very well to antihistamines. They are prescribed universally by almost everybody, but there is evidence to show that except for the sedating part, maybe it dulls you down, you go to sleep, you don't scratch. Even that doesn't happen. There is nocturnal scratching. So they don't really work. So moisturizer, topical cooling lotions that contain these things, topical antipruritics are there, but this kind of stuff can cause contact sensitization. Doxepin typically is well known to cause type 4 sensitization and then cause contact dermatitis. But pramoxine is good, diphenhydramine is good for short-term relief topically. And of course, avoidance if a patient, so there is a term called atmocnesis. This typically history patient, atopic dermatitis patients will give you when they're changing clothes. When they take off their clothes and the skin comes in contact with room air, the itching starts. And by the time they've put on their night suit and all that, the itching goes on and then it settles down in 20 to 30 minutes. So this is another minor marker of atmocnesis. So any kind of pruritogenic stimuli. So they can close themselves up in a warm bathroom or a toilet or somewhere where there's no breeze blowing and then change their clothes there, etc. A lot of these things have to be devised based on their particular triggering factors. And of course, control of eczema is the best way to control the itch. So treat the eczema aggressively, the itch goes away. Topical corticosteroids are the backbone. I will not bore this audience with the details of topical corticosteroid use, but it's very important if you want to learn to treat atopic eczema. So the right molecule, the right formulation, the right pack size even, because they won't go and buy it again once the itch goes away and the eczema has not gone away completely, so it's going to come back. Designing the right regimen, various modifications are there. Just a little bit, how potent do you want to use, sensitive skin areas, duration of application. Occlusive dressings are sometimes very helpful. How much to use, this fingertip unit method is a good way of telling our patients how much steroid to use so that it isn't absorbed and they don't get Cushing's and all the other problems, which is surprisingly common with topical corticosteroid use. We did a series of 8 AM cortisol levels in patients who were using just topical steroids, and we were surprised to find so many unrecordable levels. So this is basically learn to taper, become comfortable with 2 or 3 molecules of topical corticosteroids, how potent they are, how well they work, and then you taper slowly, or you can make it alternate days, or you can start combining them with topical calcineurin inhibitors so that you gradually shift them from steroid to the calcineurin inhibitors, which are safer in the long term. So this is how we manage it in the long term. Wet dressings, I'm sure outside of a dermatology, even dermatologists don't do it, but they are extremely effective. They can, make your cyclosporin, etc., all beat them, but they're difficult to do. You need to put the child in a hospital, apply a lot of moisturizer and a very weak steroid all over the body, cover them up like a mummy in some clothes for an hour or two. Voila, magic, in 2 days the eczema goes away. So it's an inpatient treatment, difficult to do, but very, very good if you want to avoid systemic immunosuppressants, etc. The same principle can be applied to these are called prurigo lesions, which are very common in atopics. Ferociously itchy lesions, and the patient keeps scratching them like that. You can see they're all excoriated by the patient's nails, and the eczema perpetuates. So you can cover them with a bit of polythene, and the steroid penetrates well, but it has to be done carefully, otherwise you'll get too much absorption. Of course, these are extremely common. That's why I always put a slide of this. Please do not use corticosteroid antibiotic combinations. Because of the skewed pharmaceutical policy of our country, unfortunately, these tubes cost half as much. The same steroid, if you add gentamicin to it, DPCO makes you sell it for 10 rupees. If you don't add gentamicin to it, sell it plain, you'll have to sell it for 50 rupees. So this kind of perverse incentives have been given for irrational combinations. Try to avoid using them because antibiotics are also sensitizing, and atopic children are more prone to get allergic sensitization. So use plain steroids. If you have to use an antibiotic combination, make sure that the lesion is actually infected. There are signs of infection. So there is heat, there is pain, there is pus, there is a yellowish crust, etc. Then you can use it for a short duration. Otherwise, try to use oral antibiotics if you're sure. And there are excellent studies that show if you just do a swab, atopics are heavily colonized with staph, and it's just sitting there doing nothing. So if you do a culture, you'll think, I need to give anti-staph antibiotics, but treating them with plain corticosteroids is as effective as using combinations. Topical corticosteroid allergy, again, a niche topic. I won't go into this, but it can happen. Please remember, if your eczema is not responding or responding suboptimally, they might have developed allergy either to the drug itself or to the excipients in the formulation. And there are ways to patch test it, which I'm sure Dr. Sunil will tell you, which you can pick this up. This is the biggest problem these days. 20 years back, we didn't have it, but with the onset of internet and Instagram and various forums, the first for dermatologists, I don't know how is it with you guys, but for me, when many times internet savvy patients sit down on the stool, the first question is, steroid to nahi doge, otherwise I'm going out. So, and when this is the backbone of your therapy, it becomes slightly difficult. So, but again, counseling is key. You can bring them round. You have to educate pediatricians and GPs as well. There are various false beliefs. Women have hand eczema, they apply a steroid ointment, then they have to go into the kitchen. They immediately wash their hands a lot with Dettol, and then they think this is some kind of poisonous thing that might poison my food. So all those things have to be tackled, otherwise it doesn't work. Topical calcineurin inhibitors are very, very helpful. Please learn to use them. The only downside is a bit of burning sensation that is caused in some patients on initial application. It goes away in the vast majority, and a simple hack is to put it in the fridge. If the tube is kept in the fridge, the incidence of immediate burning on an acute eczema goes down drastically. Much safer than steroids, very good for long-term use. We have had crisaborole ointment now, which is a topical phosphodiesterase inhibitor, in our hands for the last about 6 months. It is less effective than steroids, has some of the kind of burning sensations issues, but is again helpful because anything that can minimize the use of topical steroids is good. Topical JAK inhibitors have come in. We only have a tofacitinib ointment, although ruxolitinib and delgocitinib are available in Japan and Western countries. They are some of the most promising drugs which we are hoping to get in our hands soon. They are almost equally as potent as steroids and much safer so far, as we can make out. Systemic therapy, this is our #1 drug. It works very, very well. We tend to use it in short bursts, not more than 3 or 4 months at a time, for obvious reasons. But methotrexate and azathioprine work very, very well as well in resource-limited conditions. They are a little bit slower, so you have to make do with your steroids and moisturizers and a lot of hand-holding and antihistamines in the beginning. But once the initial 4 weeks are over, they can do very, very well in patients who can't afford cyclosporin or biologics. Mycophenolate is not that great in eczema, but it can be worked if you have contraindications. So since my time is up, I will just rush through this. I've already talked about this. So various monoclonal antibodies, Professor Behera has given you an excellent overview, and he talked about AD indications as well. So these are the ones. Dupilumab is the one we have available. Unfortunately, it costs a lot, but we have Indian experience. It works very well. The only significant adverse effect is conjunctivitis that occurs in about 25 to 30% patients, but is well manageable with artificial teardrops or with mild steroid. Of course, abrocitinib is going to come into the market. This is the Indian experience, which was published last year by our colleagues from Kolkata on just about 25 or 30 patients. Because the therapy costs about 60,000 rupees per dose, so about 1.2 lakhs per month. But they still managed to get 25 patients, and you can see the fantastic results. This child has erythroderma, and these are post treatments. JAK inhibitors is mostly with tofacitinib, which is off-label, works very, very well to control the itch. In about 30% of the patients, the response is magical. Within 2 days, the patient says dramatic relief from itching. but not all. So obviously we have to identify the endotypes, where to give them. Prurigo lesions just seem to respond very well. Abrocitinib is coming next month. It has very promising data, better than tofacitinib, a little bit more selective, but we don't know about the side effects, whether it's actually safer or not. So with that, I thank you very much for your attention. If there are any questions, I'll be happy to take them.
Thank you, sir, for a very lucid talk and very comprehensively covered. Sir, there was a transient failure for omalizumab for those subsets with high IgE and IgE. Any experience which you might
Yeah. Yes, I have given it to 3 or 4 difficult patients of atopic dermatitis, and a couple of them have done very well. But again, the problem is identifying those who will do well. We don't know the serum markers. IgE levels don't seem to help. One of the patients who responded very well to omalizumab had IgE levels under 50. So it's worth trying in desperate situations. It does help, but of course not as effective as dupilumab. Dupilumab, you will get remissions in almost 70%, 80% patients. But yeah, worth trying if you're stuck.
So if there are any questions from these two?
Thank you, sir, for the lecture. One comment and 2 questions. When you said you won't bore us with the details of topical steroids, did you mean you won't give us the secrets?
Oh no, I'll be happy.
Anyways, we won't be detailing.
I'll be happy to talk about them for an hour.
No. So 2 questions. One is, this topical tacrolimus, can they be called as steroid sparing topical therapies and used upfront? And second, oral tacrolimus side effect profile is slightly better than cyclosporin. So how do you place that?
Yeah. So topical tacrolimus and pimecrolimus do work well as upfront therapies for mild eczemas. They're not potent enough to control the worst ones. We have very potent steroids, clobetasol and halobetasol, available to us, which are very powerful. So the potency issues are there, and the issue of an acute eczema, once you apply a TCI on it, about 40% of the patients have that burning sensation issue. So yes, they are steroid sparing drugs. We do use them like that. I showed you some ways to taper down and bring them into the therapy and get your patient off steroids. That's how we use them, and they're very, very useful. What was your second question? Oral tacrolimus. Somehow oral tacrolimus has not been tried as much in atopic dermatitis as we would like to. I have given it to a couple of patients. It seems to work pretty well. It is safer than cyclosporin, but I don't know why. There were some studies that showed it doesn't work as well, but frankly, the literature is not there. Somehow it's not been tried that much. But it should work, and from personal experience of just 1 or 2 patients, it does seem to work.
Any other questions? If there are any more questions, thank you, sir.
Thank you. Thank you very much.
So now moving on to another skin problem. We have Dr. Sunil Kumar Gupta, who's an associate professor at All India Institute, Gorakhpur. And he is going to talk to us regarding contact dermatitis.
Chairperson, a very good afternoon to all the faculty and the delegates present here. And in the continuation of the atopic dermatitis, now another important aspects in dermatology clinic is the contact dermatitis. Most of the time we say that this patient complaining itself that, sir, I am suffering with some allergy, or we are suffering some itchy conditions, and what is the allergy? What are the allergens that causes this problem? So it is very important to understand, is the patient really suffer from allergy or contact dermatitis or any other things? When we talk about the allergy, the whole things, each and everything in the world can cause allergy, even the human beings. So it is very important to know. So the outline of this is analysis of contact dermatitis in clinical way and the identification of the triggers and how to avoid those. So on background, the contact dermatitis is a common inflammatory skin disease affecting more than 15% of the adult general population worldwide. And in our OPD, we are seeing 4 to 7% of the conditions. We are know very well that there are 2 most common contact dermatitis that termed as allergic contact dermatitis and the attenuated contact dermatitis. And those are due to some repeated exposures or due to intense irritant. Even allergic contact dermatitis sometimes occur due to inhalation or injections. And there is another term that is known as the protein contact dermatitis that occur due to frequent touch with food that causes type 1 allergy first and later change into the contact dermatitis. This is a very simple diagram showing how contact dermatitis or allergic contact dermatitis or irritant contact dermatitis develop. The outer material, the substance that come in contact with the skin is most of the time same, but it is the media or surrounding or environment that it change into the haptens or into irritants, and that change and causes either irritant contact dermatitis or allergic contact dermatitis, and that may change. Why allergic contact dermatitis occur? We understand our body just like a UPS, and when any USB or pen drive come in contact with the UPS record the whole the data of that pen drive. Like that, the skin also record each and everything on the surface that material come in contact with that, and after that, that is recorded in the memory. And that memory is turned into the resident memory T cells. This actually the memory T cells, resident memory T cells, that ultimately results into the allergic contact dermatitis in future. So when patient develop with contact dermatitis, the most common feature is the erythema, edema, vesicles, oozing, and of course the notably intense pruritus. There are so many conditions, but when we talk about the ectopic allergic contact dermatitis, the allergen reaches the patient's skin by exceptional routes. It may be due to autotransfers, like with nail lacquer located on the eyelids or on the neck, transfer by fingers. It is very common in females. Most of the times females using a different types of nail polish, and specifically the one dangerous is the black color of nail polish. And they most of the time with the nail touch her face like this or neck like this and showing their nail polish. With that, these nail lacquer and the chemical of nail lacquer is deposited on the face, and later that causes either irritant contact dermatitis or the allergic contact dermatitis. Even the heterotransfers, that the transfer of allergen to the another person, mainly the partner, is also occur, that is known as the connubial allergic contact dermatitis. We of course know the airborne contact dermatitis, so we should maintain a pollen calendar, because most of the time this is occur due to pollens in a particular season. But sometimes what happens due to some the puja materials like the sticks, the scented sticks, and even the havan samagri, and the women working in the kitchens and developing frequent vapors, that causes irritant and allergic contact dermatitis. So these are very important when you are searching for what is the precipitating or triggering factors. And photoallergic contact dermatitis, some of these chemicals are very sensitive, and when patient come in contact with the light, develop photoallergic contact dermatitis on sun exposed part. So it is very difficult that for a dermatologist that is it actually contact dermatitis or not, because there are so many differentials like the atopic dermatitis, dyshydrotic dermatitis, pneumolar dermatitis, stasis dermatitis, and even scabies and psoriasis. So it is very difficult for a dermatologist to diagnose, but the patient already diagnosed that he is suffering from allergic dermatitis. So we should check and identify the peculiar or typical clinical features for each and everything. For the diagnosis, the most important thing is the history. You should take time for searching the precipitating factors. So what are the time of onset and possible contact with the allergens? The contact area corresponding to the reaction area. Even initial clinical patterns and evolution of morphology. The working environment of the patient is very, very important, because that can precipitate different types of occupational contact dermatitis. And sometimes, most of the times, some are people are using mobile phones frequently on his ears and even the earbuds, Bluetooth devices, that even causes irritant and allergic contact dermatitis on the face and around the ears. Even the leisure activity, domestic products, protective measures regarding cleaning works. Just I want to share one of the experience regarding the cleaning works and the development of irritant contact dermatitis in a toddler. I search for frequent history, but I don't find anything. When I asked to the patient's parent that what else the kid was doing, both the parents are working outside, so they left the child in the room after cleaning of the floor. And the child is crawling on the floor, and the disinfectant present on the floor that causes irritant and allergic contact dermatitis. So history is very important, and it takes times. Skincare products, fragrances, nail and hair products, even the jewelry, artificial jewelry is very, very common, but even the golds can cause allergic contact dermatitis, and the plastic beads present on beside in earrings, that is also causing that. Even the suspicion regarding the heterotransfers like connubial dermatitis and the history of previous dermatitis. So with that, we search at different particular regions of the body how the contact dermatitis can present. When we talk about the lips, the several lip care cosmetics products like the lipsticks, lip balm, lip salve, lip gloss, these are all causes, the lip allergic cheilitis. Even the toothpaste, the most commonly I am unable to say here openly, but the herbal toothpaste are very frequently causing the allergic cheilitis and perioral dermatitis. Even the allergen can get transferred from gloves during any dental treatments by the dentist. The most common ingredients that causes the allergic contact dermatitis were even the castor oil, benzophenone, gallate, wax, and colophony. And nickel, of course, the most common one. This is the presentation how allergic contact dermatitis occur around the lips, cracking, fissing. Eyelid. Eyelid is another important site for development of allergic contact dermatitis that occur due to perfumes, metals, antibiotic, cosmetics, even topical eye ointments. But the most important thing is the perfumes and the vapors in the kitchens. Sometimes the patient says, "Sir, I'm using perfumes on my cloth, not on the face." Then I asked, "How can you smell?" Because the perfumes contain some, the microparticles that deposited in your nasal vestibule, then you perceive. Like that deposited on your upper eyelid, and that causes contact dermatitis. So this type of explanation is required to your patients. Even the benzalkonium chloride is a quaternary ammonium cationic that present in eye drops that causes allergic dermatitis. Other triggers may include the soap, detergents, acids, alkalis, and goggles while swimming. Even the cosmetics like the eyeliner, eyeshadows, and mascara can cause allergic contact dermatitis, and the extreme of the temperature and humidity. Here, if you see, there is a bilateral, more prominent on the right side, there is edema, and mild on that left side, the development of the allergic contact dermatitis due to mascara. Even the gold-plated metal parts of earphones causing allergic contact dermatitis, and the ear ornaments can cause allergic contact dermatitis. Scalp is also very frequent site for allergic contact dermatitis, but with the dye, it is very rarely seen, because when a patient applies dye on the scalp hair, he frequently develops allergic contact dermatitis of the face or nape of the neck. But in extreme or in severe conditions, he also develops the dermatitis of the scalp. Sometimes even some of the hair growth products can cause allergic contact dermatitis or irritant contact dermatitis. So we should know about those products. As you see, due to PPD present in the dye that causes the contact dermatitis. Hand and feet. We are frequently using different things with our hands and feet. So hand dermatitis is very, very common. Most of the time we miss the, the contact hyperkeratotic dermatitis of the hands and feet and misdiagnosed as a case of, psoriasis. But when we take detailed history, we will find that there are different, triggers like the rubbers, vegetables, and soap that can precipitate hand dermatitis. Even the ingested allergens like nickel, chromium, and drugs used topically like neomycin and hydroxyquinolones can precipitate hand eczema. There was a study by Bajaj et al. That showed that nickel was one of the important culprits that causes hand eczema, followed by the neomycin and other agents. The most common sensitizer in men being potassium dichromate, used by the cement workers, and in female the nickel, followed by the soap and detergent. For the feet, the commonest allergens are the mercaptobenzothiazole, followed by the potassium dichromate and thiourea mix. Even the latex rubber in the footwears can cause contact dermatitis of the feet. These are seasonally aggravated in summers, and housewives are most commonly affected by foot dermatitis, followed by students, because their feet most of the time are immersed in the water, and that's why they are more prone to develop allergic contact dermatitis. The trunk. The primary potential textile allergens are dispersed dyes and formaldehyde textiles, resins, chrome, cobalt, and latex and rubber. Even azo dyes, and most commonly the blue dye used by the rural persons in their cloth, causes allergic or irritant contact dermatitis. Fragrances, preservatives, and surfactants are also cause this type of dermatitis. And even the buckles and belts that causes nickel dermatitis on abdomens. Another, but not rare, is the contact dermatitis of genitalia. Ingredients of topically applied products like fragrances, preservatives, anesthetics, antibiotics, even steroids, and dyes and nickel can cause such type of contact dermatitis of genitalia. There's prolonged immersion in bath containing perfumes may induce an irritant vulvitis, and shower gels, soaps, deodorants also can cause this type of reactions. Dyes and synthetic resins in underclothing, douches containing acid or alkali that are not properly diluted can cause contact dermatitis of genital region. The dermatitis in response to the spermicidal agent is also proved in contraceptive creams like nanogenol 9, and also to the rubbers in condoms have also been reported. Even the chlorogelinol and 4-chloro-3,5-dimethylphenol present in the antiseptic preparations and soap causes dermatitis of scrotum. Patients most of the time present with intense psoriatic eczema of the scrotum with thickened skins, and when I asked about the history, we found that the patient was cleaning the area with the Dettol. Another important, here is a table that shows some important material that can cause genital contact allergy. The sexual material includes even the seminal fluids, in some cases spermicides, latex, KY jelly, and different things. In non-sexual, the topical medications, feminine hygiene spray, bubble bath, and scented soaps. Now something regarding the PPE kit. As we face the COVID era, and after that, the cases of contact dermatitis increases, because the PPE kit is worn by the person or healthcare workers for a longer duration. The rubber accelerators are used to extrude the vulcanizations of rubber and have been identified as allergens that is used in our mask in PPE kit. Another is the metal wires or rims are used in masks, and adhesive chemicals are used in constructions of medical face masks, and N95 respirators can also cause this type of allergic contact dermatitis to PPE kit. So it is very important. But one thing also important regarding the use of hand sanitizer. Previously there was some report that hand sanitizer can precipitate contact dermatitis, but after a long research, it was found that the hand sanitizer is not important culprit. Initially, after using the hand sanitizer, there is a irritant effect, but later it decreases the microbiota of the skin and control the contact dermatitis. So when you find that patient is suffering from contact dermatitis, how do you approach? It is very important. I am not advised that you directly go for a patch test. The most important thing is the history. And when you find that history is suspecting some important thing that can cause contact dermatitis or allergic contact dermatitis, then you will go. Because if you are going blindly on patch test, you will found that there are multiple materials that can cause reactions with the patch test. So it is very important to rule out the suspected materials by the history first, then confirm with the patch test. It is one of the gold standard diagnostic test for the allergic contact dermatitis, and it is an in vivo test to prove with the help of type 4 hypersensitivity reactions, and in which we are applying the allergens in a dilute in a particular vehicles in a particular chambers on the backs, and read the conditions after 48 hours, 72 hours, 96 hours, and after 7 days. And if we find if there is any skin changes in crescendo manner, then it may be a case of allergic contact dermatitis to a particular agent. And if we find is there any reaction but in decrescendo manner, then we can say it may be just irritant contact dermatitis to a particular material. And we can score that with these, the scoring systems, in which if there is no reactions, it is negative scores, and confusion when doubtful reactions, and +1+ when weak non-vesicular reactions, erythema, slight infiltrations, 2+ when strong reactions in the form of erythema, infiltration, and vesicles, and 3+ even very extreme reactions are bullous or ulcerative. Irritant reactions of different types is termed as IR, and NT is not tested. This is another scoring system for the same. The limitation of patch testing is that there is a variation in the materials like the chambers, vehicles, variation in the type of occlusion, the duration of applications, and reading times, and finally the score grading of patch test reactions that we can't universalize or that can be acceptable by all. The amount of allergen is important, as the reactions can provoke either false positive by using an exaggerated quantity of the allergen, or causing an irritant instead of an allergic reactions. And it can only be performed if there is no more active inflammation. The result could otherwise be false positive. And sometimes what happens, the allergic condition persists for more than a month, and so we should wait till the clearance of the condition. After that, we will go for patch testing. There are some modification of patch test like the strip patch test and ROT. ROT is one of the very simple, test by which we can judge or suspect that this particular material may be a culprit for the allergic contact dermatitis. Other tests are Atopic patch test and sketch test and prick testing, but these are not very helpful. And even the in vitro test is done for the diagnosis of allergic contact dermatitis, but understand the in vitro and in vivo scenario is always different. There are different, chemical milieu on the body, in the skin, that change the in vitro conditions. That's why it is not very reliable in a clinical scenario, clinical practice. Every year, we are getting more and more allergens in our batteries. And the last year also, there is a different allergens are reported in 2020 and 2021. And in future, I hope that each and every things we will find that can cause allergy to the human beings. Something regarding the biomarkers. Is biomarkers helpful? Still, we are in research. Although allergic contact dermatitis, we know that it is considered a Th1 cell-driven disease. Some allergens also induce Th2 cell activity, and studies have further shown that there is increase in interleukin 17 and interleukin 22 activity. So, the patch test studies have been utilized for this, and after that, we will do the biopsy and we will check for the particular, cytokines and lymphokines in that biopsy material to check for that. So the interleukin 16 and loricrin is very important biomarkers for allergic contact dermatitis and irritant contact dermatitis. Even recently, we are working on the CXCL9 and CXCL10 and ZBP1, but the results are not very, supportive. The potential new treatment, when you diagnose that the condition is a contact dermatitis, the most important thing is the avoidance of allergens. Only the avoidance of allergens can help, otherwise you will treat the patient for a long time, or patient will lost and move to another doctor. So the most important thing, treat immediately with avoidance of allergens and prompt use of suitable dose of oral steroid. Sometimes some of the non-dermatologists are fear to use oral corticosteroids due to steroid phobia. They are using, 5 milligram BD or 10 milligram OD, not more than 20 milligram. But I recommend, if you are thinking that patient is suffering from allergic contact dermatitis in an adult, you choose 0.5 milligram per kg body weight of oral corticosteroids for shorter duration and then taper. And that should be one time, not BD or TDS. And the treatments that, as already Abir sir discussed about the JAK-STAT inhibitors and dupilumab, but these are under trials. So these are some important things. These are my differences. Thank you all for kind attentions.
Thank you, Dr. Gupta, for finishing on time, rather before time. Yes. And can we have some questions? Yes, Avinash.
Of skin genitalia. Is there some role even in patients who have isolated recurrent oral ulcers? The reason I'm asking this is one of my patient himself picked up a chemical in the toothpaste. I can't recall it, probably SLS or something. And once he stopped it, the ulcers went away. Whether it was just a chance or this is one possible.
Right. You are right. Even the oral contact dermatitis is very common. Oral contact mucositis, actually, contact mucositis is very common due to some particular toothpaste, and even sometimes due to particular vegetables that contain some salicylates and other materials that causes. Okay.
Yes, Dr. Abir.
In your case, if they thought that SLS is not one of the common allergens in toothpaste. The most common allergens in toothpaste are cinnamates, yes. Which are those peppery, clovey type fragrances and flavors. But if it was SLS, then it was an irritant contact mucositis. SLS is basically a detergent, sodium lauryl sulfate, and it's present in all foaming things, almost all foaming things. So, and if it indeed was the culprit, then this was not allergic. This was just an irritant dermatitis, and that patient should be advised to avoid, hand washes, aggressive soaps, alkaline soaps, etc. Also, so it's very important to understand that Dr. Sunil did say this. Allergic contact dermatitis and irritant contact dermatitis are two very, very different things, and they can be picked apart, and they need slightly different approaches to treatment.
How to treat cement contact dermatitis?
Yes, it is very difficult to manage cement contact dermatitis because those patients are very poor and very unable to change their job. The most important thing is to change the job. Even sometimes we recommend that they should use some gloves, PVC gloves. But even when they are working, the seepage of the cement material till this, above the elbow joint, that can cause allergic contact dermatitis and irritant contact dermatitis. So it is very difficult to manage. The most important thing is the counseling and change the job.
In fact, in the same vein, I think occupational dermatology.
Yes, sir. Sure, sir.
The understated fact is the use of barrier creams.
Barrier creams.
That should be really considered before one can be nudged to change the job.
Actually, the most important thing, a poor person, how he manages. What amount of his salary he spend on, the moisturizer or his daily wages. It is very important. जितना कमाया नहीं उससे ज़्यादा तो उसने अपने treatment पे खर्च कर दिया. It's better to change the job.
The cement dermatitis problem can be solved at a very high level. We have to talk to the government. Countries have solved it to some extent by reducing the chromate content. We know that potassium dichromate is the factor causing cement allergy. And there are technologies, but again, we'll have to change the formulation of all the cement factories and the kind of cement they are producing, and this requires, lobbying at government level.
Is it that common?
Yes, sir. It's very common.
Abhishek has a question, yes.
Tattoo making as such not causes allergens, but sometimes it causes some different issues.
How severe it can be?
Like the sarcoid, tattoo sarcoid, and even granuloma. That is very important. Allergy.
Yeah, certain types of tattoo dyes. I mean, if you are a tattoo artist, it is a very, very high risk profession for developing contact allergy of the hands, because you will be handling not only various types of dyes, some of which are allergenic, but you will be handling a lot of other chemicals also for cleansing the skin of your clients, and putting a lot of other adhesive tapes, etc., all of which expose you to colophony and stuff like that. So that is a high risk. And as long as if you're getting a tattoo done, then as Dr. Sunil said, you can develop, and particular colors are high risk. Yellow tattoos, red tattoos. So these are, not only are they very, very difficult to remove by our lasers, they are much, much more prone to cause granulomatous and itchy skin reactions, which are very, very itchy and very difficult. I mean, we literally have to cut the tattoo out.
Thank you, sir.
Thank you, everyone. I request all of you to gather outside, just outside this hall, for a group photograph before proceeding for the lunch. Pertaining to the allergic disorders. And to chair the session, I would like to invite Professor Vikas Agarwal, sir. He is professor in Department of Clinical Immunology and Rheumatology at SGPGI. And over to you, sir.
Very good afternoon to all of you.
Sir, I would like to interrupt, sorry. I would also like to invite Vishad Vishwanath, sir, who is consultant rheumatologist at IRIS Center, to co-chair this session.
Very good afternoon to all of you. This is the penultimate session for the day. The session is titled as Evolution of Allergy Therapeutics, Oral Medications, Biologic Agents, and the Immunotherapy Frontier. And there will be three stalwarts who will be actually dealing with this complex topic. And I think everybody. He was the the Department of Clinical Immunology and Rheumatology at King George Medical University, Lucknow. He is currently a DNB mentor for rheumatology at Homeopathic Super Specialty Hospital. He has got more than 63 publications and many book chapters. He is an excellent orator, and I'm sure whatever topic he deals with, he enlightens the audience with crystal clear clarity. So over to Anupam.
Thank you, Vikas. So the topic that we're going to discuss today afternoon is DRESS syndrome, and Kunal very aptly labeled it as dressing up the challenge. I have no disclosures relevant to the present talk. The objectives will be to know that DRESS is an acronym: Introduction and Terminology, Epidemiology, Etiology and Risk Factors, Clinical Features, Differential Diagnosis, and a little bit about the management. So we know that Boquet et al. Coined the name DRESS. It was initially drug rash with eosinophilia and systemic symptoms, but recognizing that about 5 to 10% cases do not have a drug rash, it became drug reaction with eosinophilia and systemic symptoms. So that's the term to remember. It's a severe adverse drug reaction. There is usually an extensive skin rash in up to 90 to 95% patients. There is organ involvement, there is lymphadenopathy, there is eosinophilia, there may or may not be atypical lymphocytosis. There may be a protracted course. In fact, there usually is a protracted course with multiple flares that can happen. And the latency between drug initiation and disease onset is normally anywhere between 2 to 8 weeks. This is in contradistinction to Stevens-Johnson syndrome, where the latency is much less. So, DRESS is the most commonly used terminology. It has also been called as drug-induced hypersensitivity syndrome, so that's another common name that you'll hear. And the older names, depending on which drug caused this problem, was phenytoin hypersensitivity syndrome, allopurinol hypersensitivity syndrome, and dapsone syndrome. You would remember that we do remember phenytoin as a cause of atypical lymphoid hyperplasia and lymphadenopathy. So that was actually the phenytoin hypersensitivity syndrome, plus minus a drug rash. We have a prevalence of about 0.9 to 2 per 100,000 patients per year if you take all drugs. Among hospitalized patients, the incidence is about 10 to 20% of all cutaneous drug reactions. Adults normally more than children. And the important thing is that varies with drug usage or risk with individual drugs. So there are certain high-risk drugs that we will see. But at the same time, depending on anti-seizure medications, you could have a 1 in 1,000 to 1 in 10,000 per exposures. And in ICU settings, you know the antibiotic usage is high. So something like vancomycin. So where antibiotics are being used more, you could have more of DRESS in those circumstances. So among the etiology and risk factors, we have a drug exposure. We have a pharmacogenetic susceptibility with an HLA and certain genetic polymorphisms. And we have reactivation of the herpes viridae group. Whether it's the cause or effect is something that is still being debated, but let's have a look at it. A drug exposure is clearly identified in 80% of DRESS patients. It is most often due to high-risk drugs, which we'll look at in a moment. Case reports are important. So if you're sometimes faced with a DRESS-like situation and you don't find that drug in the initial list, check up the case reports. You're certain to find it there. So definitely keep that in mind. Pediatric cases normally more would have it because of antibiotics and anticonvulsants. And the factors that may affect our renal failure, if you give allopurinol, there is a higher chance as compared to those who do not have renal failure. And you have delayed clearance based on the pharmacogenetics as in phenytoin and reactions induced by minocycline. Now you can see the list of drugs. These are high-risk drugs, and by means, no means is the list complete. So you have anti-epileptics, mostly the aromatic anti-epileptic drugs. Among antibiotics, you have a wide plethora, but you have sulfa drugs. See that even azithromycin and levofloxacin are known to cause DRESS. Amoxicillin is fine, trimethoprim, and then vancomycin as an IV antibiotic. Any of the ATT drugs can cause stress. A non-steroidal anti-inflammatory normally doesn't come to our mind, but keep it in mind. And then you have allopurinol. Amitriptyline is so commonly prescribed. Dapsone among indications, hydroxychloroquine for us rheumatologists, imatinib you know, nevirapine as an HIV drug we know, omeprazole given all the time, right? So, and yet if you don't find it in this list and you think you have a drug reaction, look it up. So we talked a little bit about it. I think Pravin mentioned it as well. Look at the HLA susceptibilities and genetic polymorphisms. So if you have an HLA B5701, you have about a 50% chance of developing a DRESS syndrome with abacavir in this population. So this research goes on, and as more populations get tested and more screening happens, these things come out. The important thing is look at the negative predictive value for most of these. It is close to 99 to 100%, which means that if you do not have this polymorphism, the chances of this group of patients reacting by abacavir is next to zero. That's the important thing. The positive predictive value is just 50%. So you're not sure whether your patient is going to have it.
Asians with CYP2C9 3 polymorphisms are more at risk of phenytoin-induced severe cutaneous reactions, and variations in the NAT gene, which basically makes the person a slow acetylator, are related to a sulfonamide-related hypersensitivity reaction. And then finally, there's a lot of talk about reactivation of the herpes viridae group. HHV6, which you can actually estimate, is the most common, found in about 15 to 60%, depending on the series. HHV7, EBV, and CME. There is data to suggest that if the virus activation occurs and you have a high viral load, then the chances of a poor prognosis increase. Is it the cause or effect? So we know that the viruses are basically sitting in the T cells, and when the T cell replicates in presence of an insult, you can have excessive shedding of the virus. At the same time, we do know that because it's a Th2 mediated disease, you do have a relative immunodeficiency state with decreased immunoglobulins, and viral replication can increase. And then again, we have drugs that can directly stimulate viral synthesis, that example, valproic acid and amoxicillin. I've just put COVID-19 infection and vaccination there because both COVID-19 infection and vaccination are known to produce DRESS-like situation and the drugs that are given during that period. So just something to keep in mind there. So pathogenesis, we have talked, so it's a Th2 mediated disease. We have talked about it all the time. I'll run you quickly through it, but you're basically familiar with it because we've been talking about this for the last 1.5 days. So you have a culprit drug with genetic susceptibility, and maybe the reactivation of the herpes virus is also one of the pathological causes. You have drug-specific T cells, you have antiviral specific T cells. They end up secreting a lot of cytokines, and you've seen that IL-4, IL-5, IL-13, you've heard all of these, basically cause inflammation, cause hypereosinophilia, and it causes the varied manifestations that you see here, which are skin eruption, fever, lymphadenopathy, hepatitis, can cause acute interstitial nephritis, GI manifestations, pneumonitis, autoimmune diseases, and multiple drug sensitivities. So remember, Th2 cytokine mediated. We have talked about these cytokines in great detail, and in most cases associated with hypereosinophilia. And so the IL-5 pathway, there were some case reports in which the JAK-STAT pathway was also described to be upregulated, and so there have been a few case reports about therapy with tofacitinib, and we'll come to that in a moment. So if we look at the clinical features, I told you that the latency between the delivery of the drug and the DRESS syndrome is about 2 to 8 weeks, but you can have a rapid DRESS within 1 week or so, especially if the first one was a primer and you didn't have those many reactions, and the mean range would be anywhere between 3 to 105 days. So the drug may have disappeared long ago or has been given for a long time, and you think this shouldn't cause a problem, but it actually is the problem. You do see a shorter latency with beta-lactam antibiotics and iodinated contrast media, so those are two important things. Prodrome is non-specific. You can have cutaneous and mucosal lesions. You can have systemic symptoms. You do have lab abnormalities, and you can have organ involvement. So it's a complete whole body disease. Cutaneous manifestations, skin often the first. You can have a maculopapular to coalescing erythematous rash. You can have purpura, plaques, pustules, exfoliative dermatitis, bullous lesions, and target lesions. And when you have target lesions, you may have a problem differentiating it from target lesions in? Yeah. Facial edema has been described to be striking in about 70% of the people, and more than 80% people have greater than 50% of body surface area involved. So it can sometimes be as bad as a burn for the patient. A mucosal involvement is usually mild, and that is a contrasting feature with Stevens-Johnson syndrome or toxic epidermal necrolysis. And pruritus usually occurs, but may be minimal or absent. And so you can have this erythema, more appreciated in fair-skinned individuals. You can have it coalescing, and then you can have a plaque-like scaly erythema. And if the patient and the disease needs to confuse you, then you can have target-like lesions, you can have significant mucosal involvement, and you can have ear erythema here. The reason I put up that photograph is that when we look at the ear, as rheumatologists are concerned, we are either thinking leprosy or we are thinking relapsing polychondritis, and you can actually have a tender cartilage with infiltration there. So it's just something that we need to keep in mind. Systemic features: fever, more than 101.3, lymphadenopathy, a myriad of hematological manifestations, eosinophilia, definition-wise more than 700 per microliter, leukocytosis, neutrophilia, lymphocytosis, monocytosis, and atypical lymphocytosis. Atypical lymphocytes normally come in when there is proliferation of the virus, CMV, EBV, and HHV. Symptoms and lab involvement usually are associated visceral involvement in about 90% of the patients. If you are to have organ involvement, you have definitely one organ involvement in about 90%, two organs in about 35%, and more than two in about 20%. When you see terrible dress, most organs are involved, and that is when we need to be worried. Remember that internal organ involvement may precede the rash, so you could actually get organ involvement, in liver injury, for example, and cutaneous rash and organ involvement may behave entirely differently. You may have the rash improving, but the liver or the renal function actually deteriorating. So liver, most common, 53 to about 90%, usually mild and transient. You can have any one of the three pictures, but it may be so severe as to require a liver transplant. So if you have acute fulminant liver failure, you need a liver transplant, bottom line. Kidney, you can have proteinuria to renal failure, and the usual drugs involving the kidney are either allopurinol, carbamazepine, or dapsone. They're the most common known. You can have acute interstitial nephritis, renal failure, and you will require dialysis in about 1 to 2% of the patients. Pulmonary involvement, myriad manifestation, acute interstitial pneumonitis, lymphocytic interstitial, ARDS, pleuritis, pleural effusions. They are rare, but it can happen. And if it has to happen, the most common drug would be minocycline. Cardiac involvement is even more uncommon, but remember, always look at the heart, because if you miss myocarditis, that's happening, your patient will pop off. And minocycline again and ampicillin are two common drugs. You can have a hypersensitivity myocarditis that is relatively easier to treat, but if you have a necrotizing eosinophilic myocarditis, which is normally diagnosed by an endomyocardial biopsy, there's a greater than 50% mortality. Neurological, I was surprised, but yes, it can occur. Bell's palsy, neuropathy, aseptic meningitis, limbic encephalitis, and CNS vasculitis in about 2 to 8% cases. It's like a full-blown autoimmune disease. GIT, uncommon, but you can have all these manifestations. Others are much rarer: myositis, thyroid dysfunction, uveitis, and a dreaded complication, that is the hemophagocytic syndrome. Other atypical manifestations are described with various drugs. Just naming a few: chylomicrosis, cicatrizing conjunctivitis, delayed interstitial nephritis, leukoencephalopathy, pneumothorax, pneumomediastinum, and you can see that separate drugs tend to have separate kind of manifestations. Is there a difference between adult and pediatric dress? Some pointers, although they could behave in exactly the same fashion. The mortality rate is about anywhere between 2 to 10% in adults, and it is slightly lower, about 5% in about pediatric cases. The culprit drug in adults are normally anticonvulsants and allopurinol, then sulfonamides. In pediatric cases, they are aromatic anticonvulsants, antibiotics, and then sulfa drugs and NSAID come later. Pathogenesis the same. Pulmonary involvement is rare overall, but it is more prevalent in adults, and GI involvement is more frequent. So you may have the person presenting with abdominal pain and loose motions. Long-term sequelae by far and large normal. The MDH stands for multiple drug hypersensitivities. So even though you may have reacted to sulfa, but you could possibly react to another drug as well. So all prescriptions of unnecessary medications need to stop when you have a person of dress syndrome. They describe this mini dress skirt syndrome. I was trying to find out a male equivalent of a mini skirt. So that's where it is. The man looks okay. Okay, so people are not sure whether it exists. But we do know that different people, for example, a drug-induced hypersensitivity pneumonitis, the kind we see with nitrofurantoin, is identified by pulmonologists, and a DILI or a liver injury is identified by hepatologists. So I guess just like you have an atypical, suppose you had to have 6 things for a diagnosis, then maybe you have 1 or 2 of the manifestations. So one does need to keep one's eyes or ears open. The acute phase gradually resolves in 6 to 12 weeks or longer. Flares may occur months later, and the one important thing that can cause a flare or deterioration is a rapid taper of steroid. So that's an absolute no-no. Keep the steroids there for a minimum of 3 months, if not longer, or use a steroid-sparing agent. So avoid unnecessary treatment because cross-reactivity is possible. The long-term sequelae are there. About 10 to 11% you can develop autoimmune thyroiditis, vitiligo, AIHA, alopecia, lupus, and even type 1 diabetes. So my last patient with DRESS, skin improved, liver improved, went back home, came back about 2 months later with diabetic ketoacidosis. Everybody said it's because of the steroid, but then type 2 diabetes does not present that commonly with diabetic ketoacidosis. We treated her on antidiabetics, came back 2 months later with hypothyroidism. So thyroid had been hit. So it's real, it is seen, you just have to look out for it. So criteria for diagnosis, not going into the details, but new drug exposure in the preceding 2 to 8 weeks, fever, enlarged lymph nodes, eosinophilia, atypical lymphocytes, skin involvement, and organ involvement. And resolution in greater than 15 days. Okay, maybe resolution takes time. There is a Registrar scoring system. I am not going to go into the details. We've sent out enough reading material to all of you. Have a look at it. I've taken it from one of those systems. You score it. There's a fair chance total score. If you see at the bottom here, you know how to diagnose DRESS syndrome. Remember that you may not fulfill all the criteria because the pitfalls in diagnosis are the disease is dynamic, so you may have one thing developing after the other, and it may not satisfy criteria at one point in time. It is modified by medicines including steroids. Reaction hai. Allergic drug and steroid would be prescribed anywhere today. They may not have skin involvement or eosinophilia, so keep your index of suspicion high. Remember the latency of 2 to 8 weeks. And some of the long-acting drugs, even though they have been withdrawn and you think, oh, this has been removed, why can I get a reaction? But you may have a long half-life of the drug and it's still circulating and it can end up causing a reaction. Lab tests for confirmation of diagnosis, right here. If you have facilities and the patient can afford it, I would definitely estimate the viruses as well. Exclusion of alternative diagnosis here, and assessment of organ involvement by whatever is required, right? If you do a skin biopsy, it's not diagnostic. You can have various patterns, normally non-specific. You can have interface dermatitis with basial vacuolization, and you do have a dermal eosinophilic infiltrate. I'm not going to touch on those. We have talked about these in the last 1.5 days. You could do a dermal patch testing, which is diagnostic in most cases, but remember it is invariably negative in sulfasalazine dress and allopurinol dress. Intradermal testing is best avoided because it can precipitate the disease again. You can do drug-induced cytokine assays and lymphocyte transformation tests. You have to do this 4 to 6 weeks after the dress has subsided, number one, and the patient should not be on an immunosuppressive medication. Otherwise, you're going to get false negative results. Various kinds of differential diagnosis, Stephen Johnson right at the top, or toxic epidermal necrolysis, acute generalized exanthematous pustulosis, I'll show you a photograph of that, lupus, hypereosinophilic syndromes, and various kinds of viral infections with viral rashes. And so this would be Stephen Johnson syndrome, right? Occurs faster, skin much more involved, more bully than anything else. Lot of mucous membrane involvement. This is AGEP, mean day of onset 2 to 3 days, and there's a generalized pustulosis, and this would be SCLE, right? So what do we do? So there's drug withdrawal and supportive management. You can see the degree of multi-system involvement. Every system needs that support. The patient could be treated if it's a mild disease on OPD basis or inpatient, and you would have certain patients with renal failure or acute fulminant liver failure landing up in the ICU. Use of topical steroids and antihistaminics, systemic steroids, and pulse in severe stress. This is the mainstay of treatment. You could require anywhere from 0.25 to 1 milligram per kg per day if the patient is severe. Cyclosporin kind of crept into the management of DRESS. People have observed that if you use cyclosporin upfront in a dose of 5 milligram per kg per day divided over 2 doses, and you give it for the initial 2 to 3 weeks, and the responses are faster and equivalent to that of steroid. Of course, you will have to taper it, and you might need addition of steroid as well. So this is something to think about. IVIG in the sickest of cases, especially if they also have an infection, but there have been trials against IVIG. In fact, one of the case series described that IVIG actually increased the amount of complications. For long-term treatment, recalcitrant DRESS, you may need MMF, rituximab. I talked to you about tofacitinib. Tofacitinib is upcoming. There are a small number of case reports, but with an access identified there, it might work in 5 milligram twice a day, maximum of 10 milligram twice a day. Cyclophosphamide when you are absolutely frustrated. An anti-IL-5 treatment, you know the 2 for anti-IL-5 and 1 against the receptor. And I'll just give you the names. And if you do identify CMV or hemophagocytosis, then the way to go is with ganciclovir or valganciclovir, because that will make a difference to your overall mortality. So again, I think we will pass on the slides to you, but if you have DRESS, almost there, I have one more slide. So suspend the drug involved, multidisciplinary approach, antipyretics, antihistaminics, topical steroids, emollients. Avoid NSAID and antibiotics unless it is absolutely required because of cross-reactivity. Non-severe DRESS, OPD, severe DRESS,
Steroid, otherwise cyclosporin, IVIG, you can use plasmapheresis in certain situations. If there's viral activation, ganciclovir, and this is basically for the liver injury. Old age, minocycline and allopurinol are associated with an extremely poor prognosis, so watch out. Severe stress is if you have life-threatening organ involvement or you land up in an ICU. A total eosinophil count greater than 6,000 is a poor prognostic factor. If you develop eosinophilic myocarditis, hemophagocytic syndrome and coagulopathy, if on skin biopsy you've done one and you find extensive necrotic keratinocytes, it's a poor prognostic factor. And we did talk about the adult mortality being close to 2 to 10%. So ladies and gentlemen, to summarize, we have exposure to an offending agent with genetic susceptibility and pharmacogenetic alterations. We can have a viral replication which basically produces the illness of stress. Remember, it's a reaction, not rash. We have manifestations like eosinophilia with atypical lymphocytes, lymphadenopathy, interface dermatitis, fever, skin eruption, relevant facial edema, hepatitis, kidney involvement, pneumonitis and pleural effusion, and long-term complications such as autoimmune thyroiditis and diabetes. We do have a list of drugs. Remember, we talked about oral steroids, cyclosporin, IVIG, cyclophosphamide, plasmapheresis, mycophenolate, the 3 drugs against the IL-5 axis on which there are enough reports now that it can help in severe stress, and finally tofacitinib. Remember, it's a multi-system disease and has a 2 to 10% mortality, have a high index of suspicion. Thank you for a patient hearing.
Thank you, Professor Album. A very lucid and a very clear-cut presentation of a very difficult topic. And I'll start from the last word of this, have a very high index of suspicion. Because I have seen people, despite being told that this looks like stress only, not initiating glucocorticoids in time. We have a hospital-based practice, so we do see severe stress always, almost always. The presentation is open for comments, discussion, queries. If there are any queries from the audience. Yes, okay.
We had one patient in we had reference for one patient from gastroenterology. He is a diagnosed case of ileocecal tuberculosis, started on ATT. After starting ATT, after almost 2 to 3 weeks, he had severe stress, and then he was referred to HGB and admitted in gastroenterology department. They have started them on 1 mg per kg steroids, but now the repeat consultation was when they can restart or re-challenge ATT, because the patient will need ATT, and he has taken ATT4 combination.
So very, very difficult situation. But if it was severe stress and the patient is on steroid, then if the skin is settled down, if your liver function test, I will really look at the liver function test and renal function test. If they both settle down, then I would go with if you look at ATT, you do have re-challenged doses of the drugs. You start with 10 milligram, 20 milligram, 50 milligram, like that. So I would start with one drug at a time. I would totally forget about any kind of resistance to drugs. See if there is the slightest bit of reaction with any one of the drugs. Try and identify which one it is. It's normally rifampicin or pyrazinamide, but of course can happen with any of them. And take it from there. So it has to be very gradual. They have to be re-challenged with the smallest doses of drugs. And I don't know, there's a tendency to prescribe those combination of drugs, 3 tablets at the same time in the morning. I normally prefer to give arsenic and INH together and give ethambutol and pizide separately and probably space them out a little bit. So if one drug is not suiting it, you'll get to know.
Thank you, sir.
Sir, regarding renal, systemic. Sir, my question is regarding systemic involvement in DRESS. Can we have organ involvement subsequently, like if a patient is presented to us with a disease duration of about 2 weeks, she or he has been hospitalized for DRESS, she has been diagnosed, she has been on treatment on 1 milligram per kg of steroids, can subsequently that patient has systemic involvement in form of acute renal injury leading to proteinuria or hematuria, or like cardiac involvement leading to myocarditis?
Let me counter you with a question. You have a patient of lupus who has been admitted for severe arthritis and mild myositis who is on 0.5 milligram per kg of steroid. Can the patient subsequently develop a renal involvement or a GI vasculitis or a neuropsychiatric lupus? Similarly for DRESS, yes. DRESS is unrelenting. It will not leave your organs. Sometimes it may not be controlled by one drug and you may need additional drugs. So absolutely it can occur. DRESS should never be taken lying down. Never, never, never. You can develop myocarditis 3 months later. So you have to be extremely, you can develop hypophysiitis from DRESS, and that is well described. So endocrinological abnormalities are really well described. So absolutely you can develop it, and you have to really keep a close watch for
Mostly then it is disease that DRESS only that is leading to.
Oh, absolutely. So for the patient that I was mentioning, by the time I realized what DRESS was doing to her body, she was hypothyroid and diabetic. And till now, till date, 6 months later, I have not withdrawn her cyclosporin because I understand that the DRESS is on a march. There will be a next organ that it will be eating up. And at some point in time, I've just stopped steroids. The patient is doing well, and now I'll reduce cyclosporin by 25 milligram increments and see where it goes. There's no data in literature, believe me. On long-term DRESS, there is no data. You just have to manage it for longer. That's all that is written.
Okay, thank you, sir.
Can you be specific how long?
I don't know. Every 3 months I reduce by 2.5 milligram of steroid till it is 2.5 milligram once a week. Maybe I might have to treat for the next 6 months. Pravin.
Just to give you the context of what Dr. Anupam was saying in terms of the importance, the amounts of T cell activated in DRESS is more than superantigens. So, when you talked about Staphylococcus superantigen and E. coli superantigens, in previous day, now obviously we know that was not the case. The amount of T cells that are activated here are 2 logs more than those cases. So you can imagine what an inflammatory milieu is. And when we talk about multi-drug hypersensitivity, the other drugs are actually not themselves contraindicated later on. Those other drugs just perpetuate this inflammatory phenomenon. And usually these are on multiple drugs, apart from, your anticonvulsants, where it is a single drug and it's easy to make a diagnosis. But one thing about steroid tapering, because we have published on this 3 years worth of DRESS syndrome causing severe alopecia totalis. 6 weeks is minimum you will treat. If liver enzyme is more than in thousands, it is 6 months. And the only 2 factors help in deciding that. One is viral reactivation. HHV6 is very important. So I know, but it might not be done here. So that's a difference here. And the viral reactivation, you wouldn't do one-off. So you have to do it at 2-week mark, even if they are on steroids. So don't do it at diagnosis, do it at 2-week mark. And that is why the recrudescence of the problem when you stop early steroids.
Absolutely.
So, and the second thing is flow cytometry. So you can actually quantitate the activated CD4 T cells by doing a combination of DR, 38 and 69. So you do HLA-DR, CD38, CD69. If that quantitation, antigen-specific activation is more than 15%, you will keep going at least for 6 months, minimum. But some of them might require longer treatment.
So maybe 1 year, 2 years, nobody knows.
Well, that is only in steroid era. So it will change now because the drug that is possibly going to fix it actually is tofacitinib.
Yeah.
So there's a Nature paper on it. Looking at I'm sure you've read it as well, the TH17 pathway, and being completely blocked off with use of tofacitinib within 3 days. So in modern day practice, if you went for steroids and organ threatening, I would jump in with tofacitinib straight away.
So, thank you for a very comprehensive lecture. You really managed to keep the audience active in the postprandial session. So I have one question. in case of DRESS syndrome, we know that the exposure to medication, the shorter the exposure, the better it is. So is there any study regarding drug elimination from the body, reducing the course of DRESS syndrome?
Oh, I mentioned to you that there are certain, like the slow acetylators. So they will have a poor drug elimination from the body, and they'll have the drug in there for a longer period of time.
Things like dialysis, there are some of the medications dialysis.
So plasmapheresis is something that is definitely being done. So, but it will do one sweep, but it won't perpetuate the advantage that you get. So.
Just to add to that also, it is not the actual drug at times. It is some of the metabolite of a drug which
Correct.
is important, so which may not get eliminated even by doing a dialysis. So the effect is going to persist for a longer period of time.
So there was one online question from Dr. Shabir. He's asking whether severe presentation almost looks like CTD, what is the prevalence of autoantibodies in DRESS syndrome, and whether there are any clues to differentiate from autoimmunity apart from the drug history.
No, we get foxed all the time. We have done ANAs and ANCAs and ENAs on them. We find ANA positive all the time. Unless your pre-test suspicion for lupus is very high, I would strongly recommend don't do it, unless you are thinking that the DRESS-like manifestation is because of lupus, because lupus does come in the differential diagnosis. So yes, you can find false positive ANAs in this condition, absolutely.
Is there another question online? Can we diagnose DRESS syndrome without skin involvement?
Without?
Skin involvement.
With a high degree of suspicion, yes. So it depends on the drug, number one, and number two, who's seeing it. So as I said, if the gastroenterologist is seeing it, then it becomes drug-induced liver injury with eosinophilia, but may not have skin involvement. If it's seen by the pulmonologist, I don't know how many of you have seen nitrofurantoin hypersensitivity syndrome, but it can be quite terrible. And it doesn't have that much of a florid skin involvement as other people. So yes, absolutely.
Any question from the
One thing for rheumatologists remember is if you are not getting a suitable drug, think of leflunomide, because of its long half-life, patient may have stopped it and now coming with DRESS syndrome. And since the drug, we know that it is there in the body. Cholesterol washout is something,
No, that's a very important point, Abel, and we do know that leflunomide can present with a DRESS syndrome, absolutely, and does have a long half-life.
I just like to add one or two lines to what Anupam has presented today from our experience on DRESS over the last 15-20 years. That also we have learned in the hospital itself. Most of these patients tend to have progressive leukocytosis. Patient had come with a leukocyte count of say 7,000, and by the time patient has developed full-blown DRESS syndrome, the counts have gone up to 30,000, 40,000, or even 50,000. And we keep on chasing this PLC count, thinking that patient is going in sepsis, severe sepsis, or even the severest of the sepsis, without realizing the fact that we are not diagnosing the patient correctly. So if you tend to have this kind of presentation, please do consider a possibility of DRESS syndrome. Atypical lymphocyte, even eosinophilia may not be evident at times. And as somebody has already asked, skin manifestations may or may not be there, though they are there in 90 to 95% of the cases. That is why now the terminology is drug-induced hypersensitivity syndrome. For the oldies, it was used to call as pseudo-lymphoma syndrome, phenytoin-induced pseudo-lymphoma syndrome. So these are some of the nomenclatures, but total leukocyte count rising progressively, if we don't realize that patient has got DRESS syndrome, needs to be taken into consideration by all the physicians who are managing these kind of patients. So with this, I thank profoundly Dr. Anupam for his very educative presentation.
Dr. Pravin Hissaria, request no introduction. He's giving us an overview of the pharmacological treatments available in allergy management, and I think he's the best person around to enlighten us on this. Over to you, Prince.
Listening to me. I'm going to keep this very simple because I think we've had a talk on biologics and small molecules, and I think those are more sexier in terms of learning and everything. I might just give you some practical points in terms of how you should use some very commonly available medications in your routine day-to-day practice. And what are the common pitfalls that we see when we are prescribing it in terms of the combination therapy? And I think the dermatologist mentioned it very elegantly about this combination treatments becoming more cheaper than the single, and hence they are increasingly being used in vogue. I do have some conflict of interest disclosures here, although you know I'm not sold to them because I still speak against them. So to start with, I'll start with the most common thing actually that we definitely, if we are planning to practice allergy, we should know, which is management of anaphylaxis. I think that is an acute life-threatening situation which can kill within minutes. So you have to be well prepared to how to deal with it. And I think I missed the talk yesterday, so I'm not sure exactly how much depth it went into, and I might be repetitive, but I'll still stress the point. I think it is worth learning again how to manage effectively anaphylaxis. And guess what? It is not a difficult thing to do in terms of making a diagnosis of anaphylaxis. The criteria, without going into very detail, are very simple. Anything which is an acute onset, right? And if there is when you already know a trigger, it can be any manifestation: skin, gastrointestinal, respiratory, cardiovascular collapse, anything. You go ahead and treat it. You're better off treating it than not treating it, because most of the times the deaths have been where there has been a delay in administration of epinephrine. If there is a suspected trigger, then possibly you need more than one system involvement. So then you might want to look for a rash, which can actually be hidden. So patient might be unconscious and they might not actually, you might have to, remove the clothes or something to find a rash. But that should always be done. And that's one thing that now, as part of Australian College actually guidelines, we are planning to change in terms of management of an unconscious patient that you find. You do your CPR and we always know about ABCs and everything. But this should be part of the thing, because most of the deaths are when you don't know. And obviously, if there is no suspected trigger or an obvious trigger, then obviously you need to have the full-blown feature, which should include, at least two of the cutaneous, the respiratory, the cardiovascular, or gastrointestinal. But as I said, this comes on very quickly. And why is that? Because we've already said, right? Mast cells, they are preloaded. Like from Dr. Sunil's talk yesterday, we saw that they have such highly packed, dense granules in their cytoplasm. And all that happens when the Fc epsilon or any other receptor-mediated triggering event happens is that they just release these highly potent vasoactive amines into the bloodstream, which means that at that point in time, there is no point trying to put an trying to negate the effects of them in terms of doing so many long-term therapy. So you just have to get in and stop what can kill, which is the stimulation of the alpha and the beta blocking, and hence you give adrenaline, right? One thing you have to learn about management of anaphylaxis is it is adrenaline, adrenaline, and adrenaline. Nothing else. Don't even think about anything. If you can't find your oxygen system, if you can't get an intravenous line, that's fine. First give adrenaline, then you start thinking. Obviously, you have to get an intravenous line and fluid overloads, and those are the guidelines that still remain in practice, that you lie down. But two things you should do straight away. One thing is the patient should lie down, and this is important for situations, like for example, dental practices and everything, where the patient suddenly falls and we think it is vasovagal syncope or something. The first thing you do is make them lie down, give adrenaline once you have suspected anaphylaxis. Then you can buy about 2 or 3 minutes to then decide your next action about calling for help, finding your oxygen cylinders, or taking an intravenous or an intra-arterial line. But the first thing is adrenaline. And if it doesn't respond within 3 minutes, no blood pressure, again adrenaline, right? And don't worry about thinking that, because it is very severe, you have to give intravenous adrenaline. The studies have been done, very good mice model studies, where intramuscular works equally well, okay? So give intramuscular adrenaline straight away. The guidelines would say you don't even need to actually, remove clothing to give that injection. You can just give it on the outer side of the thigh through the clothing. So it is that degree of medical emergency. But this has to be known, because you still find that if you're suspecting anaphylaxis, people still write F-colin and Evel. That's wrong. And especially Evel, because that actually causes, as you all know, intense it can cause paradoxical vasodilatation, which means making the actual symptoms worse in terms of regaining the blood pressures, right? So adrenaline, lie down, then start thinking. Then obviously the other things come up. Antihistamine, possibly yes, you can give it once because histamine is one of the most potent things which is released, and the histamine receptors are very highly dense around the vasculature. That's why they can cause, that's why the wheals are caused, and that's why they can cause vasodilatation. So you can give antihistamine. Steroids, there's no role for it acutely. Don't even bother thinking about steroids for the first 2 hours. Okay? If there is a recalcitrant one, that is, if there is a second wave or second phase coming in after a couple of hours, maybe steroids. And even that is not supported with very high degree of scientific evidence there. We just do it because that's what we've been told, that, this delayed phase. And all that learning comes from asthma, right? So asthma, when they used to do these challenges and you get severe asthma as part of mast cell activation, not as part of just bronchoconstrictive responses, that time people have shown that, steroids in long term can manage. But otherwise, acutely, no role of it. Don't even bother about doing it. Yeah? Steroid has to get into the cell, it has to bind to its receptor, it has to get translocated to nucleus, then it stops the transcription of your cytokines, right? That takes at least few hours, if not more. Methylprednisolone, obviously there is some cell surface stabilization, but the most important thing is that. The other thing that I tend to mention is the use of glucagon. So if patient is elderly and if he is on beta blockers, and if you have used up 3 adrenaline at 3 monthly, and the adrenaline is every 3 minutes, if you're not getting back the blood, the control of and if they are severely bronchospasm is still persisting. After 3, you can then, by the time hopefully you've had the IV line, this is obviously in an outpatient, like in a setting where there is no intravenous line in place. If this is in hospital-based drug-induced or something, they are already there, and after 2, maybe you can start your adrenaline infusions. But if it is not there, after 3 is when you start your IV infusions. And IV infusions obviously is 1 in 10,000, and I don't need to tell you that, which is to be given 2 mils per minute. IM is 1 in 1,000, okay? So you need to be careful, and there are 2 different strengths that come. The other thing about anaphylaxis is the education, that if you can't identify the trigger, we have to treat, and this is where the difficulty arises, especially in our country, where we don't have the auto-injectors available. So normally what I tend to tell my patients in Ahmedabad is that you give them an insulin syringe, you give them a 1 in 1,000 vial, you actually ask them to draw it up in front of you so that they can draw 0.5 in front of you with an insulin syringe, right? And they should have at least 4 insulin syringes so insulin syringe, you can use the same needle to draw up, they can be accurate with their 0.5, and you give it adrenaline. Now the only thing is, if the patient is a bit thicker, then you might have to use a larger, longer needle, right? So then you might have to prescribe a 25-inch needle, a 25C needle, which is 1.5 inches, because only then it will penetrate into the muscles, right? You don't want to give it into the subepidermal region where there is just dermal fat and it won't get into muscles. But otherwise, for thin people and muscular people, usually it is good enough to just give insulin syringe as well. But you have to ask them to draw them up in front of you and see the time and tell them the importance of that timing as well. And possibly even educate a couple of the other family members, as well as tell them to educate those, if it is kids, the caregivers as well. And it is a myth that food anaphylaxis is not rising in India, by the way. Peanut anaphylaxis is definitely rising now. So we definitely need to actually start educating these people up to how they should be using adrenaline. And that is possibly being proposed as part of the school teacher training program as well. I normally tell them, and I put this up here because you can download it yourself. And the importance of this is twofold. One is obviously for the patient education, but also because it helps to educate other treating physicians as well as other carers, because this emergency can happen without any medical personnel being around. So, and this is on our Askia website. So you can just download it and print it out in a PDF format, and then place the patient's name and everything. And obviously here we will have EpiPen or AnaPen on it. You will have to write down what needs to be done in terms of syringes and everything. So that is one thing about anaphylaxis. As an allergy specialist, you have to know how to manage anaphylaxis. And as I said, do send off tryptases as well yesterday, okay, whenever you suspect one. It is one of the most important tests that now we have, which just makes the diagnosis, and there are not many other differentials if that's high. Now talking about, in next 5 minutes, about other allergy medications. I think I've done to that antihistamines in last 1.5 days. But you all know it can be used in a higher doses. It is called type C in pregnancy, but can be used freely, okay? right? So we don't tend to stop antihistamines during pregnancy either, although the classification is type C and it used to, but those are from the previous studies on mice and everything. And with these drugs, no one is now going to do, the pharmaceutical companies are not going to come out and do proper, again, studies which are going to cost millions, and they are happy to let it remain in the type C category, but it can be used in pregnancies as well. Possibly use non-sedating. As I said, sedating possibly has no role most of the times. In case. If you were to use a sedating antihistamine for an allergic condition, I would rather use doxepin. So I think you asked me this question, Avinash, yesterday. Not me, I mean, you asked the floor about the use of doxepin. Doxepin is a better one. So it is an anxiolytic, but it has an antihistaminic properties as well in terms of H3 receptor blocking. So that's what you would use. Not Evil. Evil is no more used in the modern day practice. All of them have similar efficacy. But switching helps. There are things science can't answer, and I can't answer as well why that works, but we've seen this well documented across many patient histories, that cetirizine was not doing anything and fexofenadine suddenly starts working. You shift them, right? But stick to one if you're increasing the dose, and you can go up to 4 tablets a day. Obviously, the increase in the dose depends upon the indications as well. So, for example, if it is like eczema, 4 times is not going to work. If 1 doesn't work, 4 doesn't work. For urticaria, it works because histamine is the primary reason why they are getting that problem. Whereas here, we are trying to treat an itch because of atopic dermatitis. So there, increasing it to 4 times is not going to work. So this increasing to 4 times story is mainly, more importantly, for urticaria, possibly also for seasonal allergic rhinitis, where they tell you about these classical symptoms. That I take it in the morning, I go to work, I'm fine and everything, but when I drive back, and reach home, I start getting symptoms. Well, then you possibly know that they might need an additional antihistamine, at least to cover up during that season. All right? But otherwise, apart from urticaria, 1 is enough. And if 1 doesn't work, 4 won't work. Yeah? H2, I have already said that H2 blockers are very important in terms of your armamentarium. And they are also important in just angioedema as well, as Ankur was saying yesterday. Right? So before you call it bradykinin mediated and not histaminergic. So the only way to do that is to give them a trial of antihistamines to see if they work, right? But before you call them bradykinin mediated, you want to do both the H1 and the H2 blockades before you start exploring the bradykinin, the medications for the bradykinin pathways, right? So use the H2, don't forget the H2 antihistamines. Systemic corticosteroids, very short courses, possibly they've already been documented in asthma, I think, for all the practical purposes. And one of the reasons they say that anti-IL-5 or Xolair did not have increase in parasitic infections in India is because these patients have been put multiple times systemic steroids. And if steroids can't cause fulminant strongyloidosis, nothing else can. So if they've had steroids, multiple courses, and that's when you decide on these monoclonal antibodies. And if they've not had parasitic infection do much in terms of respiratory failure or something, your anti-IL-5 will be safe anyway, right? So that's why you don't worry about parasitic infections. This is an anecdote, by the way. Topical steroids, I don't have any conflict. Avinash, you can manage as much dermatitis as you want. There are 4, and obviously you keep cycling through them. And the role of topical calcineurin inhibitors is they are very weak. So they are not used for steroid sparing, by the way. They are used to prevent topical steroid-induced side effects. And that's why you use them only on face most of the times. Because you don't want steroids on your face, especially the potent ones. So most of the times the add-on therapy of topical calcineurin inhibitor is with milder steroids on face. No one has shown any steroid sparing, and they are very bad in terms of their anti-inflammatory effects. So only very mild forms will be affected by it. And obviously you have to keep on using it and use very potent ones before you say that eczema is bad and you need to go into systemic therapy. And you have to talk about adherence to the patient and the use of moisturizers, and use of simple things like you should never, rub dry. You should always pat dry. These little things can do worlds of good for patient. Just this, not drying and just pat drying and always keeping, after you take bath, keeping it a bit wet, putting your steroids first thing after bath, because that's when your skin is still, hydrated enough, if you've pat dried, obviously. These little things do wonders for eczema patients. And I can tell you there is nothing more heartening than managing an eczema patient properly with proper advice. It is a killer in terms of quality of life for the patient who suffers. So those things are what you need to mention, right? And the other thing, the air current was an excellent example. The covering during winters is an excellent example, that you never have transfectant heaters and those kind of things. So those are very important. But use potent steroids before going to systemic ones, okay? And don't keep using them all the time. You need to taper down to less potent as well, as soon as. So don't just keep using clobetasol, although patient might keep using it anyway after they have found it very useful. Montelukast, or that's I think the most common ones. It keeps getting talked about, and there were trials when they came in, and they were thought to be wonderful drugs because they thought that's the one thing that is going to bridge the gap. After antihistamines, everyone thought it was leukotrienes and everything. They've not actually shown that much promise, to be honest, except for pediatric asthma maybe. But then you have to be very careful about the side effect, which is depression. So if you prescribe Montelukast, and I know it is taken even over the counter lots of times as a co-prescription with antihistamine, you have to be very careful with pediatric patients to ask them about the mental health, because that generally doesn't appear on our tick boxes when you're talking to the patient in an outpatient clinic, right? Allergic rhinitis, again, as I said, it has no role. No one has said additional role. They have compared it with antihistamines and said they are equipotent. But then if you're using antihistamines, why would you use leukotrienes? So there is no added benefit of using them at all. So GINA guidelines don't even mention, as you know, now with the use of monoclonals, they don't even mention anywhere Montelukast appearing on their list of stuff to do. So, and I know it is being prescribed so commonly, so that's why I'm putting it out there. Decongestants should never be used in allergic rhinitis, and I'm sure this was told enough. And anticholinergics, they are, I think, underused in asthma management. As you saw from GINA guidelines, they do fit in with moderate to severe. I think it is worth a go, even if you think it is pure asthma phenotype and not the asthma COPD phenotype. If you're managing asthma, that is, they still have a role to play. I'm going to actually not talk about any of this. We've had enough of them. But obviously, we know why we've started suddenly talking about the type 2 asthma and non-eosinophilic asthma, because the way we manage is going to be totally different. And that's because, I think I might just end with this one slide, is that this is the trajectory that I keep talking about, why I think allergy is at a stage where rheumatology was in 2000. So when we were learning about the pyramids, and I'm sure you all have heard about the talk, you start from bottom and it was up, and only then disease-modifying agents came in quite later. And that's what happened with asthma till about 10 years ago. It was always symptomatic treatment, right? So there was bronchospasm, you give bronchodilators. There was nothing about what is the underlying disease, what is the inflammation, what are the long-term remodeling that is happening, and ways to tackle those, right? We added steroids, which was again non-specific. Again, steroids were not actually causing remodeling or or causing alleviation of the underlying immunopathophysiological phenomenon. It was again dampening the immune response non-specifically. And that is where now the knowledge that has come in with the use of these biologics is where we have started using multiple stuff. And not just type 2 pathway, as we know. Type 2 is just one of them. It is then the eosinophils, and then there is now the epithelial cell itself, right? So TSLP molecule and dupilumab, and they have shown that actually the epithelial cell itself is one of the drivers for the antigen presentation and the ever-perpetuating inflammation that is causing the problem. So that's why this trajectory, as you can see on the left side, you can see how many stuff has come in the last 10 years, right? And it keeps growing. You heard about the success of dupilumab, and I would vouch for those photographs. It's a life-changing thing. Patients get better within 2 weeks. And you can imagine eczema, imagine having a small patch which is itchy, will keep you awake at night. These people have like a SCORAD of about 70% of their body being involved. You give dupilumab, 2 weeks, it is like, how we saw, Scafo working with psoriasis, it melts away. Same thing happened, literally, the rashes melt away. So dupilumab, and thankfully it will come out of patent someday, and we Indians are all well prepared for biosimilars. So these will be coming in next 5 years. I think I'm going to stop at that. I think rather than, we've heard all of this enough.
Okay, thank you, Dr. Pravin, for the nice presentation. I'm sure there may be many questions from the audience and also online. Yeah, Dr. Avinash.
So in setting of autoimmune diseases, particularly lupus, when we see angioedema happening, generally they are mucosal, GI involvement is there. But would you still recommend trying H1, H2 blockers? No, right? Tranexamic. Because as you mentioned that before you figure out whether it is bradykinin mediated or it is histaminergic, you can still try H1 and H2.
Yeah, but if there's lupus, you already have a reason.
Yes, and plus because if there is mucosal edema, GI involvement, it is more likely.
And as I keep telling, in acute onset lupus, when you get these recurrent angioedemas, they are not very amenable, as we were discussing yesterday with Anupam sir, to steroids. And that's where the co-prescription with tranexamic acid, as we've discussed. So you would give steroids, but steroids normally, urticaria works beautifully. If they have recurrent angioedema is one of the things about their active lupus phenotype, with C4, C3 both being extremely low, you would prescribe tranexamic acid at least for the first few weeks with steroids and everything, and then withdraw tranexamic acid.
So there's one online question that was asked a little time before. Does anyone have any experience with injection histaglobe for allergies? Non-specific treatment of allergies.
Dr. Raj will answer that. I've never used it.
That is a passive antibody, and it lasts for a shorter time, not for a longer time. So sometimes it happens that pre-season, patient is not on a immunotherapy. So pre-season we can give a histaglobe, which would be effective around for weeks, not for long.
So they don't tell you what it is, and they say it binds to histamine, and they say glob comes from globulin. I am still to convince myself there is an immunoglobulin specific for histamine in it, but that's how they sell it. But I've never used it.
Any question from the audience? So is the when we are using higher doses of antihistamine, like 4 times the scheduled dosages, do we need to monitor the cardiac for cardiac side effects? I mean, is it really a problem, the QT prolongation with the?
No, not at all. Drowsiness can be a problem, although we keep calling it non-sedating. As I said, you have to keep changing, but no, ECG monitoring is.
I just wanted to know, a patient has come with severe anaphylaxis, we have given adrenaline, the symptoms have improved. So how long to follow this patient?
4 hours.
Do we need to give any treatment before we discharge this patient so that he can be safer for next few days or few weeks or even few months?
Yeah, so so the Australian Clinical Immunology we have published these guidelines. 4 hours is minimum for a monophasic anaphylaxis after improvement. So blood pressure usually comes back within 5 minutes. So then you have to observe for 4 hours, and the cutaneous symptoms should all be gone. So 4 hours after the resolution of symptoms. The follow-up advice, the one most important thing is the adrenaline, and that's why you have to take that time to teach them how to withdraw, how to give it to themselves, and all those kind of things. You obviously have to find the trigger, which obviously not on that instance. You've already given antihistamines and everything, so you can't do much testing. You can still send off for specific IgE. But antihistamines, to be honest, if it is a very mild illness, we sometimes do give them that, and also they are easy to carry. So we do tell them that you can carry it. So if they just came with acute onset severe urticaria without any respiratory symptoms or cardiovascular symptoms, we do sometimes say that you can carry antihistamine till you come back in the outpatients, and we do all the testing to figure out the trigger.
Can you comment on biphasic anaphylaxis?
So that came from animal model, as I told you. So there was this animal model of asthma. Oh, they are. So as I keep saying, don't get me wrong, there are. But the whole idea, the concept came from the animal model of asthma. So they did this bronchial challenge testing. They had this. They treated with adrenaline. They went away. But then they found the mice again going back. And that's how this delayed phase response due to IgE came in. And lots of that, actually, to be honest, is mediated by cytokines. So mast cells, and I thought I had that slide here, but possibly not. So mast cells, there are preformed granules. So there are 3 waves of mast cell mediated release when mast cells get activated. So the first is these potent ones, which cause vasodilatation and bronchoconstriction and immense alpha and beta blockade and kill. The second phase then is your arachidonic acid metabolites. So that's when your leukotrienes and everything gets released, which is anywhere from starts in 30 minutes and I think up to 3 or 4 hours. And then the third phase is cytokines. So even cytokines are released. Mast cell doesn't die when it degranulates. So it's not as if it's burst open and it's dead. The cell is still intact. And if it gets activated and that signal reaches the nucleus, it causes increased transcription of those cytokines. And these are the ones that are thought sometimes that can cause. So they can cause complement activation. So C5, the anaphylatoxin concept of C5a and C3a, and that's where the role of steroids came in. But whether I've seen maybe 1 or 2 cases, possibly.
Yeah, I think as a clinician, nobody will like to see even a single case of anaphylaxis in their life.
True.
That is for sure. The reason I asked was because there is a chance that this patient can have a repeated exposure to agent. That is one thing. And plus,
Yeah, that's why you will give adrenaline.
there is some scope for the usage of H1 blockers as well as corticosteroids for next couple of days, even after the immediate severe anaphylaxis. You don't prescribe that?
Nah. So yes, one more concept actually, which I have not mentioned. I found something that I have not spoken about, despite speaking for so much. The environmental allergens never cause anaphylaxis. Okay? तो मैं ग्रास पे सो गया था और मुझे एनाफाइलैक्सिस हो गया, नहीं होता है. ग्रास पे सो गया था, एनाफाइलैक्सिस हो गया, तो भैया वो you have to find that bloody insect which stung them. So that's why it is important, not required to give it delayed. So if you have a full-blown case of anaphylaxis, environmental allergens never do it. So anaphylaxis it is mediated by drugs, it is mediated by stings, right? It can be idiopathic, foods, that kind of thing. Or idiopathic mast cell activation syndrome. It is never mediated by environmental allergens. So aeroallergens, grass pollens, tree pollens, moles, house dust mite, animal dander, they can cause severe symptoms of allergy, but not to the point of anaphylaxis. Like they won't kill them.
Right. Any questions from the audience? Okay, with this, yeah.
Any major side effects of the anti-IL-5 blockers or that we need to know about?
No, very safe, very safe. So I'm sure you've read the ERS report, 15 years use of MEPO, no signal whatsoever.
Thank you.
Thank you.
And for the last talk in the session, I would like to invite Dr. Raj Bhagat. He's discussing the principal practices and outcomes of allergy immunotherapy. Many of us had brief discussions with him during the interval time also regarding immunotherapy. So let's hear from the horse's mouth.
Good afternoon, everybody. I think it is a tough time after a meal to hear multiple lectures, but I will finish up a little bit early. Before going for any immunotherapy, absolutely necessary to go for the history. Without history and investigation, we can never go for immunotherapy. So present history, how the allergen history, what is the seasonal history, what has in the past, and then we conclude with confirmation of skin prick test. Always, immunotherapy doesn't work alone. So we have to find out the trigger. If it is possible, it has to be avoided. There is some protection required or prevention measure to be taken, specific therapy for control of symptoms, and then we go for immunotherapy. Immunotherapy is the only treatment which sometimes or many times cure the disease. Otherwise, all the therapy for this are only symptomatic. And immunotherapy usually starts with the very low concentration and gradually increase the concentration as well as the amount. This was very long back, before 100 years. It was found that allergen exogenous has been culprit for causing some of the symptom and which is immune mediated. And at that time, one another person who was having grass pollen allergy, and he introduced the pollen himself, and he was very badly shocked and treated. But after that, there is a revolution, and there are some chains of immunotherapy come in the market. So from 1920 to 2020, I think it is more than 100 years of immunotherapy, and there is ample work has been done by so much or multiple scientists. The mechanism immunotherapy works. Usually the symptoms of allergy is produced by stimulation of Th2. Here there is a diversion of Th2 to Th1. So it produces the blocking antibody, that is IgG, and this decreases the response of allergen. Immunotherapy can be given in all the conditions when there is a dermatological, either it is respiratory, either it is eye, either it is for food. Now there are some research is going on, and particularly the food anaphylaxis, there is a trial-based immunotherapy is right now on. Insect, a very good response, and a drug. If there is no other option, then only we go for a drug immunotherapy. Common allergen here, this environmental allergen, pollen, dust, some molds, animal dander, and in-house you find maximum, that is mites and cockroach. And for urticaria, the insect, food, mites, and drug. These are the common allergen which causes the symptom. Environmental allergen has increased the potency because of this environmental pollution. There is some environmental change, and this all has caused the increase in the potency of allergen, and this has increased the allergenicity. So it prolongs the symptoms also. Usually the history where it is important to choose the allergen for immunotherapy. If we test, there are chances that we may get around 10 or 15 positive skin prick test result. So is it possible to desensitize altogether? Never. The principle of immunotherapy is that less the number of allergen, better the result. And it is advised that there should not be a mixture of 4 to 5 allergen in a single vial. So the history, again, it comes very important that they are giving symptoms either outside house, inside house, what is the time, like dust mite and other cockroach can cause symptoms night, early morning. The pollens, it is outside, there is a season of pollen. Usually we are having this seasonal pollen symptoms, and right now it is on. So patient can give history of, yes, I am getting symptoms, just I am going out, and this is only second and third month every year since last 7 years. And if we test, we may find the multiple allergen positivity. But here our target would be with the history. If it is restricted to season, we go for that restricted pollen desensitization. It is very, very important to take all the cares when we are treating particularly honeybee with immunotherapy. And it has either way. Honeybee, it has many times give anaphylaxis even during immunotherapy, but other way, if they complete the immunotherapy, they almost are out of danger and they don't get any incidence of honeybee, anaphylaxis, or even urticaria. Food, again, we have to go to the deep in the history. Food, again, there is some food, there is a trial-based immunotherapy is there, and particularly some gram and peanut. It is here. We don't find more in the cashew and other things which is more in abroad, but gram is peanut and gram, that is very common in our country, and the work is on. Immunotherapy is, one is a subcutaneous immunotherapy, one is sublingual immunotherapy, oral immunotherapy, intralymphatic immunotherapy, bronchial, and intranasal. Out of which all, in market and in practice, that is subcutaneous immunotherapy and sublingual immunotherapy. Subcutaneous immunotherapy is very conventional. It can have hypoallergenic depot therapy. We can go with the rush therapy, we can go with the cluster therapy, or sometimes patient has already taken the immunotherapy, but after 10 years symptoms are there, we can go for the pre-season immunotherapy. And in certain cases, like even honeybee, if we are not getting good response or we are getting some side effect of vaccines, we can go with anti-IgE and vaccine together. Different units available for the liquid allergen extract, we have weight by volume. That is what we use here in India. As already very excellent Dr. Pravin explained that what are the things and how to tackle anaphylaxis. While giving immunotherapy, the only fear one is anaphylaxis. And it is very important to treat promptly to prevent further deterioration. So emergency measure has to be taken there. And we have to keep all the things ready. So even with the immunotherapy, we keep the adrenaline pre-filled syringe over there. And then we give immunotherapy. It has two phases. One is a built-up and second is a maintenance phase. Built-up means there is a diluted form of allergen extract, and gradually we are increasing the concentration as well as increasing the volume. So that is diluted in 1 in 5,000 and reach 1 in 50. When we reach 1 in 50, it would be a 0.7 ml. The schedule is initially twice a week, then once a week, then every 15 days, and then after every 21 days, and then it goes to the every month. When it goes to the every month, usually we reach at the level 0.8 ml, which is the desirable and optimum dose for immunotherapy, and the concentration is 1 in 50. For insect and mites, the higher dilution is required, 1 in 50,000, even sometimes 1 in 5 lakhs. When this is important, here is the importance of the skin prick test. Sometimes we have a in vitro test, it is class 4 or class 3. But when we go for the skin prick test, you find +4. So here, if we go for the immunotherapy, there are chances of some reaction. Here we can go for the dilution, and if required, further dilution. So it would be a gradual escalation, but it would be a comfortable. Previously, hypoallergenic depot therapy was available. Right now, unfortunately, it is not here in India, but it was having excellent result and almost nil side effect. It has a very good safety. Second thing is number of injection, it decreases. It has to be given every 6 to 8 weeks. And here we are giving every week 2 injections to start with. It has a faster updosing, so very early response is there. And as there is less number of injections, so patient's compliance also would be better. These European and US people, they have different mind. Usually European, they give single allergen immunotherapy, and the US people, they give a mixture. The mixture means there is a mixture of the mites with the pollen. Here also we give in a mixer, but the ideal one is to give separate pollens and separate mites. But again, number of injections, it increases. And we are getting result with the mixer, so we are on with the same therapy. This rush immunotherapy in a cluster, this both has to be done only in ICU, not even in a hospital. It should be done only in the ICU. This immunotherapy rush means you are giving very rapid response and giving 8 injections in 3 days or at least 8 injections in 1 day. So increasing the dose from low concentration to higher concentration within 3 days. And it is such a that every 2 hours you increase the concentration. Every volume is increased, and on the second day, again concentration is rise and the volume will increase. So by 3rd day and the 4th day, you reach to the level of maintenance phase. So built up very rapidly, but here there are chances of crash. So always keep in the mind, unless and until it is extremely important and we have to treat it, otherwise don't go for rush immunotherapy. The same happens for the cluster. The cluster, multiple injections are given in half an hour to 2 hours, and dose of target which reach within 2 to 3 months. This was previously used therapy when people were coming from the town, villages. So they are not able to come regularly for the vaccine. So at that time, the cluster was given to them. But again, it has to be done under supervision and only with the ICU. Duration is almost 3 to 5 years, and our practice is 3 years. In certain cases, lifelong immunotherapy has been given. So they are still on, after 50, 20 years, 20, 25 years, they are on therapy. Sublingual, that is other than injectable. So intranasal, it was found not much effective. Oral, it was also not found effective. There is some effectiveness in the bronchial, but there are chances of some patients, those who are having sinusitis and asthma, there is some variation in the deposition and absorption of the material. So these three are out, but sublingual therapy is excellent, and right now it is in market with the single allergen, and it gives excellent result. It is very convenient, very safe. You can go for updosing very rapid, and here we can give the dose of allergen 100 times than compared to the injectable immunotherapy. It is very beneficial in the children and gives very good response. For different allergen, it is available. Ideally, here in sublingual, pollen should be given different and the mite should be given different. Slit has very good result. Again, with immunotherapy, other measures has to be taken. So surrounding, environment, in-house, cleanliness, certain food, exertion, emotional upsets. So altogether, we have to give it to the patient, and then you go for the immunotherapy. Sometimes, otherwise, it may not work. This is mites, very common. Vacuum cleaning is done for that. And these are the all conditions you should keep in mind, and also give a treatment simultaneously. How to judge immunotherapy? There are nothing is available right now for judgment of immunotherapy except clinical improvement. So there is, if before, during, after immunotherapy, what is the improvement? What is the decrease in the frequency of symptom? What is decrease in the number of pills? So this is all, or there is off treatment. These are all the judgment clinical for immunotherapy. Otherwise, previously in India, IgG4 was available. So you can give immunotherapy, start at that time, take IgG4, 1 year, 2 year, and 3 years. Usually there is a rapid raise in the IgG4 if your immunotherapy is working. But right now, unfortunately, it is not available. And other leukotrienes estimation can also be done. I think it will be available here very soon, but right now it is not available. So immunotherapy is preventive. Rhinitis to asthma. It is, again, decrease the sensitization of multiple allergen from single to poly. So curative and preventive therapy, that is immunotherapy. And it also prevent the symptoms, aggravation, exacerbation in patients when it is on with a sufficient dose. Probably it may happen, those who are at the high risk, there would be a cord blood analysis, and in early phase or early childhood immunotherapy, there can be planned. That is also under trial. So intralymphatic anti-Ig monoclonal antibody already described. Intralymphatic, it is, trial is on, and it has been found excellent. Only thing, you require a surgeon together to give the intralymphatic allergen extract, and it is required every 6 months. So number of injections are very less, only skill is required, and the results are coming very good with the intralymphatic immunotherapy. The bacterial adjuvants, allergenic peptides, recombinant, and genetic vaccination, these are all going on for the research. Probably sometime it also will come in market. Thank you.
Thank you for that very useful and very important presentation on allergy and immunotherapy. I think all of us wanted to know more about the various types of therapies available and what is the response to this. So I'm sure your lecture has actually cleared many
Allergen specific.
Because IgG4 is routinely done in our lab for last many years.
No, sir, for allergen specific.
Allergen specific. Okay. So the presentation is open for discussion, question, comments.
So are you routinely using sublingual immunotherapy?
Yes, I am using both injectable and sublingual, but more preference is right now with the sublingual.
So from where do you get these immunotherapy knowledge?
It is right now available. There are 3-4 vendors, but we are getting from Delhi, Faridabad. There is All Cure Pharma and Allvec Pharma. We are getting allergen from that. Even immunotherapy also from them.
Okay. So can it be customized depending on which allergen you want against it?
Bilkul, absolutely.
And you mentioned 3 to 5 years, and then on the other side you also mentioned that they are patient for many years. More
Yes. There are few patients, those who are on immunotherapy, those who are having after 5 years some symptoms, and they used to take it every month, every 2 months, and they are on therapy right now with good response.
Dr. Raj, at what point of time, I believe there will be failures to immunotherapy. So at what point of time would we say it's a failure to immunotherapy, and approximately what percentage of patients would you call it failure? And one more question I had, what are the specific indications for immunotherapy?
Okay. Failure usually by 8 to 10 months. Usually immunotherapy starts working when we go for the maintenance phase. So after 6 months, you will get the response of immunotherapy. Initially, there are chances that you may get some trigger of symptom with the initial immunotherapy. But if by 8 to 10 months, if there is no response at all, then we can say it is a failure of immunotherapy. Usually we judge every year, first year, second year, third year. Again, before that, symptoms, severity, drug requirement, and what is right now. So if there is improvement, at least there should be 50-60% improvement in the first year. And if it is so,
how will we measure that improvement?
Number of pills, number of exacerbation, clinical visit.
What are the chances of relapses?
Yes. After 5 years, it is very less. I have not seen a patient single with the relapse. But yes, there are few patients after 10 years, 15 years, they are having some positivity and some symptoms.
Regarding the specific indications, at what point of time will you decide to take up a patient for immunotherapy?
The first one is honeybee. If patient comes with the honeybee anaphylaxis, I straight away go for immunotherapy for that patient. Secondly, if there are pediatric patients where we can help, because these pediatric patients are having some rhinitis, and later on they come with the asthma and other conditions, dermatological. So in a pediatric patient more than 3 years, definitely I will go for immunotherapy. In adult, up to the age of 60, mite symptom or seasonal symptom, there also we can go for immunotherapy. Like if there is a season for the pollen, we go for the pollen immunotherapy. We may not get 100% response, but yes, we get some reduction in the exacerbation, reduction in the symptomatic treatment of patient, and the time for the patient will be so comfortable that with the minimum medicine they can cover this season. That is when we are not getting, we are getting some side effect, or immunotherapy has some serious effect and still it has to be given. Then anti-IG, and then after we go for immunotherapy. Again, that is venom.
Sir, sometimes auto serum is also used. So where does it come in the spectrum of immunotherapy?
Auto serum, yes, but for chronic urticaria patients, they go for auto serum. Autologous serum, how it works, I don't know, we are using. But we are getting response with the auto serum, that is what 5 ml, 10 ml extract and 5 ml to be injected. It has not to be on any paper. Still, doctors, everybody are using, nobody is telling that I am using. What is the scientific way, I don't know, but I am also using and it is working in chronic urticaria.
So Is it something like vaccine kind of thing?
Madam, 10 ml blood Vitro, and we separate the serum, intramuscular.
So I published a study of autologous serum therapy in chronic spontaneous urticaria with Professor Bhagat, and we did almost 300 patients in Allahabad and Lucknow. And we've published it in our journal. And autologous whole blood therapy remains quite popular in countries like Germany, Switzerland, etc. And again, we don't know how it works. We tried to find out markers of which patient it would work for. So we do an autologous serum skin test before we do autologous serum therapy. And initially we thought that patients who were autologous serum skin test positive would respond more frequently, or it could be a biomarker. But we saw that a lot of patients who are autologous serum skin test negative also respond to autologous serum therapy. So I agree, it is mysterious how it works, but it is not as unscientific as you think it is. There are published papers. I personally have experience. And as a treatment of last resort for patients who cannot afford omalizumab and are willing to come every week, if they persist with it for 6, 8, 10 sittings, in our series, almost 60% of them got decent remissions or were, from 4 antihistamine pills, and still the urticaria not controlled, were able to come down to 1 pill and urticaria well controlled, things like that. And there were some remarkable complete remissions as well.
Thank you, sir. I think we'll wind up for shortage of time.
What happens to SPT after immunotherapy? Does the SPT turn out to be negative?
No. It remains positive.
Memory is there.
We had a very interesting
that is why the end result has to be done with the IgG4 specific. SPT is not a marker for your improvement in the therapy. It will remain positive.
We had 3 very interesting sessions, talks in the session. We'll go back with beautiful memories of the session. Thank you.
Sir, for chairing this session in which we shall be discussing 3 interesting cases. Clinical immunology and rheumatology from SGPGI itself, and currently he is practicing as assistant professor in SMS Jaipur.
Longest serving assistant professor. So I think this is going to be more of a revision. We have some set of questions at the end, and since it is a revision, so we'll ask the audience instead, and I would request Dr. Kunal to close the exits so that they don't escape. We're going to start with Dr. Pravin. Or is Dr. Pravin?
Good afternoon, everyone. The case I will be presenting today is the patient or is the relative of one of my medicine colleagues, and who he has been treating from last 2 years and having difficulty in treating the patient. So I'm glad I got to present the case today at this platform. I hope to get some inputs regarding diagnostic workup and further management of the patient. So the patient is a 29-year-old female who is a known case of major depressive disorder and hypothyroidism for last 3 years and taking sertraline and SOS amitriptyline. And the patient had a history of on and off low back pain for which she used to take NSAIDs but had no reaction at any time. But in the May 2022, after taking naproxen, she had complaint of mild itching with few maculopapular rashes over whole body. But the patient ignored those symptoms and continued to take that medication. And on the next day after taking the medication, she developed severe bronchospasm and associated with stridor after 5 minutes of taking of naproxen. And the episode was so severe that patient developed shock and had to be admitted into the HDU. And that time patient had to be given around 3 to 4 injection epinephrine at the interval of 4 to 5 minutes, and also given IV fluids, and after that patient recovered. And at that time patient had to get admitted for around 5 to 6 days in HDU, and she continued to have recurrent episodes without any identifiable trigger. And after that patient was given even trial of oral corticosteroids around 1 mg per kg for 5 to 6 days, but she had no improvement in the symptoms, and then was given antihistaminics, but there was not much relief. But after improving of some symptoms, she was discharged. And then she used to have recurrent similar episodes with symptoms of varying severity. These episodes comprised of diffuse itching, which used to be very severe and associated with shortness of breath, which was mild to severe, and sometimes associated with stridor. And she used to have headache along with these episodes, which was mild to severe and horocranial in character. And at that time, she was treated with symptomatically with antihistaminics, mostly with pheniramin, Avil at that time, and levocetirizine. And nebulization with budecort and Duolin was given, and epinephrine was given in severe episodes. So these episodes are still persistent. And then in routine investigations, all the parameters were normal. C3, C4 was normal. C1 esterase level were normal. As she was from medicine background, so he had done almost all workup, as such I know. And C1 functional assay was normal. Bone marrow aspirate in view of systemic mastocytosis was normal. Flow cytometry was done, in which no markers were positive. And upper GI endoscopy and colonoscopy along with biopsy were normal. So he had also the patient underwent next generation sequencing, and there was one variant of unknown significance, card 11. So actually when I got this report, I saw through it, and it is associated with Benta syndrome. So as such, it is seen in neonatal and pediatric age groups associated with the immunodeficiency. But some case reports were there which showed that association of it with atopic dermatitis, but not with any severe anaphylaxis. So the current treatment the patient was receiving was antihistaminics and nebulization with budecort and Duolin. And severe episodes were, at that time, she was treated with FFPs. And C1 esterase inhibitor also was tried, but only single dose was given. And then in October 2023, he read some case reports regarding the role of rituximab. So he had also tried, because he had gone to multiple doctors, but there was no clear-cut treatment guidelines. So he was not knowing that what to do. So he gave 4 weekly doses of rituximab 500 in November 2023. After giving that, she had some response, and the severity of those episodes decreased. Like she used to have was getting antihistaminics. So she was like fine for around 3 to 4 months. But around 3 days back, she again had a similar severe episode and had to be given injection epinephrine for that. So that is the case which I have presented, and there are many questions which I want to ask regarding the further workup or how to treat the patient, so that at least I can help him some way.
I think that's a very practical question out there. The first question that would probably come to her mind is, she has been on naproxen for a long period of time. How common or uncommon it is to see anaphylaxis occurring during third year, or did we miss another trigger which might have been there and started mislabeling that naproxen for that episode of anaphylaxis? What's your comment on that, sir? Like during the course of third year, fourth year of the NSAID?
That you can get, yeah. So that's a very common history that we get. I was taking it long period of time, and then one day, bang, why do I become reactive? That tryptase level that you said, that was a baseline tryptase?
No,
or
sir,
during?
I asked yesterday night, so he said that it was in between when the patient was not having any episodes.
Okay, so the first thing to do is episodic tryptase.
So that I have told.
Yeah, so you give them the form.
Yes, sir.
Because that will totally change the way we are going
Yes,
to do
sir.
the law. In between these episodes, have you given long-term? So this could be, look, as I was telling, I was talking with whom about, I think it was Vishad. So this is the recurrent acute urticaria angioedema. And I know that we actually tend to call chronic urticaria when it is persistent for more than 6 weeks.
Sir, actually, she used to have only the skin rash at the first episode.
Achha,
but after that, there
angioedema.
was no skin manifestation, only severe wheezing, bronchospasm.
So
That
lone
was it.
angioedema, yeah. Which
Yes,
is only 10% of cases can present of chronic urticaria angioedema with just recurrent angioedema episodes. So obviously you'll have to differentiate histaminergic from bradykinin mediated. And the first thing you would do is possibly give antihistamines. Now, naproxen obviously was a cofactor here. It must not be the principal driving factor if it was lone angioedema. So it could be possible that. So possibly it is possible that the episodic tryptase is going to come back normal. In which case then you label it as lone recurrent angioedema, possibly histamine mediated, because that's the common one. And you will start H1 antihistamines to start with, and you manage like chronic spontaneous urticaria, so you can go up to 4 times and add on H2. What I would do is I will go back to that next-gen sequencing. Obviously, there was some good bioinformatics person. I like it when they've reported VUS. That means someone has looked at the data.
Yes, sir.
Obviously, card 11 doesn't mean anything. It is with rare primary immunodeficiency syndrome. But I would look at c-KIT mutation. I would ask them to probe specifically if they can look at 6 of the hereditary angioedema genes and one of c-Kit. So you would want to ask them specifically that question. Because as I was telling yesterday, whole exome sequencing is 30 terabytes of data. So you have to specifically ask them that look at these regions, and then they would. Unless, it is a big company like Invitae or something, which have, very good inbuilt bioinformatics platforms in them. Okay. That's what I would do.
Two questions that I have. One is, if the tryptase level are coming out normal, the baseline, how do we expect any mutation happening in the c-Kit region? Yes. Yeah. And second is, regarding the use of rituximab, does it really help? And what were those episodes which were responding to epinephrine when she would really get? Was that anaphylaxis?
Well, that's why I'm saying histamine mediated, because they were responding to epinephrine. If epinephrine was not helping, then it is bradykinin mediated. We would have gone straight to tranexamic acid.
Yes.
But because they are responding to epinephrine, that means it is histaminergic.
Yes, sir.
So will these subset also respond to cyclosporin once we have tried H1, H2?
We'll manage them on lines of chronic spontaneous urticaria angioedema, yes.
Okay, sir.
Okay. But you need an episodic tryptase. And because you already have done the next-gen sequencing, you would want to ask those questions. Because the data is already there.
Yes, sir.
It's just mining it here.
Because mast cell disorders, they can have precipitation of anaphylaxis with non-steroidal anti-inflammatories. So that's well described.
Okay.
And because it happened with naproxen, and now you're getting fluttering manifestations later, that might be something to look at.
Have you taught the patient how to use self-use epinephrine?
Yes, sir. She knows, and her husband is a DM clinical hematologist, so he knows.
So mast cell disorders, all of them may have some kind of systemic manifestations like cutaneous mastocytosis, the systemic ones?
Not
the idiopathic ones will not have. Mastocytosis ones may have.
Exactly.
They are clonal disorders.
So that's why they came up with the MCAS terminology.
Okay. So they may not have any skin manifestations of mast cell.
So there are two types of disorders. One is due to mast cells themselves, and then one is what we call mediator-induced syndromes, which are episodic in nature. So the mast cell activation syndrome, the name was coined for that reason, where it was just the mediator-induced phenotype and not the mast cell load-induced phenotype, which is what urticaria pigmentosa and those kind of stuff are.
So, one more question to Pravin, sir. Sir, regarding use of tranexamic acid, so what doses do we use for prophylaxis and therapeutics?
I start with 2 grams at least per day. You can go up to 3. Obviously, there shouldn't be any thromboembolic risk factor and those kind of things. And then you down titrate. But you want to start higher.
So like in patients who are having underlying
tablets, I think it's a 500 milligram tablet. So you give 2 TDS, yeah.
Okay, sir. Okay, sir.
We'll move to the next case, Dr. Lily.
Good afternoon, everyone. Today I'll be presenting a case which was treated by our department as an outpatient case. I'll be presenting a case of a 25-year-old female who works in a multinational company. She presented to us with complaints of multiple erythematous maculopapular pruritic lesions over bilateral lower limbs, which the episodes initially were 2 to 3 times per week, but later became almost daily, and gradually they progressed over the course of next 2 years. The lesions also appeared on the trunk and later became generalized. Rarely she had concomitant lid edema. There was no subcutaneous edema or hyperpigmentation after the lesions disappeared. Diarrhea sign was positive. She also had chronic depression, and she complained of holocranial headaches during the episodes. There was no history of any diarrhea, GI disturbances, dyspepsia, syncopal attacks, hypotension during these episodes. There was no personal or family history of atopy, and there were no identifiable aggravating or relieving factors. So if we look at the disease course of the patient, she developed maculopapular pruritic rashes in the year 2017, which were initially limited to the thighs, which were controlled with antihistamines. Over the course of next 2 years, she developed generalized lesions and were treated with oral glucocorticoids. In 2022, she received cyclosporin as the lesions had increased in frequency and were not controlled with glucocorticoids and antihistamines alone. But she developed hypertension and cyclosporin had to be stopped for the patient. In 2022, when she came to our OPD, skin biopsy was done for the same and mast cell infiltration was seen in the biopsy. She was advised oral glucocorticoids and dapsone, but sadly the patient was lost to follow-up. So in investigations, her ESR was 38, marginally increased, CRP was 5.29, SGOT was normal, CBC didn't show any eosinophilia, MCV was 85.4, serum tryptase level was advised but was not done, serum IgE was normal, 25.5. In skin biopsy, there were superficial dermal vessels were surrounded by moderate infiltrate composed of lymphocytes and few eosinophils, scattered interstitial mast cells, and in IHC there was CD117 positivity, and on immunofluorescence there was IgG deposits in dermal vessels. So currently on telephonic conversation, we came to know that she was being treated with antihistaminics, oral glucocorticoids, 20 milligram per day, and autologous serum therapy, with which her frequency of the lesions have reduced to around once every 3 to 4 months for now. The pertaining questions are, when to think of mastocytosis in case of urticaria in this case?
So when to think of that, when to biopsy, and what's the treatment on the right?
I should have given a talk on mast cell activation syndrome actually. So this is classical mast cell activation syndrome, and you know what is the giveaway? The psychiatric symptom. So you know how we were discussing later on this whole long COVID story. As you know, if you look at it, long COVID story, it's all mast cell activation syndrome. And the giveaway is the psychiatric symptom. So if you have real mood disturbances, chronic depression, aggressive behavior, we tend to call it secondary reactive to the problem that you have. Here it is because of the mast cell itself. So I think that will be the biggest giveaway. As I was talking, even before you put in the cutaneous skin biopsy, I was talking actually we should get tryptase done, because this looks like mast cell activation syndrome happening. So tryptase would have been very nice. I wouldn't give any steroids. Mast cell, there is no role of steroids, long term. And I would add on H2 blockers. I might add doxepin. It will act as antidepressant as well. So that's what you would do. And I would monitor her neuropsychiatric symptoms very closely as well as dealing with, the urticaria side of things. Because that might be a marker of how much you need to escalate the treatment. And if that doesn't work, omalizumab. In here, it will definitely work. Autologous serum skin test, I don't know how it's working, but it's in the combination of lots of things. In chronic spontaneous urticaria, possibly, as nicely mentioned, it definitely works. We don't use it, but it definitely works. Because, yeah, we've heard talks on it in the European meetings as well. They are big fans of the serum skin test. This, possibly, I wouldn't do both. I would just add on the H2, I would add on doxepin, monitor the depression, and then add on omalizumab if those are not working.
Yes, sir. Sir, currently the patient is not in our follow-up, so if we can get her to come back, we'll try to.
But other than the psychiatric symptoms, what are the other classical
Brain.
symptoms we should?
So episodic nature. So it should be a combination, as I keep telling, of one of the four, as I said yesterday. So neuropsychiatric symptoms, very important. So, and that cannot be such, as diagnosed depression. It might just be brain fog. It might just be behavioral issues. So how like, I keep giving example of limbic encephalitis, the Morvan syndrome ke patient aate hai na, anti-LGL1, who just come with mood disturbance, and that can be the only feature of that. And then they need to have episodic in nature. They need to have involvement of either skin, gastro, and subjective cutaneous symptoms as well. They get more subjective symptoms than full-blown urticaria. So you actually documented diarrhea sign in your first. Well done. You should have done a biopsy then. So if you documented that, you will directly go for biopsy, because they are there everywhere, not just at the site of the lesions. If diarrhea is positive, you'll just do it and do it. So those, so gastrointestinal, neurological, cutaneous, and this episodic nature. Tryptases obviously at the time of the episode. Now obviously the normal tryptase and mast cell activation syndrome is all fibromyalgia. And there are so many of them going around. So if someone wants to start a mast cell activation clinic, that is a nightmare. That is like running a fibromyalgia clinic. Because 90% of them come with, I'm sure I have mast cell activation syndrome, here is my list of things. And then you tell them, look, I can't actually find evidence of mast cell activation syndrome. And then they show you what was shown yesterday, the 24-hour prostaglandin D4 secretions and can you do urinary PGE2 levels? And we tell them, look, none of them is validated. So that is a different story, but yeah. And in some of them, so the other thing I might mention with this case, just as a learning point, because mast cell activation is something we've not discussed actually in this, is you would do the KIT mutation studies in this. And the reason being, if that's normal, so here you want the mutation to be negative. And you know why?
Then it would be only cutaneous mastocytosis.
No, imatinib works. So if it is negative, because as you know, the c-KIT mutation, which causes mastocytosis, confers resistance, because that alters the shape of the groove where imatinib grows and sticks and stops the autoreactive pathway from happening, the tyrosine kinase. But if the mutation is negative, imatinib also will work in this. And imatinib has penetration into your brain, so CSF penetration. So it will really improve the neuropsychiatric manifestations.
So, sir, should we consider imatinib in this case, midostaurin, imatinib for...
If you have shown tissue infiltration and you have convinced yourself, you do event tryptase, and that is definitely high. So now your diagnosis is mast cell activation syndrome, right? You've shown tissue infiltration, you've shown symptoms that are consistent, and if you show KIT mutation negative, resistant to standard therapy, definitely imatinib. But you have to tick all those boxes before though. So don't start putting up all your urticaria on imatinib, by the way, if they are KIT mutation negative, because they will be negative.
So I didn't understand what you meant by doing a Darius test in this patient. Was there a persistent skin lesions on which you did the Darius test, or you just mean dermographism? You elicited dermographism?
Sir, she was complaining also that whenever there was stroking,
right.
Some injury.
So you elicited dermographism?
Yes, sir, dermographism.
Right, so that's not Darius sign.
No. Absolutely right. So Darius sign has to persist for at least 6 hours.
Yeah, and Darius sign is a sign in cutaneous mastocytosis where you have persistent brownish or leathery looking skin lesions. You stroke the lesion and you stroke the normal skin alongside. Yes. And the wheal on the lesion is much, much bigger, much larger, much more itchy than the normal skin, or there is no lesion on the skin. That's Darius sign. And that's why I think you're asking again and again about mastocytosis. I don't think this is mastocytosis. And a few mast cells in a patient with chronic spontaneous urticaria, as your pathology histopathologist reported, they were isolated mast cells. They are absolutely normal, expected in chronic spontaneous urticaria also. So it all depends on how strongly positive your CD117 was. Were they, more than expected in chronic spontaneous urticaria? Or, were they predominant in the biopsy?
On IHC, it showed that there is CD117.
There were a lot of cells?
Yes, sir. It was.
Okay.
If she's showing a perivascular spindle,
okay.
and the spindling is important, and the location is important. So, yeah. But that Darius sign is a very good point.
Any questions from the audience? So we'll move to the last case, Dr. Priyansh.
Good evening, esteemed faculties, my dear friends and my seniors. I would be presenting a case in the conclave. I would be glad to getting opportunity to present the case. This is the background history of our patient, who is a 47-year-old female who had inflammatory polyarthritis for the last 2 years involving small and the large joints, with an early morning stiffness for 2 hours, for which she was taking alternative medications for the initial 2 years. In the month of November 2023, she visited a local physician for worsening pain and swelling of the joints and was started on sulfasalazine and methylprednisolone 8 mg. December 21st, 2023, that is 2 to 4 weeks after starting the sulfasalazine, the patient developed high-grade fever, which was 102. and had skin lesions which are papulosquamous lesions all over the body with ulcerations which were non-blanchable and non-pruritic. She was outside admitted in nursing home for the new onset transaminitis which she developed, and was admitted in Global Hospital in 3rd of January to 9th of January with skin lesions and new onset lip swelling. Over there she had transaminitis, AKI and mild eosinophilia. Considering this possibility of a background history of alpha-salazine induced DRESS, they started her on 1 mg per kg steroids, 60 mg Vislon, and post-discharge the patient developed and was discharged on 9th. Post-discharge, the patient again developed worsening of the skin lesions and had again fever spikes, and her routine urine showed over there pus cells, and there was procal was 100 with a query of pyelonephritis was done at the outset, and she was referred from then to SGPGI. This was the investigations before the coming to the SGPGI, that is at the hospital where she was admitted, where eosinophil counts were high in the initial reports, and her procal was, then the last admission was 100 nanograms per ml. Course in the SGPGI, she was admitted in SGPGI on 16th of January 2024, where she had a BP of 120/80, SpO2 95%, and she had bilateral mild pitting edema with erythroderma with diffuse edematous macular skin rash involving till palms and soles with pallor and icterus present with no lymphadenopathy. Respiratory system had bilateral coarse crepitations, and this was the, at presentation, the picture of the lady. And these were the second picture of the lady which was taken with consent. Once we labeled her or thought of on the lines of DRESS, on the day 2 we started her on IVIG since she had a procal of 100. So the patient received IVIG at 2 grams per kg. Total 100 grams IVIG was given to the patient over 5 days. And we also added a broad spectrum antibiotics. Day 5 of IVIG, the lady became afebrile and the procal had come to 1.39 with the blood cultures were still awaited. 25 to 28, the fever spikes were still persistent, and we had shifted to 1 mg per kg steroids and topical emollients in the form of coconut oil, and antibacterial ointments were used for the lesions. The subsequent reports of the patient were on 28, she showed the TLC count was 12,900 and eosinophil count of 15, and the blood culture that was awaited coagulase negative staph aureus, and for that the antibiotics had to be changed. She had some breathlessness, and for that CT thorax was done, which was suggestive of bilateral mild pleural effusion with hypoalbuminemia. So the patient was started on IV albumin along with Lasix with a negative balance as target. The skin lesions started to desquamate from the hands and the trunks, and the antibiotics were continued. This was in February 5 to 10 February. The patient developed new onset fever and also had neutropenia. The neutropenia was with an ANC count lowest was 85 with a TLC count of 1700. And considering a background of neutropenia, we started on GCSF single shot 300 micrograms, and we gave 10 shots of folinic acid. And we also worked up her for mass, but the mass workup was negative. And after this, we shifted her to DEXA 10 mg per meter square. In these reports, we did an ANCA which was negative. We did CMV PCR which was negative. Her ASTLT, which was initially raised, had come to normal. And the DLC eosinophil count was also 15% with a normal platelet counts. And from 9 to 12th, her ASTLT again was normalized, and serum creatinine was 1.1 to 1.3. There was no new onset of fever, and antibiotics and dexamethasone was continued, and the counts had recovered by this time. 13 to 18th of February, she had a new onset gross hematuria, but there was no fever spikes. The skin's desquamation had already settled around 70%. Considering a fungal background, we started empirically on voriconazole, and we also sent urine microscopy for fungal microscopy, which was 3 times negative, and a urine culture, which is sterile, for 3 times. Ultrasound QB was done, which was no evidence of pyelonephritis, and ANCA was done, which was negative. She had a new onset transaminitis following voriconazole, and we had attributed the transaminitis to the voriconazole, so we had stopped the voriconazole on day 5, following which her ASTLT, which was elevated, again had settled down on day 3. On 19th, it was 38/66 with a neutrophilic leukocytosis and a normal eosinophil counts and a normal creat counts. 1 week prior to discharge, there was no fever spikes, the counts had recovered, there was no transaminitis, there was no AKI. The only thing was the persistent hematuria was the thing which remained unsolved. Since her creatinine has come to the normal, so we planned for a CCT KUB. And a CCT KUB was done, which was shown that the kidneys appear swollen with reduced parenchymal enhancement, and there was a possibility of pyelonephritis. But again, this could be also a part of the DRESS syndrome, that hematuria as a part of DRESS syndrome. At the time of discharge, the IV DEXA was changed to oral, and 95% of the skin had desquamated, and there was no fever spikes with a normal counts, and she was finally discharged and asked to follow up in OPD if hematuria persisted. She was finally discharged on 23rd of February 2024, and this was the time at the discharge where all the lesions had desquamated, and the questions are this.
We can take questions maybe from the audience. If there are any doubts during the course of illness, if you have any questions. I'll add a few. So what is the interpretation of procalcitonin in setting of stress, and how much of IV antibiotics, use of voriconazole is justified?
I don't know about DRESS, but I've seen one patient with delayed anaphylaxis due to omalizumab who had sky-high procal and was being pumped full of antibiotics because of that. So that's falsely elevated in delayed anaphylaxis. I'm not sure about DRESS. I don't think it has been studied in DRESS.
Because I think rarity of the disease, though we have seen here different cutoffs for procal in adult onset still disease, vasculitis, we take a higher, mast, we take a higher cutoff. So, and use of IVIG in stress.
I think you managed it very well. Obviously, she has improved. But the only thing possibly in light of what's been seen in last 6 months and with that publication of the Nature paper, I would go to tofacitinib straight away if you suspect DRESS. IVIG is still very dubious, and it doesn't appear in any guidelines after the publication of that case series showing increased mortality. But there is very good mice evidence and N equals 5 experience in that case series that was published in Nature about the use of tofacitinib. So, and it is so cheap and easily available. So that's the only thing. Voriconazole, that's what we were discussing as well, that possibly it was very soft, the indication for voriconazole.
The patient had become infebrile, just that the neutropenia, for neutropenia, that it was empirically added.
There is neutropenia and then hematuria, so probably renal involvement, fungal or something.
Yeah, because the other thing about DRESS is never put in lots of stuff. You have to try to reduce as much as possible.
Because it can get a little confusing. Exactly.
Yeah, actually we attributed to levoflox at that time.
Yeah, Avinash, the reason why we use IVIG was the lady has got 100% body surface area involved. And look at the face that you have seen, the whole body was like that. It was even very difficult to look at the lady. So obviously there are all portals open to the environment where she is likely to, it was like 100% burn. The very fact that she survived in itself is a miracle, because 100% burn will never survive. So we wanted to give immunosuppression, and I think for all the postgraduates, if you are in a dilemma in a setting of sepsis or severe sepsis, go for IVIG. Whether there is evidence, we were not treating DRESS with IVIG. Had she been only DRESS syndrome, we would have only given methylprednisolone and maybe tacrolimus at the best. But since she has presented with severe sepsis with all the portals open, there was a strong suspicion for sepsis. That is why we use IVIG. Voriconazole we started empirically because she was neutropenic for 3 to 4 days and the fever spikes were continuing. Imagine a patient having an absolute neutrophil count of 85. So we thought maybe it is good to give, because in the hindsight we may have regretted why we didn't give antifungal to the lady. But since she developed transaminitis and the cultures came out to be negative, so it was discontinued.
I think probably the side you wrongly mentioned,
Yeah, so see, again, if you are neutropenic, don't wait for fever for the postgraduates, because even your pulse rate or your heart rate or your respiratory rate can tell you the patient is in severe sepsis.
Just a few questions on drug hypersensitivity, sir. So how do you test drug hypersensitivity to a drug? What are the absolute contraindications that when a drug is causing this severe a reaction, you wouldn't ever test? And there are certain issues when a patient has had a hypersensitivity to an injectable agent. So for example, I recently had a patient who had a reaction to injectable methotrexate, a hypersensitivity reaction. Now you don't know whether this is to the excipient that is there in the solution or to the drug itself. Now, would you ever try testing the oral drug? What dose would you try if you want to try, and how would you go about it? Yeah.
So this is hypersensitivity reaction is anaphylaxis?
No, it wasn't anaphylaxis, but a severe, sort of an anaphylaxis reaction.
Okay, then it can be excipient. You're absolutely right with injectables, because you don't see much anaphylaxis. Like I've read about 1 or 2 cases only. So then it could be excipient. So you would want to look at that list first. More importantly, lots of these excipients, which are in all of our medicines, have a very common thing. So you possibly could rule out half of them by just finding out what else has she received in the parenteral format and has tolerated. So you make a list and then make out what other injections she's received in 6 months and if they were okay. If in absence of that, you definitely can do just simple skin prick testing with the injection itself. But with drug allergy testing, skin prick is not good enough. It has to be intradermal, right? And at the top of my head, I can't tell you what are the concentrations reported in the literature. You'll have to look for it, intradermal thing, but you could look for it. In terms of what patients you could check, possibly we are in an academic environment, so you can do this in your lab. So obviously, with that severe, there's no way you are going anywhere with a sulfa within 5 kilometers of that patient. But what you can do is, you can do an in vitro testing. So you can do ELISpot. So you just need 10 million PBCs and 6 concentrations of sulfasalazine or ICMA positive control. Or we have ELISpot facilities अपने lab में यहाँ पे. अच्छा काउंटिंग वाला लेकिन PhD वाले हैं ना सर PhD वाले कब काम आएंगे इसको मैन्युअली काउंट कराओ PhD क्यों करते हो यार फिर अपने टाइम पे तो PhD यार वो लोग काउंट करते थे ऑस्ट्रेलिया में तो हमको ही करना पड़ता है मैम स्टूडेंट्स हमारे बाप होते हैं But yeah, it will be good. Like if you're planning to write it up, ELISpot karke, it will be good.
So I think Abir sir was also wanting to, on the drug testing, would you really do the drug testing for sulfasalazine now?
No, we have taken the dermatologist approach to severe drug allergies, and we looked at it. There was a thesis done when I was in PGI, and we took patients. Admittedly, there were only very few patients with DRESS. We had mainly patients with toxic epidermal necrolysis and SJS major. Antituberculous drugs, anti-seizure drugs, etc. And we did patch testing to see whether we could find some way of, predicting. And it was good. We had patients who had reacted to it and we had a control group. So it was helpful in about 40% of them. They were reacting on an epicutaneous patch test to something that they had reacted earlier. And we could find out some negative controls also, because many times in India, that we never get a drug history. The patient lands up with TEN or DRESS, they have not a single parchi, not a tablet in their hand, nobody knows what they took. So in that kind of scenario, we are trying to see whether we can find out something. We know the common top 10 culprits, top 10 drugs that can cause these kind of reactions, we know epidemiologically. So we were testing with those patch test concentrations, but they are not standardized. So 1%, 5%, 10%, you take 3-4 concentrations. So it can be done. It was a crude approach, but it worked in a few patients. That's how far we got with it.
Sir, but for sulfasalazine, patch testing is generally negative, as Anupam sir told. So how would it help in such cases?
Yeah.
the predictive value is not very good. It was in this series that I'm talking about, it was mainly antibiotics, ATT drugs, and carbamazepine, phenobarb, and phenytoin, which were our drugs that we were looking at.
Okay.
By using sulfasalazine. You can this time. I hope it should come.
I'm just being kind to SGPGI because this is my alma mater and I've studied from here. We've done that, tried that 4 years. Didn't work. 4 years, ma'am. Tabhi that one that I was telling, the HLA-DR 38 and 69 combination, that was part of that project. Just doesn't work. Now, with the new kits coming of antigen-specifically stimulated T cells, the new BD kit is coming, maybe that we can try. But non-specifically, just putting with them and looking at upregulation just didn't work.
I think for most of the known culprits, when we are starting those drugs and we counsel the patients that these drugs can cause 1 in 10,000 very serious allergy, and we counsel them to wait for first 10-15 days and watch for any allergy. And the moment it starts, if they stop it very early, probably many a times we are able to prevent such serious reactions. It progresses to this grade only if after the onset of reaction they keep on still taking it for 3-4 more days. So
it's a question of if you catch it and you start treatment earlier.
yes, that is. But if we like sulfasalazine, sir, if we like counsel them, we start at a lower dose, and the moment you see any kind of reaction, there can be a lot of false alarms also, but sometimes we can prevent.
Doesn't really have to.
Yeah, I mean, what's the difference between a 250 milligram versus a 500 milligram?
Not much.
500 once a day, and then if at 10 days they say a drug rash, then the patient immediately comes, you withdraw the drug and institute steroids and whatever you have to give. And that is the time you can probably abrogate.
Yes, that is why. But if they are not told that such thing can happen.
And the other thing is, I think we immunologists, rheumatologists in this country are not getting it right. We need to learn from orthopedic surgeons. You have to prescribe prednisolone, methotrexate, hydroxychloroquine, sulfasalazine, and tofacitinib. And you won't get any reactions.
Because Tofa is just clear up. Tofa is very like prophylactic.
No dressing or undressing.
When there is a reaction to a drug, what advice should we give to the patient? They have to avoid that drug and also all the other chemically similar compounds as well. Like, it's very difficult to tell the patients this.
So again, if you have to first define what is the reaction though. So the molecular mimicry, the cross-sensitization as the cross-reactivity with different antigenically similar, immunologically makes sense only for antibody-mediated reactions because antibodies bind to your soluble protein which is circulating around, right? So for IgE-mediated, yes, beta-lactams, there is, we know, although that is now being refuted as, penicillin allergy, the cross-reactive cephalosporin allergy, to the first degree is only about 5.5%. And to a third generation cephalosporin is 1% of all your penicillin anaphylaxis. So that kind of cross-reactivity theory or explanations on immunological basis, from what we know of, immunology stands true only for IgE-mediated reactions. No one knows anything about the cross-reactivity of the T-cell mediated reactions. So for your SJSs and TENs and everything, because it's antigens are processed by the antigen-presenting cells. That's why it takes 2 weeks, right? And then they are presented, then you develop a memory response. So there, the chemical structure of that innate molecule which was first ingested is possibly not important. The HLA association might be as to how you are going to process it, but not that. So that is more important than telling them cross-reactivity. And that is why when you see someone, like you see lots of, I'm saying dermatologists, sir, you are excluded. Dermatologists, when we get a patient from SJS, this is Indian setting, they have this list of like 50 things that you have to avoid because you had SJS syndrome to phenytoin. And I said, no, nothing is known about this. You had it to phenytoin, just avoid phenytoin. You can still continue having lots of other things. But this is a very common practice, by the way, that I have seen from dermatology. So cross-reactivity with T cells, don't know. Cross-reactivity with IgE-mediated, possibly yes.
Specifically with phenytoin, as well, in dermatology literature, we give a standard advice to avoid 2-bore, barbiturates, and carbamazepine. Up to 30 to 40% cross-reactivity is there because of common, those aryl hydrocarbon rings or whatever they have. I'm forgetting the exact names. Yeah, aromatic rings. So these three, yes. Otherwise, it's very difficult to predict. But in anti-seizure drugs, this is at least standard teaching in dermatology. For these three, any one you react to, don't try the other two. And of course, the safest we used to say is valproate. And of course, we have several others available now. So lamotrigine is a bad one, not a very great one, but yeah.
Vote of thanks.
I actually write better than I speak, so I'd written a vote of thanks in the intermittent period before I could come to you. I'm extremely overwhelmed with the response to this conclave, and I'll start with a share in my own style that आज बादलों ने फिर साजिश की थी, जहाँ मेरा घर था वहीं बारिश की थी. अगर फलक को जिद है बिजलियाँ गिराने की, तो हमें भी जिद है वहीं आशिया बनाने की. So thank you everyone for being here, and today thank you for the unwavering support for making the conclave a success. I'd like to thank Amita ma'am for being the head of the department and providing us mentorship, for involving me in the previous conference so I could understand what is to be done and what is not to be done while you hold a conference, for being supportive and coming every day and asking Kunal aaj kuch kaam hai kya. Thank you ma'am so much for all the support. Thank you Vaklu sir. When I think Pravin sir is the reason why we have this conference. Over the last I think 6-7 months have been pressuring Pravin sir to एक बार आ जाओ कुछ allergy हमें सिखा के जाओ. I think I've been telling ma'am for the last 9 or 10 months कि एक कुछ allergy की conference करनी है. We need to understand, learn, and make ourselves better in the immunological aspects of allergy. And sir said ठीक है 2 महीने में आ रहा हूँ कर लेते हैं कुछ ऐसे. And then planning a conference in 2 months and ensuring that it was done to the till I think I owe everything of this conference to Vaklu sir. When I went to Vaklu sir ki conference karni hai, and we might not have enough money to do it in the beginning, sir ke tu conference kar, paise main de dunga. So this is the amount of support I think you require when you're doing a conference. To Vikas sir, for all the support and all the guidance that I've received from him during the entire conference. His expertise, his insight, his actually greatly, his humane aspects of a conference have greatly helped in the handling of the conference. To Able sir for financially educating me regarding कि क्या SAC codes भरने हैं form में और किससे कैसे पैसे लेने हैं. And today is also his birthday, so wishing Able sir a very happy birthday. To my colleagues and fellows who are here, Digvijay, Prasanna, Juhi, Kriti, Rudra, Anu, Upen and Rajat, I think you guys have been godsend to me to ensure that this conference was done to the till. I have got a great team who have always done everything unquestionably. कभी किसी ने कुछ कहा नहीं अगर कुछ काम करने के लिए भी बोला है तो. And to our newly formed assistant professors, Kishan, Darpan, Abhishek and Abhilash, we got their enthusiasm, their fresh energy that added great value to this conference. I extend all my gratitude to all the DM students and PhD students. We had a PhD student who was manning the registration desk throughout this conference. Without them, this couldn't have been possible. Every member of the Department of Clinical Immunology and Rheumatology at SGPGI, Your participation and encouragement have made this event truly memorable. I'd like to express a sincere thanks to our pharma supporters, IPCA, Laranon, Hetero, Sun, Abbott, Overseas, Zydus, RPG, and Cipla. Your support and collaboration have been essential in making this conference a reality. To all the esteemed faculty members who have ensured that we had great science throughout the two-day discussion, and to all the participants who asked n number of questions, all those who have attended this conference, predominantly most of them have been in this hall and not outside, and this tells the amount of interest and the academic zeal that all our participants had. We had vibrant and interactive interactions, and it is important to recognize that allergy is a part of immunology spectrum disorder, and this conclave was an humble attempt at understanding allergy better. I sincerely hope that all of you are taking away a few new points from this conclave, and this will help you in the pursuit of advancing in the field of immunology and allergy. The purpose of this conference was just to imbibe that spark among you, that if anyone of you further wants to learn more about allergy in the scheme of immunology, you're more than Pravin sir is starting a fellowship, I think, under him going on, and if you want to learn allergy more, I think we've given you a platform. You can contact Dr. Nitin at VPCI or Pravin sir at Australia if you want to roam around and see Australia, how it is with them. And once again, I thank all of you. I might have missed out a few important people to thank. I'm sorry for that. I think this is quite an overwhelming feeling to do a conference. This is the first time I'm organizing a conference, and I'm too young to do this great or this larger magnanimous entity. And I think my emotions tell it all. And thank you for all your presence, support, and contribution to make this event an overwhelming success. We've had significant participations from across the country, both online and offline. And the last quote I would want to say that for all those who want to sing, we'll always find a song. So keep trying to sing. Thank you.
Kunal has been at it for the last 2 months, and I think he deserves one big clap from all of us. He's really worked very, very hard.
Marriages, once they start, they will finish. So don't worry at all. So all well done, excellent.
I did put forward a question actually, which I'm still to get answered.
For all the in-person candidates who are not the part of our WhatsApp group, we have a WhatsApp group which we have put regular updates of all the lecture topics. Jo bhi lecture ho rahe the, we have summarized one critical review that is there for the topic. You can go back after attending the conference also to read it back. You will understand all these topics better and understand the crux of it better. So if there's one way you can pay gratitude to the conference, please go back and read it well. So that would be the best thank that we can get from the conference.
Detoxification for 2 days.
Yeah.